It is too short to do justice to TCD. It's a full 2-day workshop actually, but we'll leave it to the experts to try to give you at least a taster session, and you can later on, those who are interested, can dwell into the details and can enroll in one of the workshops the organizers hold. So let me invite the first speaker. Can we have the CV of the first speaker, please? So Dr. Amit Batra. So he's DM neurology and has is associated with Max Balaji and Max Vaishali Hospital. And his major achievements are he is certified neurosonologist by the American Society of Neuroimaging and is recipient of various awards. So I would not take much time and ask him to take the dais where he would be talking on basics of ultrasound.
Good morning, everybody, and thanks, sir, for the kind introduction. As he rightly said, 1 hour is too short a time to do justice to transcranial Doppler, but we'll try to wind up, at least give you some glimpse of what TCD is, its basics, and also the clinical applications. So before we dwell into TCD, we should all know what is ultrasound and what is Doppler, right? So basically, ultrasound is a mechanical longitudinal pressure wave with a frequency which exceeds the upper limit of human hearing. So human hearing ranges between, it is 20 to 20,000 hertz. So anything which is above 20,000 hertz is ultrasound, right? And the medical ultrasound which we use ranges between 2 megahertz to 16 megahertz. So it is very important to know that the medical ultrasound is 2 megahertz to 16 megahertz. The frequency of the probe may vary depending on what modality you are using. So how is ultrasound produced? So it is produced when you pass an alternating current through a scanner head on your ultrasound machine, which you all must have seen. And this is an alternating current which passes through a definite set of crystals, what we know as the piezoelectric crystals. And piezo means pressure. So once you pass a alternating current through these piezoelectric crystals in the head of the ultrasound probe, this converts this. So this converts this alternating current into a pressure wave, right? And this pressure wave then hits the target, which may be anything depending on what you are trying to scan. But for vascular ultrasound, the targets are the moving red blood cells. So these ultrasound pulses are transmitted for nearly 1% of the time, and these hit the RBCs and again return to the scan head, where this converts the pressure wave back into an electrical signal and into a mechanical ultrasound wave. So these electrical signals are then processed by your ultrasound system, which then gives you the waveform as you see on the ultrasound machine. And the frequency of these waves, what you get, also depends on the composition of the piezoelectric crystals. So whether it is a 2 megahertz probe or it is a 15 megahertz probe, and also on the electrical current which you are using to produce these signals. So you should also be familiar with the concept of pulse wave versus the continuous wave output. So pulse wave echo or pulse ultrasound is the one which we use for practical purposes in all our systems. Here, the signal generation happens for only 1% of the entire signal. So the scan head is only producing signals for 1%, and for the rest, 99% of the time, it is sitting back and receiving the echoes from the target, which is the red blood cells, as I've said. So there will be on times which are very short, and there will be off time where it is just receiving those signals back. And the time of signal return is proportional to the distance travel. That's why we say that your TCD is depth discriminant. So you can make out from what depth these signals are coming back from. So what is Doppler ultrasound? So Doppler ultrasound is basically ultrasound which uses the principle of Doppler. So here it depends on the Doppler shift frequency. So there is a difference of the frequency between the emitting waves and the waves which you receive back, right? So this difference is what we call as the Doppler shift frequency. And this Doppler shift frequency depends on the speed of the moving red blood cells. And because, as we know, there is a laminar flow in all the blood vessels, and here the Doppler wave which you get is a mixture of the Doppler shift frequency which you receive from each of these RBCs, which is billions of these RBCs put together form a Doppler spectrum. So what information do you get from the Doppler? So you can first confirm that there is a flow. So you can confirm the presence of flow, you can confirm the direction of flow, you can confirm the character of the flow, right? Another concept which you all should be aware is the concept of a M mode, right? Before the earlier TCD machines which were introduced by Rune Asler, so they had a single gate channel, right? So here you could image only, or you could obtain the Doppler signals from a very short segment of the blood vessels. But then Mark Moring, he was the one who revolutionized this concept and he introduced the M mode. So here you have 33 overlapping gates, and because of this, now it is not a single gate, it is a multi-gate channel, and you can, because of this multi-gating, the Doppler signals which you receive are from a longer length of the vessel. That's why by using the M mode, you are able to image at least around 30 to 40 millimeter of these blood vessels, right from the bifurcation or from the midline, which is around at 70 millimeters, up to the distal vessels or distal branches of the MCA, which is around 35. So because of the M mode, you are able to image the longer length of this vessel. You can see the entire MCA, you can see the entire bifurcation, and you are also able to gauge where you are just based on seeing the M mode, right? Otherwise, because you cannot see the vessel wall or you cannot see the actual vessel when you are doing the TCD, the M mode helps you to navigate through and you know where you are actually in the circle of Willis. So this is what your TCD screen would look like. The above one is the M mode, and then below is the Doppler spectrum. This principle of Spencer's curve is very important in understanding, because you all keep on hearing the concept of a hemodynamically significant stenosis. So this is the basis where we deducted, or we came to this concept of a 70% being a hemodynamically significant stenosis. So if you see here, do we have a pointer? So this Spencer curve shows you the relationship between the degree of stenosis or the degree of diameter reduction and the volume of the flow and also the flow velocity. So if you see, till you reach a degree of stenosis of nearly 70%, the flow volume keeps on increasing, right? So even if you are at a 70% stenosis, the flow volume keeps on increasing, and that the flow velocities keep on increasing, and that compensates for the volume of flow. So till you are at a 70%, your velocities keep on increasing, and this compensates, and your flow volume does not get affected. So that's why we say till 70% it is not hemodynamically significant. But once you cross this figure of 70%, the increase in velocity still keeps happening, but that cannot compensate, and your flow volume begins to go down till you reach a stenosis of nearly 95%, and beyond 95%, even the flow velocities cannot increase further, and flow volume keeps on falling till you reach a near occlusion or a near complete blockade of your flow. So 70% and below is hemodynamically insignificant, and above that becomes hemodynamically significant stenosis. So this Spencer's curve you should always remember, because that is how you are able to decipher your TCD readings. So what are the Doppler principles we should all know? One is, higher the frequency, more is the attenuation in the tissue. And higher the frequency, better is the resolution, right? So that's why when you're doing a carotid probe, your probe frequency is close to 12 to 14 megahertz. Your frequency is high, but your resolution is better. You are able to see the vessel wall, but because its penetration is very poor, you can only see superficial structures. But once you are trying to do a transcranial Doppler, you have a thick bone here, so your probe has to be, it should be able to penetrate through that skull and reach the circle of Willis. So the TCD probe which you use is a low frequency probe, that's a 2 megahertz probe, where the resolution is very poor because your frequency is low. So here you will not be able to see the vessel wall, but you will be able to penetrate the skull and reach the inner depths of the skull and reach the circle of Willis. So for carotid or your superficial structures, you use a higher frequency probe, and for transcranial Doppler, the probe used is a low frequency probe. That's a 2 megahertz standard probe. So coming to the TCD basically it's a non-invasive ultrasound where you use that machine to understand and to decipher and also to record the flow velocities in the intracranial vessels which are around the circle of Willis, and also to pick up the collaterals from the surface of the brain. So it is a non-invasive bedside method, and because it is so important for vascular neurologists, we call it the stethoscope of your brain. So TCD, as I said, we use a 2 megahertz probe, and you first need to localize your acoustic windows, and you then identify the vessel walls based on what depth you are working on, what is the flow direction, and also what is the spatial as well as the anatomical position. So this is your workstation, your probe as well as the circle of Willis. So we've got 3 windows to work on. One is the ophthalmic window, which is through the eye. Then you have a temporal window, which is just in front of a tragus. And then you have a occipital window. So this is a busy slide, but as you start doing TCD, you will be able to decipher this slide better. So you have to, one, look at what window you are working on, what is the depth of from where you are picking up those signals, and whether the flow is towards your probe or away from your probe. So there will be some vessels where the flow will be towards the probe and you will see a signal which is above the baseline, and there will be another vessel where the flow is away from the probe and you will get a signal which is away from the baseline. So based on your window which you are working on, based on the depth you are picking up those signals, based on the flow characteristics, velocities, as well as the direction of flow, whether towards or away from the probe, you can identify which vessel you are working on. So through the ophthalmic window, you are able to see the ophthalmic artery as well as the carotid siphon. Through the temporal window, you are able to pick up the entire length of the ipsilateral MCA. You are able to pick up the ACS, you are able to pick up the PCS, and you are also able to image the terminal ICS. And through your occipital windows, you are able to insonate both the vertebral arteries on either side and also the entire length of the basilar artery. So this is what your TCD screen looks like. As I've said, the M mode as well as the Doppler spectrum. And how to read these waveforms? So if you see this cycle which starts here, this is exactly where the heart pumps your blood, and this reaches the brain here. So this is the early systolic acceleration. So if you remember your physiology, this is exactly what your single cardiac cycle looks like. So this is the peak systole, this is the systolic deceleration where you have the diacritic notch. Here this is the end diastole, and what you calculate is the peak systolic velocities, the end diastolic velocities, and also the mean flow velocities. So as I said, you need to study the peak systolic velocities, the end diastolic velocities. Mean flow velocity is a derived component which is very important because all your criteria for stenosis, for vasospasms are based on the mean flow velocities. Then you also should know the pulsatility index, which is the resistance to your flow. So if the resistance to flow is high, as in cases of stenosis or vasospasm, your PI values tend to go up. And these are all derived values. The formulas you will obviously learn in due course of time. So also another entity which you should all be aware of is the TB scoring, which is the thrombolysis in brain ischemia. So this is grades from 0 to TB4, which is absent signal to minimal signals. Then you have a blunted waveform to a dampened waveform and stenotic velocities, and ultimately you have a normal waveform. So many times when you start doing your TCD, you might be getting an absent flow, and as your thrombolysis progresses, your signals may become better to a dampened flow, and then ultimately you might be able to reach a normal flow. Thank you so much. I think I didn't have an option to, I had to only rush through these slides. Thank you.
So, thank you, sir, for the lucid presentation. I think I know you had to rush through your presentation, but because of scarcity of time. So, those ever who are interested can get hold of Dr. Amit later on. So let me introduce my next speaker, Dr. Arvind Sharma. Dr. Arvind Sharma is the head of neurology and stroke program at Zydus Hospital. He is also associated with NHL Hospital, Ahmedabad, where he is the assistant professor in neurology. He has a vast experience in neurology, and he has obviously being an eminent teacher. He has a Mackenzie's Award from American Society of Neuroimaging and Sonology. So, Professor, welcome, sir.
Thank you. Thank you for the kind introduction. Thank you. And may I have the slides, please? Uh, uh, those who want to attend the workshop, as been told by the chair, can do in June, 17 and 18 June at Vijayawada. We have a midterm neurosonology conference. The main will be in Chandigarh in December, the neurosonology. And September, Saurabh is doing his national neurocritical one. So you have three options for the demonstration of the TCD. That is very important, and very good basics which has been demonstrated in a rush, I agree, by Dr. Amit Batra. I will not go into the basics now because he has demonstrated very well, but to learn TCD, the chair has said very correctly that you need 2 days for the workshop, live workshop. So these are the indication where you use transcranial Doppler. The most at my center, because having a high cardiac center, we use a lot of emboli monitoring and to know the mechanism of stroke, that is PFO. So I'll talk about that. We do for several vasospasm in SAH, but Dr. Saurabh will discuss about that. So this is already done. We'll not talk about this. I'll not go into, because Amit has already done the Spencer curve. We'll directly go to the emboli monitoring to detect, quantify, and localize the embolization in a real time. What are MES, microembolic signal? They are asymptomatic. Since the size of the particle producing them is usually comparable to even smaller than the diameter of the brain capillaries. There is physician who asks, when you do emboli monitoring or when you do a PFO, you push air, saline, so you are inducing stroke or not. So it is not like this. So what you are identifying when you are doing emboli monitoring, you want to identify the proximal source, like heart chamber, septum, aortic arch, which is very common in cryptogenic stroke, where it's arch of aorta, atheromas, AF, monitoring cardiac and cardiac surgeries. So you do 40 minutes minimum of the emboli monitoring in such patients. So how you complement this modality? So it is not that you have a TCD, so you have everything in your stroke armamentarium. You have cath lab, you have DSA, you have CT angio, you have MR angio, and you have TCD machine with you where you can live demonstrate the emboli. So you can see the critical stenosis here, and you can see on carotid Doppler how the stenosis is, and down, if I can point my arrow, yeah, down you can see the emboli on the transcranial Doppler. So it is having all the three modalities here with you. They are random in occurrence, they are brief duration, high intensity. You can listen the chirp sound also, primary unidirectional, and audible component like a chirp or a pop. Video is there. If it works, you will able to hear that. This is what the emboli look like, and this is what the frame is. It looks too tedious when I started long back putting the frame. I thought it will take minutes to do it, but once you start doing it, it is seconds you can put the frame. So these are the emboli. And this is another one where there is an intraplaque hemorrhage is there. You can see the critical stenosis and you see the emboli. That is the DSA. And subsequently, you can detect the MES. And it is a very useful parameter in diagnosing the patient and prognosticate the patient, where you can modify. If patient is on antiplatelets, you want to add another one. Even on single antiplatelets, some patients with cardioembolic stroke, if they are having a stroke, you have to add anticoagulation in such patients. So this is what you see on the machine. This is for what the machine is look like. I think we'll show you on machine about the insonation depth, type, size, ultrasound device, all these things. And this is the study which was done by one of the very prominent from Hong Kong, Lawrence Wong, who used to do Mark Hughes and Lawrence Wong, they did a lot of work on emboli monitoring by using the TCD. Here they used clopidogrel and aspirin. Now the point and chance has shown that, but during that time they have shown with the TCD that a double antiplatelet in first 7 days of the minor strokes with the intracranial stenosis makes a hell of a difference in emboli monitoring. So they definitely showed that 3.8% of the dual therapy MES were positive, and in monotherapy it was 72.7%. It was of the 100 patient study, so larger number of study is needed. Expert hand things look easy because they are doing it regularly. Once you start doing it, you become an expert. This is the paper which I mentioned. You can download from the Annals Indian Academy of Neurology, where all the advanced applications are there. So we go to the second point, that is PFO. PFO is the commonest source. If 5 people are sitting here, one may have the PFO. This is what the incidence is. And not every PFO has to be closed, and they are the mechanism of stroke. So the mechanism of stroke as a stroke neurologist is very important. One of them is PFO for the young stroke, where you do the procoagulant workup also. So when you have an acute stroke and you want to do a TEE, it is very difficult. It is gold standard. It is very difficult to do a Valsalva by putting a tube in the mouth. So 56% of the cryptogenic stroke less than 55 years have PFO. So TEE is still a gold standard, but you know it is poorly tolerated, required sedation, limits patient ability to do Valsalva maneuver and put in the lateral position, left lateral position during the procedure. I'll show you one case. 33-year-old male came to our ER with GCS of 8, afebrile. The resident made the differential diagnosis, as you can see, post-ictal state, non-convulsive status, posterior circulation stroke has to be ruled out. We did a scan as it was an old stroke. It was bilateral thalamic involvement was there. So what is the role of TCD in such cases? It was the artery of Percheron infarction in young. And we did the TCD in this patient. So here, as Dr. Amit has already told about the spectral window, and you will hear the voice of a chirp when there are very few emboli. But when the PFO is large, this is what you see. It is known as curtain. And ultimately, the procoagulant workup was also done, and this patient was closed and still come for the follow-up. So they are in 25% of cases. TEE is gold standard, but if you have a TCD, it is a very non-invasive way to push it. How you do it? You have to have an intravenous access of 18 gauge needle. At least one MCA should be, if you put a frame, it is good. If one NCA should be insulated, 9 ml of the isotonic saline with 1 ml of air mixed with the 3-way stopcock with the Lurlock syringe. And you do with the rest, and when second you do with the Valsalva maneuver, contrast injected 5 seconds before and it is done once. And this is another video where you see the spectral window, and you can see how we are mixing it, and we are agitating that 9 ml saline with 0.1 ml. So here you will hear the chirp. So this is what the PFO positive. We'll go to the second. Here you can see the 2D echo also. When you push the agitated saline, the right side of the chamber of the heart filled with that. You see it is filled now. And you will, if the right to left shunt is present, you will hear the pop and the chirp very clearly. This is what you are. So they have a grading for that. So position matters, we agree. So there is a grading according to the ICC, that is 0, 1 to 10. Greater than 10 is shower. 3 and 4 are important. Curtain I showed in the patient of that young patient. Curtain and more than 10 are important. Another grade is Spencer grade, where 3rd, 4th, 5th are important if they are attributing to the mechanism of stroke. Not every PFO has to be closed. I'll not go into the preoperative assessment because Dr. Saurabh is going to show you the VMR, but it makes a hell of a difference when there is a asymptomatic stenosis and patient is due for CABG, how you can tell your cardiothoracic surgeon that you have not to touch carotid or you touch the carotid at that time. So you do a VMR test, very simple test, the BHI test, breath holding index, where you can show that the cerebrovascular reserves are not preserved. So here I will finish. So there is one more sickle cell anemia, which is a whole half-day session where we have done a project pre-COVID. We are going to start it again at Chhattisgarh, where the sickle cell is very common. At our Gujarat, Bardoli, we are doing the regular screening of the children for sickle cell anemia, and you make a hell of a difference in prognosis of such patients. Thank you very much. Thank you for the patient listening.
So let me have the honor to invite the last speaker in this session, Dr. Saurabh Anand, a very dear friend, Chief of Neurocritical Care at Artemis Hospital, has various accolades, is involved in a lot of academic activity with the SNAC and Neurocritical Care Society. Dr. Saurabh is going to speak on the role of TCD in neurocritical care. Dr. Saurabh.
The presentation is not visible. Thank you. So there are 31, good morning everyone. There are 31 live cases which are going to be happening today. But behind those every cases, there is an anesthetist and an intensivist who is looking after those cases. Dr. Harsh's team might be looking at Menanta, my team right now may be looking at Artemis, the live cases which you are going to be demonstrated. So nothing bad happens to them, depends on us as well. It's not only the interventions, it's just you are going to coil the aneurysm or do a carotid stenting, but post-operatively reperfusion bleeds doesn't happen, post-operatively vasospasm prediction, all depends on how good your neurointensive care team is. So transcranial Doppler is the most important tool in your hand. I will say most important tool in the hand of a neurointensivist. It's like, I will say, a microscope in the hand of a good neurosurgeon or maybe an EMG lab for a neurologist. So it is so important that if you go ahead and start doing transcranial Doppler, you know how important it is. I am going to show you some cases. Let's start with SAH. So in SAH, what you can do, you can triage your resources. What I mean by triage is, on a third or a fourth day, you know that you are going to insunate MCA velocity or an ACA velocity. It comes out to be normal. You know that it's a grade 3 or a grade 4 bleed. The vasospasm might going to happen on a 5th or 6th day. You send the patient to ward. Okay, but you're daily doing your repeat TCDs every day. So the day the velocity starts rising, you might shift the patient back to your HD or critical care unit. So you save 3 or 4 days of patient's charges as well. You don't keep unnecessarily the patient in ICU. And if the velocities are coming normal, you can shift back the patient directly to the ICU, to the ward. Identifying the spasm is most important because time is brain. We almost tell in every stroke whether it's vasospasm. So in vasospasm, what is happening? A particular territory has not been receiving the blood. So it's a kind of stroke which is going to happen. So we need to prevent that stroke. We need to prevent and predict it so that it should not happen. So if your patient has been beautifully coiled by a neurointerventionist and your patient is walking paraplegic, it's somewhere down the line we have missed the bus. So that is the importance of a transcranial Doppler. If you are see, a good instrument in a hand of a good person is important. So I don't believe in observer variability at all. There is no observer variability. If you are a good driver, the chances of accidents are very less. So it depends on you how you do your study. So if you look at, I'll directly go to the cases. So if you look at this case, this is you can have a pointer, please. Yeah, it's here. Okay, so you look at this, there is a bifrontal hematoma. There was an ACOM aneurysm which was coiled by the neurointensivist or neurointerventionist. And if you look at those velocities, can I have the volume, please? Yeah, please increase the volume. So if you look at these videos, bilateral ACAs are having an increased velocities. So you know the bleed was in an ACA territory, the velocities are increasing in ACA. When I was doing an MCA also, this was the MCA velocity. Now if you look at this MCA velocity also, the velocities are in the range of 180 or 190. But if you look at the Lindgard ratio is at the level of 3. Now, what does that mean? Now, Lindgard ratio is the ratio of the MCA and the ipsilateral extracranial ICA. Now, if the Lindgard ratio is less than 3, that means there is a lot of hyperemia which is happening at that level. So, for vasospasm, I will say you just need to remember 4 numbers, 120, 3, 6 and 200. So, if the velocities are more than 200, Lindgard ratio more than 6, severe vasospasm. Velocities around 120, Lindgard ratio more than 3, then that means there is spasm, might be a mild spasm. But supposingly the velocities are touching 180, 200 and the Lindgard ratio is in the range of 3 to 4.5, that means lot of hyperemia is contributing to it. So in this particular patient, the ACA territories have increased velocity. We know that the hematoma was at the level of ACA territory, but at the same time, the middle cerebral artery is showing increased velocity also. So middle cerebral artery is actually supplying to the transcortical collaterals to that ACA territories. And that is why the patient is not developing symptom, but it is about to develop the symptoms maybe very soon. So this is the prediction. Okay, so when we did a TCD at that level, the bilateral ACA was at the spasm and intra-arterial dilatation was done. Now if you look at this video, this is an ACA velocity of another patient. You see ACA velocities are increasing. If you look at this, ACA velocities are in the range of 101. But you look at the same side MCA velocities, the velocities are normal, but the pulsatility index is around 1.6 or 1.7, might not be visible, but if you look at the diastolic flow is very less. You see, this is the diastolic flow. Diastolic flow is less, systolic flow is more. So that indicates that there is somewhere down the line increased resistance distally. So in this very territory, I know the blood was in the MCA territory. Chances of having a cerebral vasospasm might be more in that territory. We are seeing that the pulsatility index only in that particular vessel is increasing. That means the distal resistance is increasing. So there might be a distal spasm and this ACA velocity might be compensating for the same side transcortical collaterals. So this is how you are going to make the difference. I'm not telling you that simple velocities are increasing and this is how you are going to get the spasm. This has been very easy. You to insonate an MCA and see that the velocities are rising and you say that there is a spasm. But no, you have to see what is happening in other vessels also, whether they are involved in the collateral circulation or not, whether those increase is actually because of vasospasm or because of a hyperperfusion. So if you look at the protocol, what we have found in our unit is mild to moderate vasospasm in transcranial Doppler with focal neurological deficit. We shift the patient to DSA lab for chemical angioplasty or balloon angioplasty. But without focal neurological deficit, if there is a spasm of mild to moderate range only and there is no focal neurological deficit, we increase the blood pressure and add intravenous milrinone to it. But if there is a severe vasospasm in TCD, that means the Lindgard ratio is more than 6 and the MCA velocities are more than 200. And in ACA, the velocities are more than 120, or in a basilar, the velocities are more than 120. Then in that situation, we directly take the patient to the DSA lab. That means that something might bad happen very soon. It might happen in the night when your neurointerventionist might take some time to come from home and the patient might develop an infarct. So all your things, all your doings are for the prevention of that infarct. If the permanent damage has happened, the case will be gone. So if you look at this case, this is a very good case, 35-year-old man who came to us with subarachnoid hemorrhage, grade 2 and liver failure. We were getting this waveform on day 2. If you look at this waveform, this is an MC and AC territory waveform. You look at the pulsatility index, the pulsatility index is 1.3. Here also the pulsatility index is 1.3. So both in MC and ACA territory, the diastolic flow is very, very less. But this is happening on day 2. Now differential diagnosis includes that there might be a rise in intracranial pressure because of which it is happening. We have done a CT scan. There was no sign of raised intracranial pressure in the imaging. Then it might be happening because of a distal vasospasm. We have just done an angiography a day before to see what kind of aneurysm it is, because we need to coil that aneurysm day after. So we know that there is no angiographic vasospasm and it is also day 2 of that subarachnoid hemorrhage bleed. So chances of cerebral vasospasm was very low. And this can happen in hyperventilation. Hyperventilation, carbon dioxide will go down and there can be a decrease in the velocity and increase in pulsatility index, as we are going to show in the VMR also. So, but patient was talking normally to us, so no hyperventilation. So what was the reason? This patient was of liver failure. In liver failure, there is a hyperdynamic circulation. And because in a young patient of hyperdynamic circulation, there are distal vasoconstriction which is happening. So before ruling out and just going to a focal deficit in the brain, please rule out any systemic abnormality. If there is any problem in the heart, if the patient of aortic stenosis is there, definitely your velocities will be low. So before labeling it to carotid stenosis, you should label it to the aortic stenosis. So TCD velocities are low, so it is telling us that there is some obstruction right from the heart to the brain. Where it is not telling us. So you need to have your clinical acumen and other imagings also to know what is happening inside the brain. So if you look at what is the role of TCD in stroke, in acute stroke, assessment of recanalization following occlusion. So your neurointerventionist has done a beautiful mechanical thrombectomy, and you are in the in the ICU looking after the patient and doing transcranial Doppler. First thing, you know whether the velocities are increasing or not. If the velocities are increasing, you might be heading for a reperfusion bleed or an ICH. But if at the same time your velocities after achieving a TICI3 flow or a TIBI grading 5 flow, it starts decreasing to a TIBI grading 3 or TIBI grading 2, that means a reocclusion might be happening there. So this is how after mechanical thrombectomy you might help your neurointerventionist. Most important thing is the blood pressure. When you are doing a mechanical thrombectomy, what kind of blood pressure you want postoperatively in your patients? If you look at the transcranial Doppler, and if there is a 100% increase in transcranial Doppler velocity postoperatively, then you have to strictly control your blood pressure to maybe less than 120 or maybe 20 to 25% less than what it has been achieved. So we generally keep it below 140 once the recanalization has been achieved and a TK3 flow has been there. This is a case of a carotid stenosis. If you look at this patient, left ICA long segment tight stenosis is there. Right ICA was also included. So now this patient was posted for carotid stenting. So we did a pre-anesthetic checkup. There were some red flags which can point it out that this patient might go for a hyperperfusion bleed postoperatively. These red flags are diabetes, maybe both the vessels are blocked, left ICA is blocked, the right is also blocked. We did a VMR, impaired VMR. So vasomotor reactivity we did, which we do by holding a breath holding. We are going to show you in the demonstration this. So if you look at this waveform, this was the waveform of the left MCA of that particular patient in the left ICA was severely stenosed. So there is no sharp systolic upstroke. There is no pure diacrotic notch here. That means these velocities are low. If you look at this waveform, this is reaching late to the brain. That means there is some kind of an obstruction. So if you just wanted to come to this Marriott from your home and your highway is blocked, you are going to take a collateral route to reach here. So you will reach late to your destination. This is what happening to the vessels also. So if you are insonating here and there is a stenosis here, that means these vessels will dilate first. So the pulsatility index will be low, so that they are able to receive whatever minimal flow they are getting from the carotid. And second thing is those velocities will be very, very low. So this is a typical carotid stenotic waveform. We did a VMR through breath holding index, and the breath holding index was impaired less than 0.2. And if you look at this, the ophthalmic artery flow reversal was also there on the same side. So ophthalmic artery, the thing is from EC to ICA collateral was also involved in this. If you look at this, there is a flow reversal. The ophthalmic artery will be towards you. If you are doing a TCD study, the ophthalmic artery will be towards you. It will be red. But if you look at this, the ophthalmic artery is showing blue. So that means it is involved in the collateral circulation. Ophthalmic artery is a high resistance vessel. When it is involved in the collateral, that means it is supplying to the brain. That means it becomes a low resistance vessel, because all the vessels which are supplying the brain are low resistance vessels. So ophthalmic artery have two changes. One, it is an increased flow in it, decreased resistance, and the flow reversal is also there in it. Post-operatively also, this is the waveform which has become now after doing a carotid stenting. Now you need to look for a hyperperfusion bleed. If this TCD velocity from baseline has increased up to 100%, then you strictly go ahead and control the blood pressure post-operatively for next 48 to 72 hours very, very strictly. PFO has already been discussed. This is a stroke case. If you look at the left side MCA, there is no flow. If you look at the right side, there is a good flow. So this vessel was, if you look at the angiogram, this vessel was blocked and opened by the neurointerventionist. And if you look at the post-operative, the same flow has been achieved. The same flow has been achieved as of the right MCA. Here also, you look whether the velocities are increasing after reperfusion. This is a TIBI grade 5 flow, a full recanalization, or in angio what you see as a TICI 3 flow. So, blunted waveform, TIBI grade 2, then TIB grade 3, high resistance waveform, TIBI grade 4, stenotic waveform, okay. TIBI grade 5 I have already shown you. I think I should stop here because there are so many cases to show. Thank you. Just look at these are 3 waveforms of a brain dead patient. If you look at the first waveform, the ICP is increasing, the PI output. If you look at the second waveform, which is down here, it's only systolic peak, and the third is the reverberating waveform which is there. So the TCD is a very useful tool in confirming the brain death, but we don't say brain death by TCD. We always say cerebral circulatory arrest, whether it is complete cerebral circulatory arrest or an incomplete cerebral circulatory arrest. This is what we label in TCD. A complete cerebral circulatory arrest, you need to insulate both the MC and the basilar for 30 minutes, and the diastolic blood pressure should be 50 mm of Hg. So the diastolic flow is going from heart to the brain. Only then you can label that patient as a complete circulatory arrest. Thank you.
Thank you, Dr. Saurabh. So we do not have much time, but there would be some demonstration on a volunteer here. All of you can try your hands there. Apart from that, there are 4 courses on TCD which are available. 2 Dr. Arvind's already said about the Neurosonology Society. 1 Dr. Saurabh is hosting in the Neurocritical Care Society in September, and 1 is which I am hosting in Agra, Neurocritical Care Society, another one in Agra. So all of those who are interested to learn will have ample hands-on training. In the meantime, we can all come here and the experts can teach you, or let me...
Yeah, they can sit there.
They can sit there, okay.
Yeah. Thank you, Dr. Harsh. Thank you very much. You can sit there. Take out the cable. So we can demonstrate on the... we can demonstrate here, from here only. You can sit there because only 10 minutes are given, and as been told by Dr. Harsh that we have 2 days workshop for such things, right? So we'll just, those who have seen it, it will not be very fruitful for them. For them, the June, September, December 2 days workshops are there. But those who have not started, this will be a great stimulus for them, right? So have you connected? So it will be projected on the screen as Dr. Amit has you shown all the, how the peak systolic velocity, how the arteries are seen. Camera. So the most important thing is the holding the probe in your hand. It is always like a pen. You should be in a very comfortable position while doing the TCD, rather than you are standing in a very uncomfortable position. So the best is the lying down. If you are here in the workshop, you are doing in a sitting down position, and you go to the transtemporal area, which is, as Dr. Amit told, is made by God, the translucent area where you can see the MCA, ACA. Now, here on the screen, you can see the depth at the top, that is 54. The power is 100. And you can see the peak systolic velocity, mean flow velocity, and the PI, the pulsatility index. Right? So that is the spectral window. And you can see a beautiful dichrotic notch higher up. We cannot project it, right? We have a pointer? Yeah. So very good dichrotic notch which you can see in this, where Dr. Amit has demonstrated. So this is the middle cerebral artery of a young man. So we can say that even intracranially, when you see the artery, if it is rounding off, then you can say there is a proximal occlusion or patient is having a hypertension and it is because of the age. Yeah. You can show the VMR.
So if you look at this is the systolic velocity and this is the diastolic velocity. So this diastolic flow should be around 20 to 50% of the systolic flow. Okay. So if it is more than that, then we say that the resistance is decreasing. And if it is less than that, then we say that the resistance is increasing. So the pulsatility index will depend on the diastolic flow. Okay. So if you just show the VMR, in the VMR, what we do, vasomotor reactivity, we hold the breath for 30 seconds. We ask the patient to hold the breath for 30 seconds. And the breath should not be held like, it should not be like that. It should be, you have to demonstrate the patient that you just need to hold the breath like that for 30 seconds. Just raise your hand when you are holding the breath and just tell them to release it very slowly. And keep insonating for next 10 to 15 seconds once the patient has released his breath. So you will see that the velocities are rising or not. So if the velocities are rising, you can calculate breath holding index by a formula you can find in any of the books. So it is basically an end mean flow velocity after you hold the breath minus the mean flow velocity of that patient pre-holding the breath, that is the baseline velocity, divided by the baseline velocity multiplied by 100. So the percentage increase in that velocity is there divided by the number of seconds you have holded the breath. So 30 seconds comes in the denominator. So if it is more than 0.69, we say that the VMR is sufficient for that patient. So that means the vessels are reacting. Mayank, hold the breath.
So why we do VMR, we already discussed that part. You can tell your surgeon that these asymptomatic arteries, more than 70% of occlusions need to be touched or not. If there are bilateral, then what to do?
You can see these velocities have started increasing. 60 is, it started from 57. It will start rising. See? And the pulsatility index is going down. See? So, it has reached up to 86. So, it's a very, very good breath holding index which you are getting.
So 0.69 is a cutoff.
So, only after 30 seconds, you know whether vasomotor reactivity is there. That means whether the distal arterioles are constricting or dilating or not. अगर तू सांस छोड़ने भी दिखा दे एक बार, 3 सांसें लेना जोर जोर से, hyperventilate. So if you just hyperventilate, you just see what is happening to the velocities. Hyperventilate. The pulsatility index is going up and see the velocities are going down. So your resistance is increasing. Now you just leave it.
So what Dr. Saurabh and Dr. Amit want to say that it is a very simple bedside test which you can do anywhere. If you are in ER or in ICU, anywhere you can do in your OPD, you can put the machine and you can do it. And you can identify, you have to go for a SPECT for doing the vasomotor reactivity to see the cerebrovascular reserve, right? I think it is auto-detecting the depth. Yeah. So now the machines are like this, they automatically detect the depth and they go to the where you find the vessel. And the latest which is coming up, the trial is going on. There are probes which they are 5 to 6, which fire simultaneously and they give you the complete report for the transcranial Doppler. The Neurosonar site is coming with the trial for that. If you go more than 75, then you are crossing the skull. Then you are seeing the opposite side, middle cerebral artery and the ACA. If you go more than 75. So those who are seeing more than 80 higher up is the opposite side, MC and ACA. So we closed on time. Even we did a demonstration. Thank you very much.
So you've seen the taster. So you can have the main dish in the conferences. So I thank you from the behalf of the organizers. I thank all the three esteemed faculty for imparting knowledge. I thank Remed for supporting and Mr. Mayank from Remed for being a volunteer as well. Thank you.
As everyone is aware, we had a lucky draw where all people who were attending from 8 to 8:10 a.m. in the hall, the first prize was an iPad and the second prize was a 10,000 rupees gift voucher. So we'll have the announcement of the winner in the next 10-15 minutes. And I thank our chairpersons and our speakers for elucidating the topic of transcranial Doppler. We'll now have our next session on carotid base camp. Chairing this session, we have Dr. Shirish Hastak sir. He is the Regional Director of Neurology and Stroke Service, Global Hospital, Parel, Mumbai. Sir needs no introduction. He has more than 30 years of experience in stroke and neurocritical care. He is also the past president of ISA. We then have Dr. Trilochan Srivastav sir. Sir is a senior professor, Department of Neurology in SMS Jaipur with more than 28 years of experience. We also have Nishant Aditya sir. He is the consultant interventional neuroradiologist at HN Reliance Hospital, Mumbai. We then have Dr. Naveen Mullimani sir. He is the professor and head of Department of Interventional Radiology at Belgavi, Karnataka. We welcome all the chairpersons and ask them to introduce the speakers for this session. We'll have the questions at the end of the session or at the end of both the talks. Thank you.
Thank you, and good morning, friends. Nice to see that neuro intervention has come a long way. From the time we started looking at stroke as a separate specialty, stroke medicine. So it's a great day. I'm very happy to see you all. And good morning, and thank you, Dr. Gaurav, for organizing an excellent meeting. So friends, I think the first talk is going to be something that, we always think of the brain as something that reduces unpredictability. I think that's the best definition of the brain. So it reduces unpredictability. And so I think we all love predictability and we hate unpredictability. And that's what our brain is meant to do. So I think what we see, is it true or is it false? I think that's the key question. And we've always been looking at carotid in terms of stenosis and nothing else. But I think there is a lot more than that. And how predictable is what we see. I think Darshana has been with me at Kokilaben Ambani, and she's a great neuroradiologist. So we look forward to her telling us what is the evidence of what we see. Because we see lots of things, but what's the evidence that we can link it to stroke? And how can we reduce the unpredictability of your patient? How can you tell the mechanism of stroke based on what you see? So I think, are we delusional or are we hallucinating? Or is this the truth? So I think Darshana needs no introduction. She's a fantastic neuroradiologist. Thank you, Darshana. Please go ahead.
Thank you, Dr. Hastak, for your kind introduction and encouragement to me always. Good morning, everyone. So in this session, I will focus on the particular potential of MRI to depict the key features of the vulnerable plaque. A vulnerable plaque is one that has a high incidence of complications, like a heart attack in case of the coronary circulation or a stroke in case of the carotid circulation. MRI is very well suited for this role because, of course, it is non-invasive, does not involve ionizing radiation. Importantly, it can demonstrate both the vessel wall as well as the vessel lumen, and it can be repeated serially to track plaque progression or regression. Furthermore, because of its exquisite contrast resolution, it's possible to study the compositional and morphological features of the vulnerable plaque. Now, the ideal diagnostic and screening tool would be one which can show a vulnerable plaque in a high-risk patient before a significant stroke occurs. And it is hoped that in the near future, MRI will be able to predict the patient-specific risk of developing a stroke. Research from the past decade has unequivocally showed that relying on luminal stenosis measurements alone will underestimate the risk that the patient has for developing a plaque. And there are two reasons for this, of developing a stroke. And there are two reasons for this. First is the carotid bulb is much wider in diameter than the distal internal carotid artery, and therefore significant plaque can exist in the carotid bulb without causing impressive luminal stenosis. And second is the phenomenon of positive arterial remodeling, where the plaque grows away from the vessel lumen. And so you can have a significant plaque burden, but not enough luminal stenosis. Thus, what I'm trying to say is that besides luminal stenosis, it's actually the composition and the morphology of the plaque which determines the risk that a vulnerable plaque has of causing a thromboembolic stroke. And I'd like to validate the point I'm making by showing you two cases from the recent past. So the first is of an 86-year-old man with testicular lymphoma who had a right MCA territory stroke, and you can see the infarct on the diffusion-weighted images, and the MR angiogram looks completely normal. Both the reconstructions as well as the source images, the right carotid bulb looks absolutely normal. So this patient was conserved based on this imaging with antiplatelets, but continued to have TIAs for 2 weeks, multiple TIAs for 2 weeks. So we did a vessel wall imaging. And here on the vessel wall imaging with MRI, you can see there's actually significant plaque without causing significant luminal stenosis. The yellow dotted arrow shows us that the plaque has a lipid-rich necrotic core, and it's an ulcerated plaque. So it's a vulnerable plaque. This is probably the cause of the stroke. On the catheter angiogram, again, you can see on the first column that there's not much luminal stenosis, but there's actually a plaque there. And we offered this patient stenting, after which the TIA stopped completely. And here you can see in the struts of the protection device, there's plaque and cheesy material from the plaque and the thrombus in the protection device. So the purpose of stenting this patient is to stabilize the plaque, not to recanalize the artery, because the luminal stenosis is not significant. The second case is of a 44-year-old woman with a stroke, a young stroke, and she came with this imaging performed at another institute. You can see she has right MCA territory cortical infarcts, and on the angiogram she has filling defects suggestive of intraluminal free-floating thrombus. So we immediately shifted the patient to the cath lab, and you can see that in the early phase of the angiogram there are filling defects caused by the free-floating thrombus. In a later phase, once the contrast has passed off, you can see the free-floating thrombus better. And here the free-floating thrombus has been aspirated. You can see it has a very cheesy nature. And the post-aspiration catheter angiogram looks much better. The 2D echo was normal, so in a way this was a cryptogenic stroke. The angiogram again looks normal, the MR angiogram. So we again did a vessel wall imaging of the carotid bulb. And here you can see an atherosclerotic plaque, eccentric plaque, which is not causing luminal stenosis, but is probably the cause of that stroke. Stenting was offered to the patient. So again, what we are trying to say is that it's not only that we should concentrate on luminal stenosis. You can have vulnerable plaque sitting there without causing impressive luminal stenosis. From a physiological point of view, MRI is very amenable to, the carotid arteries are very amenable to imaging by MRI for 3 reasons. It has a very superficial location, it is remote from heart and lung motion, and it has a very large size. And we now have these dedicated surface coils available, which you just put on the carotid and you can get exquisite resolution. I think it's gone to the last slide by mistake. So we use two techniques. These are cross-sectional images of the carotid. One is called the white blood technique, in which the flowing blood looks white, and one is called the black blood technique, in which the flowing blood looks black. We use a combination of both techniques in all cases. Of course, 3 Tesla has a much better resolution than 1.5 Tesla. And it's quite amazing that the plaque is actually just a few millimeters in thickness. And modern day scanners and pulse sequences have the ability to identify various components of the plaque with very high accuracy. What has really been a game changer has been the ability to access for us the end arthrectomy specimens and the availability of special stains to stain those end arthrectomy specimens. And the pathological studies were used to validate the MRI findings. And you can see there's excellent correlation between the plaque components seen on post-endarterectomy specimen histopathology compared to what we saw on pre-procedural MRI. And we can identify every component of the plaque, like the amount of the lipid necrotic core, the extent of loose fibrous matrix, calcium, as well as fibrous tissue. So as a radiologist, what we basically try to tell our referring doctor is whether it is a high-risk plaque, which is basically a soft plaque containing a lot of hemorrhage and lipid core, versus a solid or a hard plaque where the main component of the plaque is fibrous tissue and calcification. I'll show you an example of each. This is the at-risk or soft plaque. So on the T1 weighted sequence, it's very bright, and the brightness is due to the presence of intraplaque hemorrhage. On the corresponding ultrasound, it is echolucent. And here you can see that when the surgery has put a nick on the artery for doing an endarterectomy, a yellow fluid is oozing out of the adventitia, which is a mixture of intraplaque hemorrhage and necrotic material. As opposed to this, this is an example of a hard plaque which shows low signal on T1 weighted images. On the corresponding pathology specimen, you can see it mostly contains fibrous tissue, and this is a relatively stable plaque. On MRI, there are 6 criteria for defining a vulnerable plaque, and I will go through each one of them. The first criteria is a ruptured plaque. So this is a Movart's pentachrome stain of a ruptured atherosclerotic plaque. And you can see that the plaque contains a very large lipid necrotic core with hemorrhage, which is surrounded by this white area, which is the fibrous cap. And where the red arrows are, the fibrous cap has ruptured. This has a very high correlation with a significant stroke. So studies have shown that 66% of patients with major strokes have ruptured of the fibrous cap, whereas only 10 to 13% of patients without any ischemic event would have rupture of a fibrous cap. So this is a radiological finding with a high correlate for a high risk of developing a significant stroke. These are white blood and black blood cross-sectional images showing a ruptured plaque. So I'll take you through them. This area in white is actually the lumen of the vessel, and the arrowheads are showing us the plaque, which is also bright because it is containing hemorrhage. The arrowheads show the fibrous cap, which has ruptured here, allowing the blood to enter the plaque crater, forming an ulcer. So again, here you can see the fibrous cap is ruptured on the black blood sequences, forming this typical dimple. This is a ruptured carotid plaque. What happens here is that the thrombogenic components and the lipid is exposed to the platelets and coagulation factors in the flowing blood, allowing the aggregation and formation of a very fragile thrombus which can embolize at any moment. The second criteria for defining a vulnerable plaque is a plaque which has a thin fibrous cap and a very large lipid necrotic core. So here's a pathological example of a carotid vessel wall in cross section. This is the lumen. It's a very small lumen here. This is just to illustrate the plaque. This red area is the lipid core, and white is the fibrous cap, which is very thinned out here. We need gadolinium on MRI, a contrast-enhanced MRI, to differentiate the fibrous cap from the lipid core. So again, you can see that on the MR angiogram and the catheter angiogram, maybe it's just about 40 or 50% stenosis. But look at this vessel wall imaging. So there's a very, very big plaque here, actually. This is the lumen, and there's a massive plaque here. The fibrous cap shows enhancement, whereas the hypoxic lipid necrotic core does not enhance, allowing us differentiation between the two. And there are numerous studies which have linked the thickness of the fibrous cap to the likelihood of developing a stroke. The thinner the fibrous cap, the more are the chances of developing a stroke. You can see this patient has already developed a small left MCS stroke. Now, the most critical imaging finding that has a very high link to rapid plaque progression is intraplaque hemorrhage. If there's one criteria which means that the patient is at very high risk, this is intraplaque hemorrhage. It appears bright on both T1 and T2 weighted images. Here you can see again the luminal stenosis is not significant, but there's a large plaque full of hemorrhage which is very bright on the black blood as well as the white blood sequences. So the origin of intraplaque hemorrhage is thought to be due to leaky immature microvessels linked to plaque inflammation. Once we see hemorrhage in the plaque, there is likelihood that the plaque will progress very rapidly because of the ruptured RBCs, and there is a high chance of eminent plaque disruption. So I'll take you through these images and the correlation with the pathology. This is the white blood technique. This is the black blood technique. The red circle is the lumen, which is this area. Then there's a dot of calcification, which is this area. And then there is this very bright hemorrhage inside the plaque, which is this area. So once we see plaque hemorrhage within 6 months, you can expect the plaque to double in its size. For example, this is the baseline. This is 6 months later, vessel wall imaging. I draw your attention to any random column. For example, the middle column. This was the plaque 6 months later. You can see the plaque has grown almost doubled in size and the lumen has become very small. So if we see plaque hemorrhage, you expect very exponential growth of the plaque. The next criteria is calcification, which is somewhat controversial. So although many people link the presence of calcification to high risk, there are other studies which indicate that calcification actually stabilizes the plaque. Then we have the traditional criteria of a plaque burden, which is mainly the thickness of the plaque. On ultrasound, it is measured by the intimal medial thickness, which is actually the volume or the area or the thickness of the plaque. For example, this is a patient with a very large plaque burden. This is a reconstructed coronal image of the carotid artery. This is a cross-section which shows that there's so much plaque that it's compressing the jugular vein, which is outside. The plaque is growing outside rather than towards the lumen. This is called positive arterial remodeling, where the plaque grows away from the lumen. And therefore, if you do a conventional angiogram with CT, MR, or a catheter angiogram, one would feel that the artery is patent, but actually there's a large plaque on the wall which is growing outwards, and this is called positive arterial remodeling. You can see in the endarterectomy gross specimen, there's a huge plaque burden. And the last criteria, which is really the most important kid on the block, is inflammation. So we know again from numerous papers in the past few decades that atherosclerosis is actually an inflammatory process, and therefore the demonstration of inflammation in the atherosclerotic plaque is the subject of numerous new radiological techniques. We know that inflammation is the process by which the body reacts to injury, and in case of atherosclerosis, this injury is the deposition of cholesterol within the vessel wall. This injury causes the release of pro-inflammatory cytokines, which in turn cause endothelial cells to express adhesion molecules on the intima, and blood leukocytes aggregate on these adhesion molecules. So the infiltration of the vessel wall by inflammatory cells is the hallmark of early atherosclerosis, which is finally linked to the plaque disruption of advanced disease. So for example, if you see this vessel wall specimen over here, the lumen is really large. But if you see the micro photograph, you can see that the vessel wall has been infiltrated by inflammatory cells, and this is probably going to lead to significant atherosclerosis. There are two techniques which are currently the subject of research and further validation to demonstrate inflammation in the vessel wall, which is the harbinger of atherosclerosis. The first technique is dynamic contrast enhanced MRI with kinematic remodeling of the pattern of contrast uptake to demonstrate endothelial permeability and inflammatory neoangiogenesis, which are the markers of inflammation in a plaque. And the second is a PET study using special tracers which get attached to inflammation. For example, in this PET study, you can see that the tracer has been taken up by the inflammation within the atherosclerotic plaque. So these are the 6 criteria that we use on vessel wall imaging to identify the vulnerable plaque, of which the most ominous imaging finding is the presence of intraplaque hemorrhage. From carotid bulb plaque, I will move on to intracranial atherosclerosis. We know that intracranial atherosclerosis is a significant cause of plaque, especially in the Indian subcontinent, and the presence of plaque within the MCA carries a significant stroke risk. So we can try to demonstrate plaque in the middle cerebral artery as well. This is a normal volunteer. Just to show how these images are taken, they're taken perpendicular to the middle cerebral artery, and the normal middle cerebral artery should appear as just a flow void without a discernible wall. So there's no discernible wall, just a flow void, which means it's a normal middle cerebral artery. This is another positive case for comparison. So again, this is a patient who had TIS from the right MCA territory, but the carotid bulb was normal. The MCA also looks normal. We have tried to take vessel wall images of the MCA. This is an image at the level of the trifurcation. I'm going from lateral to medial. So I can see a nice trifurcation. Now where I'm going medially towards the MCA origin, it's yet normal, just a flow void without a discernible wall. But in the proximal MCA, I can see the atherosclerotic plaque. Here, this crescent-shaped area is the atherosclerotic plaque. This is another case with a left MCA territory stroke, and we couldn't give contrast to this patient because of very significant renal issues. But the interventionist asked us, is this an occluded MCA on the abnormal side shown by the red arrow, or is it just high-grade stenosis and a hypoperfusion infarct? Because a occluded MCA with a thrombus, he would plan for an endarterectomy, whereas if it was a plaque causing a high-grade stenosis, he would have to go for stenting. We couldn't give contrast. We weren't sure what was happening. So as an experiment, we took these sagittal high-resolution cross-sectional images of the MCA. And here you can see the circumferential atherosclerotic plaque. I'll just show you a magnified image of the same. So you can see that the vessel wall of the MCA is having a circumferential atherosclerotic plaque, which is narrowing the lumen. And this was the cause of the stroke. So it was probably a hemodynamic stroke, not a thromboembolic stroke maybe, because it was causing a diffuse narrowing, and this patient was offered stenting. And besides atherosclerosis of the carotid artery and the intracranial artery, vessel wall imaging can be used to demonstrate other pathologies of the vessel wall. I'll give an example again of a young stroke. And this patient had multiple posterior circulation infarcts, and we couldn't find any reason. The 2D echo was normal. I reported the MR angiogram as normal. There was no cause at all. And so we sent the patient to the cath lab for a DSA. The DSA was also reported normal, but when the senior interventionist reviewed the images, they felt that there was some irregularity in the anterior wall of the right vertebral artery. When I look back at the angiogram, MR angiogram, it was probably there, but I don't think I would have been able to report such a subtle abnormality. But we did vessel wall imaging at this site, and you can see that there's an acute dissection of the right vertebral artery. So in black is the patent true lumen, and in white is the thrombosed false lumen. You can see it beautifully, the patent and the thrombosed lumina. So that's the angiographic abnormality, which is barely discernible. I think many would have passed this angiogram off as normal. But when you see, this is the white blood technique, you see the white patent lumen and then a grayish false lumen, which is thrombosed. This is a black blood sequence showing you both lumina of an acute dissection. This is the entire set of cross-sectional images. This is how we follow an artery. So right vertebral normal, right vertebral, showing just a flow void, no abnormality of the vessel wall, which is barely discernible. And then as it turns around, in its intradural segment, you can see the dissection. So I think I finished a little bit ahead of time, but I would like to summarize by saying that yes, luminal stenosis is the major factor, but besides luminal stenosis, plaque composition and morphology are also key determinants of the likelihood that a plaque will cause a stroke. For the same degree of luminal stenosis, plaque composition and morphology will vary from patient to patient. For symptomatic patients without luminal stenosis who have a vulnerable plaque, perhaps we should offer them more aggressive treatment like carotid endarterectomy or stenting. And for asymptomatic patients who have a vulnerable plaque, possibly more intensive lipid-lowering therapy can be offered. MRI is very well suited to study the vessel wall because it is totally non-invasive, does not involve radiation. As I said, it is the only technique besides ultrasound which can depict both the vessel wall and the lumen. A catheter angiogram is only a luminogram, but an MRI will show you the vessel wall and the lumen simultaneously. And unlike a catheter angiogram, it can be repeated serially to track progression or regression of the plaque. Finally, besides carotid bulb atherosclerosis, MRI by vessel wall imaging can be used to study intracranial atherosclerosis and other abnormalities of the vessel wall, such as dissection. That's about it. I thank you for your attention, and I'm happy to answer any questions.
On time, rather before time. So we will have second talk. Yeah. So the second talk is on the carotid web by the Muhammad Al-Mehek Khafi. Is a remote talk, and the carotid web is one of the rare but important cause of young stroke. It is like slit-like projection or self-like projection in the carotid artery, in the posterior surface of carotid artery, and it is found around in 1 to 2% cases of the young stroke. It requires Doppler and CT angio to demonstrate it, and sometimes DSA. It is a type of a localized form of fibromuscular dysplasia. So it is basically fibromuscular dysplasia, which can be unilateral and sometimes it can be bilateral. And it is high chances of recurrent stroke with the, yeah, okay, fine.
So we'll just declare the prizes of the lucky draw. The first prize is the iPad. The doctor needs to be here for them to receive the prize. Otherwise, the prize will go to another person.
Yeah, I think my voice is shaking because it's my name. It's not my name. I'm honest. I'm an honest guy. I'm an honest neurologist. It's Dr. Sanat Bhatkar. Dr. Sanat Bhatkar, please. You're the lucky guy to get the iPad. Oh, not here. Okay, so the next guy. I hope it's one of our people here on the stage. Yes, it's Dr. Devashish Hota. Dr. Devashish Hota, you're the lucky guy to get the iPad. Wow, I think iPad is something everyone would have loved to have had. Please come up. Okay, so you'll receive your prizes at the gala dinner. Just remember to collect them, please. Well, why don't my colleague remove the next,
Dr. Karthik Kumar Balasubramaniam. He's here. Oh, so maybe next.
Is that an iPhone? Okay, that's 10,000
Dr.
rupees
Bala
gift voucher.
Subramani. Dr. Bala Subramani.
Wow. Congratulations. Congratulations.
Next talk live connected on the app.
Okay. So next talk on carotid web.
Hey, good morning. I hope you can hear me well.
Good morning.
Morning, we
Yeah.
can hear you well. Yes, please go ahead.
Okay, perfect. Thank you very much. Thanks for the organizing committee for the kind invitation. My name is Mohammed Al-Maklafi. I'm an interventional stroke neurologist in Calgary Stroke Program in Calgary, Canada. It's my pleasure to talk to you all today about carotid webs from selection to follow-up, a practical approach for evaluation and management. I have no relevant conflicts to declare. So this is the outline that I'd like to talk to you regarding the carotid web. So first, definition, some data about the prevalence, what we know in the normal population, in the stroke population, and then an approach, a practical approach to diagnosis, treatment, and prognostication of those patients. So I'll take a step back and just kind of mention the way, at least for me, I think about classification of symptomatic carotid disease. So when I think about symptomatic carotid disease, I think in terms of atherosclerotic versus non-atherosclerotic pathology. When we look at atherosclerotic disease, we typically look at the degree of stenosis, although the Madam Speaker just ahead of me provided an excellent way of looking at the plaque and even without any luminal stenosis. But for the time being, this is the approach that at least we have data regarding the outcome of patients with carotid disease, and that depends on how much the lumen is narrowed. So those patients could have less than 50% stenosis and still could be symptomatic, as we've seen in the previous talk. And this led to an emerging concept called symptomatic non-stenotic carotid disease, or SYNC. There is patients with severe stenosis, more than 50% and up to 90% or 99%. There is the specific entity of carotid neuro-occlusion, where there is a distal collapse of the vessel wall, kind of distally to the degree of stenosis. And then there is a complete carotid occlusion, whether it's kind of in the setting of an acute stroke, emergent, or in a setting of reversible kind of TIA or minor stroke. When we look at the non-atherosclerotic disease, there are a few conditions that come to mind. Most commonly is the carotid dissection, or there is a hematoma in the wall of the artery. There is the fibromuscular dysplasias resulting either in dissection, pseudoaneurysms, and so forth. There is the radiation-induced stenosis, which is a non-atherosclerotic, non-inflammatory radiation-related stenosis that require treatment and could present with TIA or stroke. And within this group of non-atherosclerotic disease is where the carotid web seems to fit. And we'll talk more about carotid web in the coming few slides. But it kind of, before jumping to the next slide, it's important to highlight that either of these pathologies, whether atherosclerotic, non-atherosclerotic, can be associated with an intraluminal thrombus formation, which could perhaps predispose to the event to the TIA or stroke. So what is carotid web? So really our definitions for carotid web is an operational morphological definition. It's basically we're describing what we see and the specific entity that defined by how it looks on non-invasive or even invasive imaging. So it's a shelf-like projections, typically from the posterior or posterolateral wall of the carotid bulb, projects into the lumen to a certain degree, which could vary from very noticeable, hard to miss kind of projection up to something fairly subtle that require careful examination of the images to identify. This pathology is considered to be developmental, that it happens or people are born to it, although that's not typically not fairly confirmed. But the current thinking is that carotid web is an intimal variant of fibromuscular dysplasia. in which there is fibrous kind of hyperplasia of the intima that project into the lumen and result in this shelf-like projection. And carotid web is not a new pathology that's been defined only recently. It's been published, at least in the literature, almost 50 years ago in a kind of description from the Mass General Hospital, where they describe 4 patients out of 7,000 patients who have these projections during an 8-year study. However, as we can see in the literature review, there is an exponential increase in the reports of carotid webs in the last 10 years or so, and that's most likely with the advent of non-invasive vascular imaging and realizing it's important in workup of all patients with TIA and strokes. However, with that, unfortunately, the prevalence of carotid web is still unclear. There is data reporting up to 1% prevalence in patients of controls in retrospective series, so healthy or at least asymptomatic from a cerebrovascular standpoint patients. But there hasn't been any population-based imaging study to assess the overlap prevalence, and obviously these would be very hard to conduct and understand and generalize to other populations. In another study, it was identified in about 1.2% retrospectively in another cohort study, and only 2 of those 7 patients identified in this study had a stroke in the vascular territory of the carotid web. We'll talk more about their prevalence in patients with stroke later on. However, seems to be 1% is a reasonable number to quote in terms of their prevalence in the normal population. Symptomatic carotid webs, and that means in patients who present with TIA and strokes, is likely underreported for a number of factors. One of them is the lack of any diagnostic criteria that has high agreement, although morphologically there is very high agreement on the diagnosis. However, there isn't an established diagnostic criteria that has been validated and tested. Doppler ultrasound, which is the majority of patients with TIA and stroke undergo for vascular imaging, can easily miss these pathologies or label them as mild atheromas that could be disregarded or just managed medically. However, there hasn't been many studies that have been done using CTA until recently. And with those, again, careful consideration and looking at the images is required. Otherwise, some of these webs could be missed. And that's why I think it's very important in the CTA, in the angio, when there is no clear explanation of the stroke and it's a kind of hemispheric unilateral stroke, is to follow the path that this clot may have crossed, starting from the aortic arch, going all the way to the intracranial circulation, trying to be very careful in identifying any irregularities that could identify, for example, a dissection as seen in the previous case, or possibly a small web that is only seen in the sagittal or coronal views. But even more relevant is whether what we see is an incidental finding, given that it's present in 1% of the population, or it has an etiological significance that could be related to the stroke. So how does these pathologies result in a stroke? In this review from the Calgary group, the hypothesis is that these webs generate some stasis due to the turbulence of the flow that's caused. And this stasis, in addition to other potentially factors, would lead to the formation of a thrombus that eventually will become large enough to dislodge and go to the intracranial circulation. And that's at least one of the mechanisms that's supported by some anecdotal evidence from case reports and studies. We can see evidence of this stasis in the angio suite, where we have both the temporal kind of resolution, meaning that we can follow these over time. We can see here in a carotid run that the kind of contrast is filling all the vessels, and then as the contrast is being washed out by the blood flow, there is some residual flow in the carotid bulb, which is considered a high risk marker for these carotid webs because of the degree and the duration of this stagnation that could last for a few seconds longer after all the contrast has been washed out. Obviously, people who do these angiograms know that in certain but small number of patients who perhaps are having the angiogram for a diagnostic and related purpose, we can still see some stagnation of contrast or at least layering in the carotid bulb related perhaps to some turbulence of flow in this area, and that need to be differentiated from carotid web where we see a projection into the lumen plus the layering or stagnation of contrast. So moving to studies that looked at the prevalence of carotid web in stroke, there has been a systematic review that looked at the prevalence among 160 patients reporting on carotid web from 37 publications. So small number of patients per study, but these reported that almost 84% of these patients were symptomatic, meaning that they had a carotid web at the same side of the stroke without a clear stroke etiology. About 15% were asymptomatic. So those are the ones that were on the contralateral side of a stroke or on a side of a kind of a posterior circulation stroke. 1 in 5 of those patients had bilateral webs. So it's not uncommon to have another web on the contralateral side. And the overwhelming majority resulted only in mild stenosis, meaning that most likely, if these are etiological, the mechanism for causing a stroke is not due to luminal narrowing, but perhaps stasis or other factors. When we look at the patient population that have harbor symptomatic carotid web, we don't see the typical stroke risk factors. So on average, those patients are young. 2/3 were women, and at least in this study, there was overrepresentation of African women. But when we look at the typical stroke risk factors, again, hypertension, only 23%, smoking, less than 20%. But oral contraceptive use was overrepresented with almost a quarter of the patients, which again links back to the turbulence and what other factors may promote thrombosis in addition to the stagnation of blood, and that could be one of the factors is oral contraceptive use, and it may be an explanation for the overrepresentation of the women. But the other factor is whether there is some genetic predisposition related to this assumed intimal variant of fibromuscular dysplasia. So recognition is key, and as I said earlier, a high index of suspicion to look at the carotid web, and for that purpose, all the path from the aortic arch to the intracranial circulation is very important, especially in young with stroke. But one of the reasons to be very careful is to look for other condition that could mimic a carotid web, and one of the most common ones is an intraluminal thrombus on top of perhaps a ruptured plaque or carotid mild atherosclerotic disease. Here we see something that projecting into the lumen. This is from the sagittal view. This is on the axial view. And if you looked on the axial, you'd probably say, yeah, this looks like a web. The sagittal is a little bit unusual, just given the irregularity of the surface of the artery and the length of that pathology. After a few days of anticoagulation, images were repeated, showing at least complete resolution of that intraluminal thrombus, meaning that clearly it wasn't a web. However, webs could have a superimposed thrombus formed, and these are a couple of case reports showing that. So this is one of these reports showing a kind of a carotid, a thrombus into the carotid on top of what looks like a projection of a web. But this case also shows it nicely here, where there is a projection into the lumen, and then there is kind of formation of a thrombus as seen by the arrow. And when we look at the pathology specimen of one of those patients, we can see here the carotid web with an intraluminal thrombus superimposed on it to show that. Just try to see if my mouse could be visible. I just noticed that the mouse is not showing. Perhaps here, a spotlight. Okay, yeah, perfect. So I'll keep moving. Okay. This is another study showing a carotid web with a superimposed thrombus. As we can see here, this is on the kind of CT angiogram, on the Doppler ultrasound we can see here. And this is after 2 weeks of anticoagulation plus antiplatelet therapy, showing that the area of thrombus that was seen or thought to be a thrombus initially has resolved. But there is still an intimal pathology, most likely representing a carotid web. And finally, again, the connection, the etiological connection between a carotid web and stroke would be seen here in this endarterectomy procedure, showing the carotid web with a superimposed thrombus in 2 patients, which again supports the notion that these carotid webs are not coincidental, kind of innocent bystander, but has an etiological and pathophysiologically explained relationship to the stroke in those patients. And at least one of these patients was 39 years old and 44 years old. So again, younger patient population with unexplained stroke seems to be the hallmark of these patients. And finally, just want to be careful is of the non-stenotic carotid disease, meaning an atherosclerotic pathology where we see the projection into the lumen, not causing significant narrowing, but as nicely shown by the previous colleague speaker, that the burden of the plaque seems to be high in those patients, and most likely the ones who present with TIA or stroke may have high risk features, as explained nicely in the previous talk. But about 20% of stroke patients seems to harbor some form of non-stenotic carotid disease, and at least part of them could be etiological. The two could coexist, meaning a carotid disease, a non-stenotic carotid disease plus a carotid web, as we can see in this case. And knowing which one is etiologically responsible for the stroke could be hard, but perhaps this may be a more call for a treatment as opposed to just maximizing medical treatment, but more of a revascularization definitive procedure. Carotid ultrasound, which remains the most widely used investigation for a kind of assessment of TIA or stroke, has about 60% sensitivity related to interoperator differences and so forth. And therefore, I think goes without saying that young patients with stroke require careful vascular assessment, and if non-invasively, then this should be at least with CTA or in contrast enhanced MR. But as you can see here, there are cases when the carotid web is very clear that it would show the degree of kind of projection into the lumen, and as seen and confirmed in this case with the DSA as well. I won't go much about the MRA, kind of as covered nicely in the previous talk, but as you can see, the kind of very high resolution of the MR can nicely show the carotid web in certain cases with enhanced contrast enhanced MRI as seen here. And then obviously the digital subtraction and geography catheter angiogram, which has superior spatial and temporal resolution. But again, these are typically not done for the purpose of diagnosis per se. This could be discovered during kind of an intracranial thrombectomy procedure for a stroke in the young, or in the setting of already planned intervention where we can see this stagnation of contrast, meaning that there is stasis promoting the condition for thromboembolic complications. I won't spend much about this, but some people reported on the screening for systemic fibromuscular dysplasia, and the bottom line is there is is a very small percentage of patients who have coexistent of a carotid web with systemic form of fibromuscular dysplasias, either affecting the renal arteries or other circulations, but currently there is no indication for screening for fibromuscular dysplasia systematically. In terms of treatment and natural history of each treatment modality, the systematic review done in 2018 looked into the literature in the patients, and about half of those patients underwent medical treatment alone, so either with antiplatelet therapy and a few with anticoagulation. And then a few underwent, actually 70% of patients in the reported literature about the treatment of carotid web underwent some form of revascularization, 50% with stenting and 50% with endarterectomy. And as we can see here, the risk of recurrent stroke varied widely between these modalities. About half of patients on medical treatment had a recurrent stroke, and typically those patients will have a large vessel occlusion, larger stroke. And none of the patients who underwent either endarterectomy or stenting had any recurrent stroke within a median observation time of almost 14 months in these studies. So very encouraging results for revascularization, but again, I have to stress that these are assumed etiological carotid webs. There is obviously the selection bias that the operator selected those webs with high risk features, and therefore I'd caution from extrapolating these data to any patients with carotid web, but definitely patients who are young in age with apparently no other explanation for the stroke, and there is a kind of at least marker of stasis or thrombophilia that perhaps link the carotid web to the stroke even strongly. Increased degree of stenosis correlated with a recurrent stroke, although this was not statistically significant, but again, as previously explained, the underlying pathophysiology of these carotid webs may not be per se related to the luminal stenosis, but to the stasis more likely. And there were no procedural complications reported in either the stenting arm or the endarterectomy cohorts in these studies. And that is expected in patients who are young and wouldn't really be expected to have any access-related difficulties with these cases. So what do we do when we're confronted with a carotid web that is possibly related to the stroke? So the very first question is to have a very thoughtful look at the patient and asking whether this carotid web is the culprit for the stroke. And as I said, younger patients with an ipsilateral embolic looking stroke without any other vascular risk factors and no other explanation for stroke would probably constitute a population in which revascularization can be considered. Do we know what is the risk of that patient, whether on medical treatment or revascularization? These are kind of consideration to be taken into account. However, from what we know in the literature, medical treatment per se, although this would vary, most likely it was a single antiplatelet therapy and so forth, but whether antiplatelet plus anticoagulation may be superior, that's still unknown. But for revascularization, what is the recurrence risk if a patient had an arteriopathy instead of the carotid web, and is there any risk of recurrence or instant or recurrent formation after endarterectomy or instant stenosis? And therefore, we need diligent reporting of long-term outcome of these patients, which unfortunately we still lack in the current literature. And finally, deciding whether endarterectomy or stenting. I think there are anatomical factors and patient-related factors that can be taken into account, but both procedures seem to be protective and without complications. This is one of the excuse me, reported cases in the literature for carotid web stenting. As we can see here, this is the first imaging showing the carotid web at the carotid bulb. this is immediately after stenting, and we see that right away the projection into the lumen has disappeared with just a little trace, and at a 3-week follow-up, the artery seemed to have the stent has opposed well onto the wall of the artery without any residual stenosis or projections. Some people advocate the use of dual layer stents as opposed to the standard kind of open or closed cell stents. And again, there is no guidance in the literature, but the dual layer stent seem to kind of to provide at least on a pathophysiological basis rational for kind of preventing that web and making sure that the web get opposed to the wall without any residual kind of area that could cause turbulent flow in the future.
Dr.
Yes.
Mohammed, you have run out of time. So
okay. That's the last slide. So current recommendations from guidelines only indicate medical treatment and only revascularization in patients who are refractory to medical treatment. Thank you very much.
So, at the end of this session, we will take question from the both speaker. First, Dr. Darshana Sanghvi, and then Dr. Alkavi. Any question for first speaker for the plaque imaging for carotid and intracranial disease?
Dr. Darshana, would you come on the stage, please? Yeah, so I think being the chair, I would ask the first question to Darshana. Is there a score on the plaque risk? Because, you know, as you correctly said, that the hemorrhage is number 1, and then, you know, maybe the plaque burden is 2 or active inflammation, and their weightages are different. They're not all the same. So is there a developed plaque score so that you can tell that this guy is 6, and so I will do the stenting, and this guy is 1, so I won't, or 2 or 3? Is there a score that exists right now?
Yeah, that's a very pertinent question, sir. So I think all the research now is basically convincing people that, you know, stenting or endarterectomy can be offered in that 20% of patients without luminal stenosis. But I think the research work is towards developing some sort of a score eventually. Exactly predict the risk of a stroke and then give a score. But I don't know of a score currently available in literature, a well-validated score.
Then
but
how
I think
would you put
that?
That? As you said, the plaque hemorrhage is very important. So would you grade 1, 2, 3, 4 on that in terms of what we should look out for?
So our reports are yet subjective, where we communicate that there is a high risk of stroke or a moderate risk of stroke. Of course, this is that subset of patients which requires direct communication with the neurologist or the interventionist. And with the patient also. I think it requires expanding the credibility of everyone. So it's subjective, sir. As of now, it's subjective.
And
report. Yes,
as
Nishan.
you mentioned those 5 criteria for the carotid, the proximal carotid, do you have the same for intracranial, or the imaging resolution is still a restriction for intracranial atherosclerotic disease?
I think it's limited yet. We can just about identify that there is a plaque.
Correct.
We haven't reached the point where we can define the components of an intracranial plaque. Correct. Because it's really small, the intracranial arteries.
And in practice, because we are treating now stroke more and more in a hyperacute phase, 90% of intracranial disease that we face is hemodynamic rather than embolic.
Correct.
So if you compare the carotid to the intracranial plaque imaging, carotid is having more application for the clinical decision making rather than the
Yeah, I agree with you.
Isn't it?
Yeah, I agree with you.
How do you compare?
Sorry, just to finish Nishan's question. Also, sometimes intracranially they don't know whether it's vasculitis, the vessel wall disease is vasculitis, or it is atherosclerosis. Correct. So that's one of the places where we use intracranial vessel wall imaging. There are certain descriptors of atherosclerotic intracranial vessel wall disease versus vasculitis, where the treatments, of course, would significantly vary, with steroids being offered for vasculitis. So that's one extra indication of intracranial imaging.
Which is very important for the stenting or no stenting.
Correct.
Any questions from the audience?
How do you compare 3D OCT with vessel wall imaging from MR?
CT scan?
3D OCT optical
Optical now is
coherent tomography, because the cardiologists use in and out, for their coronary stenting.
Even for carotid plaque imaging, it is
Yeah,
available now.
it is.
now
They've
the 14
started.
wire sensors are available now. With the 17 catheter, you can use it.
The resolution is almost very similar to what we get in a vessel wall imaging. But yeah, it becomes invasive. That's what.
Yeah, and the other thing is, I feel MRI is a one-stop shop. You get enormous amounts of parenchymal information, the information about the infarct core, about the extent of hypoperfusion. So typically we do the vessel wall imaging with a luminogram, with a detailed parenchymal imaging. I think that would be one benefit of MRI, even over ultrasound, which is a cheaper operator-dependent technique. But MRI is a very comprehensive tool for stroke, I think, because it offers parenchymal information as well.
Basically, we had a scoring for plaque system when we are doing a vessel wall imaging. 1 to 7 or 1 to 8, we had a plaque system scoring which came initially. Is it still valid? Like, a type of, based on the type of plaques?
Yeah, I don't use the scoring system actually. But I realize that many indications that I get for vessel wall imaging are in patients who already have critical stenosis. They're already an indication for stenting. So I feel those are not really the right indications. I don't know why I get these requests. I would do it in the cryptogenic stroke where I cannot find any other reason.
A quick question to you is that, this thinking that we had that intracranial you could do and contrast enhance and make out if this is vasculitis versus atherosclerosis. So atherosclerosis would be more patchy enhancement, whereas vasculitis would be uniform. Has that panned out, or is it just an idea?
Or is it just a
idea that hasn't been?
No, it's panned
out well.
It's very much panned
so you
out.
can separate the two.
We can separate the two, and then we just need a bit more validation with the laboratory parameters, ESR and CRP. But it's a tool we used all the time to differentiate atherosclerosis from vasculitis.
Dr. Mohammed is online.
Yes, I am online.
So I want to know which is the best modality to find out the carotid web. It is CT angio, MR angio, DSA, or even Doppler. So which is the modality you use to find out the carotid web?
So at least in my center, and I think in many other centers, the workforce for non-invasive imaging is the CT angiogram. So I think that probably would be the kind of best in terms of non-invasiveness and accuracy compared to other modalities.
Okay.
Thank you. I think we've run out of time as usual. So thank you very much, and thank you for attending, and thank you for an excellent talk, Dr. Darshana, Dr. Mohammed. I think we're updated on this. So thank you very much. I think we break for 15 minutes, and we are back at 10:15. Thank you.
Thank you. Thank you very much.
So let us start our next session on cryptogenic stroke, some of the hidden causes, how to manage cryptogenic stroke, how to diagnose cryptogenic stroke, use of cardiac MRI, as well as some of the strategies of secondary stroke prevention. Chairing this session, we have Dr. A.K. Thakur, sir. Sir is the Director, Institute of Neurosciences at Medanta Hospital, Lucknow. We also have Dr. Vinay Agarwal, sir. Sir is a Senior Consultant Neurology at Pragati Hospital, Bareilly, UP. We also have Arvind Sharma, sir, the Head Department of Neurology and Stroke Specialist at Zydus Hospital, Ahmedabad. And we also have Darshana ma'am, who is the Consultant Neuroradiologist at Kokilaben Hospital, Mumbai. I ask the chairpersons to kindly introduce the speakers. We'll have the questions at the end of the session, at the end of all the talks.
Okay, good morning. I think it's going to be a very exciting session because the theme is unknown to known for a better tomorrow. So we look forward for a better tomorrow in stroke as well. And the main reason is that we know that cryptogenic stroke, they account for about 30% of the patients with stroke. And our aim should be to bring it down to 0%, because all stroke, they must have some cause. So we have this session has two parts. First part is the 3 talks by 3 eminent speakers. The second part will be 3 case-based discussions, and this will be followed by a 10 minutes discussion and question answer. So let me introduce the first speaker, Dr. Shirish Hastak. He's a very senior and eminent neurologist and strokeologist. He's a regional director, neurology and stroke services at Global Hospital, Parel, Mumbai. He has over 30 years experience, and his stroke and neurocritical care are his main interest. He has been a past president of the Indian Stroke Association Economic Times Inspiring Neurologist Award in 2018. He's a top neurologist for India Today 2019. And he has set up the first stroke unit in the Western India. I think when we were Lilavati Hospital. And it's more than 25 publications. So it's our pleasure to be hearing to Dr. Hastak again. And his topic is on hidden causes of cryptogenic stroke, PFO, and other underlying etiologies. So over to Dr. Hastak.
Thank you, Chairman and the chairpersons, and thank you, Dr. Gaurav and the team, for inviting me. Friends, as I always feel that, you need to go from the unknown to the known, and I think cryptogenic stroke is a big unknown, and to move to the known is the challenge, and that's the challenge of life as well. So I think this is a challenge we face in life, and of course, whatever we face in life, we face in stroke as well. So I think hidden causes of cryptogenic stroke, PFO, and others is my talk today. So of course, medicine is the science of uncertainty and the art of probability. So I think, life is not deterministic as much as we think. It's more probabilistic. But the problem is our brain has a difficult time grappling with this idea of probabilistic life and non-deterministic life. So if you see the news, it feels as if everything is deterministic and everything is negative. But that's not true. And this is also not true for cryptogenic strokes. But of course, there is uncertainty in medicine, and there is always a probability of what is happening to your patient. So my talk will focus on 1, cryptogenic stroke, 2, ESUS, which is embolic stroke of undetermined source, and 3, PFO. And of course, as the chairman himself said, about 25% of ischemic strokes are still cryptogenic. It was, when I started practice 30 years ago, it was probably about 45%. And in fact, if you see the discharge cards of some of the hospitals, it would feel like 100%, cryptogenic. But because they don't mention the mechanism of stroke at all. And I think this has been our endeavor that, on your discharge cards, try to put up the mechanism of stroke. If you have understood the mechanism, please put it up. So that was one of the messages I would like to give the audience, that please put up the mechanism on the top. If you feel it is lacuna, put it up. If you feel it's cardioembolic, put it up. So let's not have this thinking of cryptogenic, try to break down cryptogenic. And but about 25% still remain cryptogenic. It's probably 20 to 25% now. So cryptogenic has a definition, of course. Post-standard vascular, cardiac, and serological workup, brain infarction not attributable to small artery disease, large artery atherosclerosis, or cardioembolism. I mean, this is the classical TOAST classification definition, and it holds true today. And of course, the definition of cryptogenic is a negative definition, not a positive definition. That's bad, but that's how it is. The possible mechanisms of cryptogenic which may be missed are cardiac. I think number 1 is cardiac. And I think it's cardiac to some extent, but yes, cardiac. Paroxysmal atrial fibrillation, PFO, ASD, and VSD. Of these, I think paroxysmal AF and PFO are the big ones. They're the big guys. Aortic atheroma dissection coarctation. Not such big guys, but yes, they are there. Arterial disease, and I think Darshana spoke very nicely on this, is large artery disease, which is less than 50%. I think this is again the big guy. This is the big guy. And this is the big guy which probably we need to break down from cryptogenic to a non-cryptogenic. And this is based on the vessel wall imaging. Then, of course, dissection can be missed unless you look out carefully for it. Prothrombotic states, APLA, occult cancers. Occult cancers can be, missed completely as cryptogenic. And we have, in our own experience, missed at least 3 patients who were occult cancers initially, only to find that they were actually strokes which were because of cancer. And the D-dimers can sometimes help you in this scenario. Of course, if you do a PET, whole body PET, then you're very clear. But if you don't want to do a massive investigation, you can do a simple D-dimer. If it's very high, it could suggest an occult malignancy, especially in someone who's old, losing weight, and having other features. The other thing is, of course, RCVS, vasculitis, FMD. That's to complete the list of cryptogenics. The other way to look at the mechanism of stroke is related to age. That means the mechanisms which you may miss is related to age. So if your patient is less than 45, dissection, cardiac defects, procoagulant states, and of course illicit drug use, migraine. But of these, I think dissection and cardiac defects are the big ones. In between 45 and 60, it's premature atherosclerosis, and greater than 60, it's occult AF and atherosclerosis. Again, the atherosclerosis is less than 50% stenosis, and you might miss the unstable plaque or the hemorrhagic plaque or the plaques which Dr. Darshana spoke about. Rare genetic disorders like Fabry's, Cadus-Hill, sickle cell, again to complete the list. Think of atrial cardiopathies apart from atrial fibrillation. That's the other thought I have. And if you have patients with left atrial enlargement, so when my doctors talk about the 2D echo, I usually ask them, what's the left atrial size? Is it more than 4.6 or is it less? And what's the size? Look at the size. If the size is big, think of atrial fibrillation. Think of doing a long-term monitoring for your patients. When do you do longer-term monitorings than the standard 24 hours Holter stuff? When I would do when the left atrium is enlarged, or there's some atrial fibrosis, or you have an increased P-wave terminal velocity in V1. I would do a long-term monitoring and look out for the atrial fibrillation, or if there's an elevated NT-proBNP. Now, these are, of course, indirect markers, but they can be useful in the clinical situation. And especially if you find the type of imaging suggests a cardioembolic stroke, so you have a large infarct, cortical, and you think that this could be cardioembolic, look out for these markers. And of course, now there is the new kid on the block, which is the iWatch, or the watch, which is, there's a very nice study from Basel, from Switzerland, on these watches, comparing all the watches, because I don't have an iWatch, but there are others, and there's a Samsung watch. And of course, there's a Fitbit, So I think, how many in the audience have an iWatch here? Yeah, I think I'm seeing two hands, 3 hands, yeah. So the iWatches are some of the things that may come out for monitoring. And I think there is a study from Basel suggesting they have a pretty good specificity and sensitivity to pick up. And even the Samsung and the Fitbit also is pretty good. So you're looking at newer ways too. So these days I tell my patients, you want to, instead of doing that 14 days Holter or the 30 days Holter, just buy an iWatch. Or if you're not that fastidious, just buy the Fitbit. And you'll probably be able to look at atrial fibrillation for a long period of time, because the watch is there all time. It's like an all-time monitor. So I think that's one of the ways to go. And this is a very nice study from Basel on comparing all these watches, and even the Fitbit looks as good as the iWatch. Though the customer satisfaction is great with iWatch. But that's another way to look at atrial fibrillation. The substenotic large artery disease, less than 50%, have the risk factors which Darshana spoke about: plaque ulceration, plaque thickness, intraplaque hemorrhage, fibrous cap rupture, lipid-rich core. And I wish we come out with a good score to tell us that this is a high risk or this intermediate risk, or this a low risk on the substenotic large artery disease. Now, studies are suggesting that proximal vertebral artery disease may be responsible for a large number of brainstem disease, or brainstem strokes rather. So I think, when you look at the vertebral artery origin and see some stenosis, in the past I had a tendency to say, this is nothing. Leave this alone. I don't think this is the cause of the stroke, but it may be. And maybe we are neglecting this vertebral artery origin, and we need to look at it more carefully. The clinical features of cryptogenic stroke, of course, cortical involvement is much more frequent. At least large cortical or subcortical is the usual type. The severity of the stroke is milder than cardioembolic and worse than lacunar. The recurrence rate on cryptogenic doesn't seem to be as high as the non-cryptogenic. So if you know nothing about the stroke mechanism, the recurrence rate is not that high, which is a little surprising, but at least reassuring. So if you have a cardioembolic, recurrence is high. If you have atherosclerotic large artery, recurrence is high. Aphasia, faciobrachial syndromes are more common than involvement of the entire hemibody. And the pathological studies, which is interesting, of clots have suggested embolism in most of these cases. And in fact, we'll come to ESUS, which is embolic stroke of unknown source, which is essentially embolic. Clues as to the mechanism of stroke from the brain imaging are that if you have an isolated superficial cerebral, cerebellar, of course, large, mostly large, are embolic. If you have a cortical, subcortical, multiple territories, it's embolism from heart, aorta. Of course, this cortical, subcortical, multiple territories, I have also seen in patients with occult malignancies. So you get these infarcts in multiple territories. I'll usually do the D-dimer and look out for malignancy. The infarcts of varying age, but single vascular territory, you have one which is old, one which is new on the MRI, and this would suggest large artery disease. So here I think you look at the plaque much more carefully and not just go by the degree of stenosis. You show a watershed infarct, you have, of course, low flow mechanism. Small subcortical infarcts, less than 1.5 centimeters in size, you think of small vessel disease, it's the standard definition for lacunes. So evaluation of the cryptogenic stroke, the standard one is, of course, brain imaging, vessel imaging, the transthoracic echo, the ECG to 24 hours Holter. That's standard. In case this is negative, we would usually do a comprehensive workup, which would include the transesophageal echo. And of course, the transthoracic echo shows you the left ventricle. So it's great for left ventricle or for the ventricles in general. And so clots in the ventricles are seen better on the transthoracic. Whereas the transesophageal is much more useful for the atrium and the aorta. So if you're looking for atrium and aorta, do the transesophageal echo. And if you're looking for the ventricle, so you have an acute myocardial infarction patient who comes in with a stroke, of course the transthoracic is better and no need for the transesophageal. And of course the transesophageal echo should be done with color Doppler study, agitated saline injection with Culf and Valsalva for PFO and shunts. I think Arvind is the expert in that area. And prolonged Holter monitoring, usually now we tend to do whenever we have a higher risk patient. That means you have a patient, you think about atrial fibrillation. He has a large cortical infarct or he has multiple cortical infarcts, no arterial disease. We do prolonged Holter monitoring, 14 days. But I think the watch, the iWatch or the Samsung watch is probably going to take over this quickly. Cardiac imaging with MRI, CT scan, IADSA, arterial wall imaging, which is what was spoken about, and procoagulant workup. The concept of ESUS is basically embolic stroke of undetermined source, is a subset of cryptogenic stroke where the stroke mechanism is most likely embolic. So here what you're trying to do is you're trying to get a subset, which is about 70 to 80% of cryptogenic strokes, which are embolic in origin. And the idea is, the definition is, of course, that ESUS is a non-lacunar stroke, obviously, no large artery disease, and no cardioembolic source. So if you have followed these three criteria, then the idea was, of course, to subgroup these so as to check out for anticoagulation. Because whenever you think of embolism, you think of anticoagulation. So the idea was to get this group out of the cryptogenic to try and think about whether anticoagulation is better than antiplatelet agents. That's the idea of ESUS. So then, of course, the trials on ESUS, the Navigate ESUS and the Respect ESUS, and of course now the Atticus trial. So there are 3 trials on this: Navigate ESUS, Respect ESUS, and the Atticus. And the Navigate ESUS was 7,200 patients. It compared rivaroxaban with aspirin, no additional benefit of rivaroxaban as compared to aspirin. Respect ESUS was 5,300 patients comparing dabigatran to aspirin, no additional benefit of dabigatran compared to aspirin. And the Atticus was the apixaban trial, and a little different methodology. You can read the trial, of course, and of course no additional benefit of apixaban over aspirin. So now both these trials, and now of course the Atticus. So 3 trials negative on ESUS. I'm sorry, I'm not seeing a timer, but is that 5 minutes more? Yeah, thanks. So both trials were negative, and of course the 3rd trial, Atticus, is negative, which really tells you that ESUS is not a simple cardioembolic mechanism. It's probably way beyond, and there are multiple mechanisms even in ESUS. So you need to sub-classify ESUS as well if you want to separate the ones that would respond to anticoagulants versus antithrombotics. Okay, treatment of cryptogenic stroke, try to find the mechanism of stroke, target it. The acute therapy of cryptogenic stroke is no different from acute ischemic stroke. IV thrombolysis, mechanical thrombectomy. Secondary stroke prevention is standard as thought about. The PFO, I will quickly go through the PFO. Ostium secundum defect, PFO is present in 25% of normal population. PFO is seen in 40 to 50% of cryptogenic stroke. So there must be something in the PFO. It's not always a bystander. So the $1 million question is incidental, risk factor, or cause of stroke. So the potential stroke mechanisms in PFO is a venous clot which traverses the PFO, in situ clot formation within the PFO, and atrial arrhythmias. These may there may be, of course, coexistent other atrial anomalies with the PFO. And I think the key one is the atrial septal aneurysm. So I think whenever we see a PFO, we'll usually ask the 2D echo person whether you are actually seeing some atrial septal aneurysm and something moving in the wall suggesting a thrombus, of course. The PFO closure, and this is something that's come up over the last 3-4 years, is that you select patients based on the following criteria. And I think the number 1 criteria is age. So I think if you find a PFO in me, please don't try to close it. So 60. So age less than 60, embolic stroke topography. You know, this is important that you understand the topography of on the MRI. So if you're seeing an embolic stroke, that means a large cortical infarct, you know, or a subcortical but large infarct. You know it's an embolic topography, and that's the second criteria. There are criteria from Pascal classification which incorporates the previous Rope score. So we used to always think of the Rope score. But now there's a classification called Pascal, and I'll come to it quickly. No concurrent indication for anticoagulation, no other mechanism despite comprehensive. So here's the standard Rope score, and I think everyone knows the Rope score, so I won't go through it. But here is the Pascal classification, which includes the Rope score. So what the Pascal classification essentially does is that it includes features which are from imaging and includes a Rope score to give us a better validation of what we could do. And I think here I just want to insist upon one thing. So probably by the Pascal classification, anyone below 60 whom you don't know the mechanism of stroke and who you have investigated enough, you would probably take him for closure unless he has a small shunt PFO. I have underlined, and the unless is only that. A small shunt PFO without an atrial septal aneurysm, and the Rope score is low. That means less than 7. That's the only guy you'll leave out. All the other guys, you'll take them for closure. That's interesting. The Pascal sort of is trying to tell us that, close every PFO, other than those guys who have a small shunt PFO without an atrial septal aneurysm. I don't think there's a classification for the small shunt, which I think maybe we'll ask Arvind, about that. The initial trials were negative. So the closure, PC, respect, these were negative trials for the PFO. And the later trials are positive. Respect, which is extended follow-up, reduced, close. And now the newer trials suggest a number needed to treat of approximately 30. Why initial trials were negative and now positive? Off-label PFO closure has waned over time, allowing more patients who are more likely to benefit in the trials. Better imaging ruled out lacunes, longer follow-up, and high-risk PFO selected, large shunt ASA. So I think the PFO closure, I think the adverse effect you really have to worry about is new onset atrial fibrillation, if you ask me. The rest of them are very rare. You can forget the rest as of now. PFO management is standard. I would not go into that. And of course, I would end with this slide that artificial intelligence in cryptogenic stroke. So artificial intelligence is coming everywhere. So I think soon our brains will become redundant. The artificial intelligence in cryptogenic stroke, the future. And this is in the European Journal of Neurology. Machine learning algorithm was used. 800 patients of cryptogenic stroke with ESUS. 4 clusters were identified by a data-driven algorithm: arterial disease, arterial cardiopathy, PFO, and left ventricular disease. And surprisingly, 50% of these were in the cluster of arterial disease. So where we are missing is arterial disease, and that's where the imaging of the wall is important. And where AI will take us shortly, and this is the image which was created by an award-winning artist, Pinder van Herman, with the help of a robot. And the robot, guided by the AI, spent 22 hours and 13,000 brush strokes to create a self-portrait of itself and the artist. So soon we'll have generative AI and creative AI. And I think that's what's going to transform cryptogenic stroke. Thank you very much.
Hello. Let's call the next speaker. So now we have a second lecture, which will be discussing basically role of cardiac MRI in cryptogenic stroke. So we have Dr. Vimal Chako to enlighten on cardiac MRI, its diagnostic and therapeutic value in cryptogenic stroke. So Dr. Vimal Chako, he is Assistant Professor of Radiodiagnosis and Intervention Radiology. He is presently affiliated to St. Johnson's Medical College, Bangalore. He has experience of 4 years. His areas of interest are cardiac imaging, intervention radiology, and he has many achievements in his name. He has received various awards for it. So I would like to invite Dr. Vimal Chako. Please present your lecture. Thank you.
Thank you, Chairpersons. So my talk will be in the role of cardiac MRI in cryptogenic stroke. So as Sir has already mentioned, he's given a great talk on the cryptogenic stroke. He said around 25 to 30% of ischemic strokes are contributed by this cryptogenic stroke. So the role of cardiac imaging is because a great subset of it is thought to be cardioembolic in source. So the first imaging test and the first line imaging is always usually transthoracic echo, but even after transthoracic echo, with its limitations, a great majority of them still remain cryptogenic. So the role of sequential cardiac imaging, again, for diagnosis of these strokes, which remain cryptogenic after transthoracic echo, the role is not well established, and usually what is done is transesophageal echo after a negative transthoracic echo. Now, I'll be discussing on the role of cardiac magnetic resonance in the role to detect these cardiac aortic embolic sources of stroke. And in my talk, I'll be just showing some specific pathologies which can be picked up better in cardiac magnetic resonance. Also, the various studies which support the role of CMR in cryptogenic stroke, some of the current guidelines, and where we are with cryptogenic stroke. And I hope to convert some of you to use cardiac magnetic resonance in appropriate clinical scenarios. So like MR in anywhere in the body, the advantages are its good spatial resolution, a very good tissue characterization, especially the myocardial tissue characterization. Also, its 3D imaging 3D multiplanar imaging abilities, as well as its ability to image the entire thoracic aorta, where imaging modalities like echo have certain blind spots. And like in other parts, the disadvantages include the gadolinium exposure. It requires a long acquisition time. Cardiac MR, normal protocol would take approximately 45 minutes, which would not be very ideal in a patient with an acute stroke or in the immediate setting of an acute stroke. And also you need a cooperative patient. You need multiple breath holds of at least 10 seconds throughout the study. And it is also, the cost benefit is also has to be taken into consideration. However, in spite of all these limitations, we have a large volume of data which supports CMR as a gold standard in assessment of ventricular volume and function, as well as in assessment of myocardial viability, fibrosis, scar, and myocardial damage to any cause. Other things in which CMR is a gold standard is for cardiomyopathies, the evaluation and characterization of cardiac masses, and also for intracardiac thrombus, along with echocardiography. Also, vessel imaging, including the aorta, where you can have atheromas, which can be a contributor to cardioembolic stroke, can also be assessed by CMR. So going on to some specific pathologies. So the first one I'd like to talk about is the left ventricular thrombus. Again, you have a large body of data which suggests that CMR is a very good candidate to identify LV thrombus. It is seen that in certain studies, it is even better than transthoracic as well as transesophageal echo for LV thrombus detection. So the various sequences we use in cardiac MR are the cine imaging, as well as perfusion imaging. But the most important sequence is this LG, which is late gadolinium enhancement, in which you give a contrast, a gadolinium-based contrast, and then image the myocardium after 10 minutes. So in that, the concept behind that is a normal myocardium would take up the contrast and wash it out by 10 minutes, whereas a damaged myocardium with fibrosis or increased extracellular volume would retain this contrast and would appear bright in it. And the thrombus would appear as a dark, hypointense area against this background. You also have certain other methods in which to make this thrombus more prominent, like an increased TI, which can pick up even smaller thrombi. So these are two-chamber images, again with a cardiac thrombus at the apex being a blind spot for a transthoracic echo. You can see the hypointense area against the enhancing myocardium, which is probably infarcted. And these are a spot image of a cine image, again showing a filling defect in the apex of the left ventricle. Also, with regards to left atrial thrombus, traditionally transesophageal echo is considered gold standard, the probe being quite close to the left atrium and the atrial appendage. However, studies have shown that CMR can be used as an alternative, especially in those patients with contraindications or who don't tolerate transesophageal echo. Here again, the sequences are same, and the important sequence is a late gadolinium enhancement, in which the thrombus would be seen as a filling defect in the atrial appendage. Here you can see a thrombus sitting right at the mouth of the atrial appendage. Others indications where cardiac MR would be beneficial in treatment is the left-sided cardiac tumors. Usually these are benign, and the most common ones are the myxomas and fibroelastomas. And these also have a significant risk of stroke if patients have these. The probable etiologies being an embolism of the tuber fragments or a tumor thrombus around the tumor itself. And again, here CMR is a gold standard for characterization. Echo might pick up these lesions. However, there is always a doubt between a tumor versus thrombus, and also the characterization of the myocardial mass is better done by a cardiac magnetic resonance. So this is one case in which there was a large mass. This was easily picked up on echo. These are not always this large. Here, the top images, you can see that there's a large mass in the left atrium, which is like kind of protruding into the left ventricle. It is hyper intense on T2 and in T2 fat suppressed, and kind of iso intense to the myocardium in the T1 images. And these are two frames from the cine sequences in which you can see that this mass is mobile, quite mobile, and it is plopping into the left ventricle in systole and diastole. And the most important sequence, the late gadolinium enhancement, shows heterogeneous enhancement of this lesion, as well as peripheral enhancement. And this concludes that this is a left atrial myxoma. The importance being that tumor versus thrombus is a very important differential to make because the treatment is quite different for both of these. Another area where CMR scores is the evaluation of cardiomyopathies. Several studies have shown that cardiomyopathy is an underlying feature in many of the cardioembolic stroke. In this case of the most common being the dilated cardiomyopathy, where you have LV thrombi forming within this dilated hypokinetic or akinetic myocardium. There are two advantages of CMR in this setting. One is DCM can be due to multiple causes, including idiopathic or an ischemic or certain specific causes like sarcoidosis or sequelae of myocarditis. All of these certain imaging features in cardiac MR can give a clue to the specific etiology of the DCM. Also, we can pick up these small thrombi which can be present in an akinetic segment or in a globally dilated left ventricle, which may again be missed on echocardiography. The other cardiomyopathy is which can cause stroke is the left ventricular non-compaction. It's a rare genetic inherited cardiomyopathy. It is a failure of maturation of the myocardium. As you can see that in these images, the myocardium appears quite trabeculated. You have two layers, a large trabeculated and a non-trabeculated myocardium. It's not always this obvious, but it can be subtle and just limited to the apex, in which the transthoracic echo might just, either it might miss it, or it might just appear as some subtle thickening at the LV apex. And this also is a potential source of LV thrombi and cardioembolic stroke, and which might be cryptogenic if CMR is not done. Another advantage is that the late gadolinium enhancement also shows delayed enhancement in these trabeculae, which again has prognostic implications for the patients. He can progress to dilated cardiomyopathy as well. Other cardiomyopathies have also been shown to cause cryptogenic stroke. These include hypertrophic cardiomyopathy, especially in this case where it is only apical, limited to the apex, which again is a blind spot of the transthoracic echo. Patients with HCM are seen to have a very higher chance of AF and also formation of thrombi within the cardiac chambers. Other restrictive cardiomyopathies, including cardiac amyloidosis, as in this case, where you can see concentric hypertrophy of the myocardium, as well as pleural effusions. Also, the delayed enhancement, which picked up the diagnosis showing diffuse subendocardial enhancement. Another cause of stroke as well as restrictive cardiomyopathy is the endomyocardial fibrosis. This is again a very florid case in which the RV apex is completely obliterated by this thrombus and fibrotic tissue. Delayed enhancement again shows this enhancement along the subendocardial surface with a small thrombus sitting on top of it and a potential source of embolism. And the calcification is quite obvious in CT as well. So these are some cardiomyopathies which can cause cardioembolic stroke in certain settings. So this study, which looked into the role of cardiomyopathies in stroke and the role of CMR, found that 7% of the patients were identified to have cardiomyopathy, of which there were HCM, RCM, and LV non-compaction as these cases which you've seen before. And so due to this underlying cause of cardiomyopathy being one of the contributors to a cryptogenic stroke, CMR should be considered in appropriate settings. Another hot topic is this atrial cardiopathy, as Sir has already discussed. So there necessarily need not be atrial fibrillation to cause thromboembolism. And although there are certain markers on echocardiography which can suggest this diagnosis of cardiomyopathy, atrial cardiopathy, CMR, by visualizing the enhancement of the atrial wall as seen in this image, you can get a definite diagnosis, and this might even precede gross left atrial dilatation. So in clinical specific settings, the presence of a left atrial enhancement, which is not as easy to pick up as left ventricular enhancement because of the thin walls, but still it is there, and you have dedicated softwares for this as well. So the presence of this could suggest an atrial cardiopathy and a cause for the cryptogenic stroke. And this study again looked into this CMR and the role of atrial fibrosis. It showed that these patients with ESIS had almost similar amount of atrial fibrosis as that of patients with atrial fibrillation, and also more than that of controls. So this could possible hypothesis that it is a causal pathway for cardioembolic stroke, which could be independent of atrial fibrillation. Another area of in which CMR is important can be helpful is the imaging of the thoracic aorta and the aortic atheromas. So these complex atheromas, which is more than 4 millimeter, ulcerated, as well as having mobile components, these can be picked up in along with a comprehensive cardiac CMR protocol in which you image the aorta as well with these black blood sequences, in which the atheroma is standing out. As you've seen, it's all similar to what you see in the carotid. The advantage over echocardiography is because in spite even the transesophageal echo, there can be certain blind spots which are missed, and because the CMR is a comprehensive evaluation of the entire thorax, you can pick these up which are missed on the echo as well. Another cause for cryptogenic stroke is the aortitis, in which stroke can occur due to multiple mechanisms, including the involvement of the valves. As you can see here, you have regurgitation both the aortic as well as the mitral valve, as well as involvement of the myocardium with late gadolinium enhancement in one segment. Also, being the comprehensive imaging modality it also picks up the thinned out aorta with wall enhancement, which indicates an active disease. The area of PFO and septal aneurysm, it is the turf of the transesophageal echo. However, when you do a CMR in a setting of cryptogenic stroke, if you pick up these certain findings like an atrial septal aneurysm, which is quite commonly associated with a PFO and can be easily picked up on CMR, which is seen as a bulge of the left interatrial septum towards the right ventricle, again depending on the pressure of the atria. Also, other imaging findings are the turbulence across this due to a jet in cine imaging, and in a first pass enhancement, if during Valsalva there would be a streak of contrast if there was some shunting across this. So all these findings, though CMR is not the diagnostic modality, if present, could indicate the presence of a PFO, and you can go on ahead with subsequent evaluation. Another thing is the atrial septal defect, not the primum and secundum ones, the sinus venosus ASD. These can also be missed by echo because these are quite high up at the insertion of the SVC into the atrium. The defect is quite high up, and also it is associated with an anomalous, usually associated with an anomalous superior venous drainage. All of these which can be picked up on cardiac magnetic resonance. Other minor diseases which can also, some indications we can get from CMR are the left-sided valvular disease, like in rheumatic mitral stenosis, in this case in which the valve leaflet is thickened, there is restricted mobility. Also the planimetry at the region of the valve orifice could give you an idea of the severity of the mitral stenosis. Pulmonary AVFs also important cause of stroke in the young. Again, CT angiography is a primary modality for diagnosis. However, MR angiography also plays an equally good role in diagnosis. The importance of this is because it can be treated. It's a treatable condition in young after you can endovascularly embolize these AVMs, after which the cause is completely treated. So cardiac MR angiogram, which can be done along with the CMR protocol, can detect the presence as well as the feasibility of endovascular intervention in these cases. Lastly, some findings you can suggest certain prothrombotic states, like in this case, where a patient presented with stroke, echo was done which showed some mass in the right atrial anterior free wall. On CMR, it was done to characterize the lesion. It showed this lesion sitting in the anterior wall, extending into the right ventricular outflow tract into the proximal pulmonary artery. Also, there was a small lesion in the aortic valve, and these lesions on characterization with they were hyperintense on T1 and showed only some peripheral enhancement on delayed imaging, and so they were characterized as thrombi with CMR. There was also a small thrombus sitting in the aorta as well. So the presence of these thrombi in both the right as well as left chambers of the heart gave a clue towards a prothrombotic state for which specific investigation was done. And finally, this patient was diagnosed with APLA secondary to mixed connective tissue disease. So various studies on CMR. This study looked at the feasibility of CMR to detect these cardioaortic sources. It was seen that, that with routine diagnostic workup, cryptogenic stroke was present in about 27%. With the addition of CMR, there was a 26% reduction in the rate of cryptogenic stroke. 6 patients were correctly diagnosed for the cause of the stroke. There was also reclassification of 3 patients based on additional criteria like a transmurality of a scar in more than 3 segments with hypokinesia A kinesia, which are shown to have high predilection for emboli and cardioembolic strokes. Another study which showed direct head-to-head comparison of MRI versus TEE, this study showed that in 6% of the people, cardiac MRI picked up additional findings which was missed on transesophageal echocardiography, and the degree of agreement was not quite high between transesophageal and esophageal echo and cardiac MR. So this gave an implied that cardiac MR, it cannot be replacing transesophageal echo, but it could play a complementary role in detecting some diseases which are not picked up on transesophageal echo. Again, another study, this was a meta-analysis of all the studies, multiple studies comparing CMR to echo. This generally said that there was no significant difference in various pathologies except LV thrombus, which was better picked up on CMR, and PFO, which was obviously better picked up on transesophageal echo. So what do the current guidelines say? So the 2021 guidelines by the AHA and ASA, it gives a 2B recommendation for the use of advanced imaging, including transesophageal echo, cardiac CT, and cardiac MR to identify cardio-aortic sources of emboli, and a 2A recommendation for advanced imaging, including contrast-enhanced echo and cardiac MR, to look for LV thrombus in the setting of acute MI. And in the algorithm, you can see that cardiac MR is including cardiac MR along with cardiac CT and transesophageal echo is quite low in the algorithm. And ideally, it should be there after the routine workup is done and you find no other sources of emboli. Finally, there is this 2B recommendation for advanced cardiac imaging with CMR. Also, this commentary regarding the diagnostic approach again shows that CT and MR of the aorta as well as the heart is part of the extended evaluation after routine imaging is negative. So what is the current role of CMR? It's not high up in the guidelines as of now, but the body of literature is slowly growing. As of now, it is an adjunct to echo, and those patients who cannot undergo echo are not willing to undergo echo. In those patients who are high risk for certain diseases like the LV thrombus, a cardiac tumor, cardiomyopathies, or false negative for echo. And the future directions, there is something called parametric mapping, which does not involve the utilization of IV contrast. So you don't need to give gadolinium in those patients who are contraindicated for gadolinium. And also these ultra-fast CMR protocols, which are in studies now with an 11-minute door-to-door time. Just 2 minutes for the entire protocol, still in the studies phase. And to conclude, cryptogenic stroke, it's only as good as what the testing is, how hard you search for it. But it doesn't mean that you have to search till the end because it has to have some implication in the treatment. Also, there should be that cost versus benefit analysis as well. Always transthoracic echo is the first line, and CMR can be used as an adjunct. It is by no means a one-stop shop because it is not viable to use it in a global perspective. In the future, we could identify certain patient demographics or imaging findings in which CMR can be ideally used. And till then, in these settings, you can use it to pick up additional sources of cardiac emboli and make this diagnosis of cryptogenic stroke a little less cryptogenic. Thank you.
Thank you, Dr. Vimal.
Our next speaker is Dr. Andrej Volny, and he's going to speak on strategies for secondary stroke prevention. Dr. Volny is the Associate Professor of Neurology at the Department of Neurology, University Hospital in the Czech Republic. He has 12 years of experience in neurology and 8 years of experience in stroke. His areas of interest include stroke neuroimaging, neurointensive care, and robotic rehabilitation. He has been the Vice Chair for Research and an Associate Professor of Neurology at the Department of Neurology, University Hospital in Ostrava, as well as a Senior Clinical Researcher at the International Clinical Research Center. He has several awards and publications to his credit. We're very happy to have him join us today.
Okay. Good morning, ladies and gentlemen. It's my pleasure to be here, and the topic of my presentation yes, you can see it, is secondary stroke prevention. I will be talking not only about the secondary stroke prevention in non-cardioembolic strokes, but I will also tackle the cardioembolic strokes and using of the inhibitors of glycoprotein 2B 3A. So I have no conflict of interest. The objectives for most of you, it will be just a repetition. So after this presentation, you will understand the role of platelets in ischemic stroke, mechanism of action of different antiplatelet drugs. I will talk about dual antiplatelet therapy in TIA and minor stroke, and also I will give you some recommendation how to treat patients with major strokes. Also, I will briefly go through the major clinical trials which were focused on secondary stroke prevention in last few years. So it's all about the healthy endothelium. So in case that there is no issues with endothelium, normally there are enzymes on the surface of endothelium which leads to degradation of ATP and ADP to adenosine, and also other factors like nitric oxide or prostacyclin are produced by healthy endothelium. This leads to decrease in intracellular calcium and suppression of the change of the glycoprotein 2B 3A, which is required for binding the fibrinogen. Prostacyclin inhibits platelet function by elevating C-AMP levels. And what happens if there is any endothelial injury? So the first step is platelet adhesion, and as you can see, some of the proteins are uncovered, like endothelin, and many others like von Willebrand factors and collagen, and basically it's a sticky place for activated platelets which then interact with injured endothelium. So many factors like ADP, thromboxane A2, and thrombin are needed for platelet recruitment, and then integrin receptors, and I will talk about drugs we use and which leads to inhibition of glycoprotein 2B3A, which are very important for platelet aggregation. So the most highly common or the commonly used antiplatelet drugs are aspirin, clopidogrel, and ticagrelor. This is just a summary slide summarizing these drugs, its pharmacokinetics and pharmacodynamics, daily doses, which a little bit are different between the countries. As you can see, some of them are prodrugs. And what is important, especially in terms of worldwide use of these drugs, is the resistance. And the major clinical trials which were published regarding the aspirin, so as you can see, the trials using aspirin in secondary stroke prevention were published in late 90s. And these trials shows that early aspirin therapy conferred an absolute reduction in the rate of recurrent ischemic stroke by almost 1%, and also reduced the rate of death or dependency by 1.3%. If we take a look on clopidogrel, so there is strong evidence that long-term use of antiplatelet drug results in significant risk reduction of ischemic stroke, but not only ischemic stroke, but also other cardiovascular diseases like MI or vascular death. Ticagrelor, I would say the newest drug, and two trials published in 2016 and 2020, Socrates and Thales. So ticagrelor in the first trial was not superior to aspirin for secondary stroke prevention, MI or death at 90 days, but the post-hoc analysis revealed some superiority in patients with ipsilateral carotid stenosis. And Thales trial, again, there was no difference in disability, but the risk of the composite of stroke or death within the 30 days was lower with ticagrelor and aspirin group if the patients were treated with this dual antiplatelet therapy. So if we talk about the secondary stroke prevention of non-cardioembolic strokes, as a neurologist, we usually use the term long-term secondary stroke prevention and short-term. So the short-term secondary stroke prevention is usually 3 to 4 weeks after stroke. So the dual antiplatelet trials, which were published in a New England journal in the last few years, showed a clear benefit of dual antiplatelet medication in non-cardioembolic strokes, and it was Chance, Point, and Thales trial. This is just a summary slide, and if you take a look, all these trials used loading dose of both medication, and the primary outcome was mostly the ischemic strokes within the next 3 months, and the combination of dual antiplatelet medication led to significant risk reduction of recurrent ischemic stroke or other cardiovascular risk factors. So this is just a summary of the Chance trial, the Chinese trial using aspirin and clopidogrel. So the primary outcome was any stroke, not only ischemic stroke. So if you take a look, there is a significant risk reduction, 32% in terms of stroke. So this slide just summarizes the survival free of stroke. If you look at the clopidogrel aspirin group, there is a significant reduction of ischemic stroke in following 90 days in comparison to aspirin alone treatment group. Point trial was another trial. Again, patient with event, so you can see that it's a little bit different if you look at the graphs, but again, there was 25% risk reduction in patients taking dual antiplatelet medication to prevent ischemic event within 90 days. If you look here, so these are just efficacy and safety outcomes comparing Chance and Point trial. Again, the outcome was recurrent ischemic stroke, and there is a significant reduction reaching, let's say, 30% risk reduction. Primary outcome in Thales trial was a composite stroke or death. Again, you can see that there was not only the reduction of ischemic stroke or other stroke, but also death from any reason. Again, if we look here, so this is just a graph summarizing the cumulative incidence of the primary outcome and within the first month, let's say, or 30 days, and there is almost 20% reduction of the primary outcome. So Thales and its exploratory outcomes have not been adjusted for multiple comparisons, so we cannot draw let's say, final conclusions. Number needed to treat to prevent one ischemic stroke was over 90. So take-home messages for you. If we talk about the timing, we should initiate dual antiplatelet therapy as soon as possible after the TIA or minor non-cardioembolic stroke. And the duration of the treatment should be at least 3 to 4 weeks. And you have the dosages of aspirin, clopidogrel, and ticagrelor. So how about the short-term triple therapy? So there was one trial, a superiority trial called TARDIS, testing the triple therapy, aspirin, clopidogrel, and dipyramidol. Primary outcome was any recurrent stroke or TIA within 90 days, but there was no difference in frequency of stroke or TIA, but the risk of major intracranial bleeding was significantly increased. So this combination is not recommended for short-term use, long-term use, but there are some trials with dual pathway therapy therapy in secondary stroke prevention ongoing. So if we move forward to 2023, we have another group of medication called oral factor 11A inhibitors. This is just a summary slide summarizing the intrinsic and extrinsic pathway, and you can see two drugs called asundexian and milvexian, which are currently tested or were tested in phase 2A, 2B clinical trials. So the first trial is axiomatic BMS trial testing milvexian, again in combination with aspirin and clopidogrel for 21 days. But within this trial, milvexian failed its primary endpoint. Other trials, dual pathway inhibition trials, was Pacific Stroke, randomizing over 1,800 patients. It's phase 2B, placebo-controlled trial with asundexian. You can take a look at the post-hoc analysis that asundexian 50 milligrams daily provided superior protection against the composite of recurrent stroke or TIA, especially in patients with atherosclerosis. So probably patients who have atherosclerosis will be our target population in the future. Just a summary, the clear benefit of dual antiplatelet therapy was proven, and right now the triple therapy is not recommended, and we are waiting for further data coming from the trials with factor 11A inhibitors. Let me go to the cardioembolic strokes. I just prepared a few slides focused on DOACs, so oral anticoagulants against, again, we have some very effective drugs, pixaban, dabigatran, edoxaban, and rivaroxaban. As you can see here in this summary slide, some of them are direct inhibitors of factor 10A, and dabigatran is the direct thrombin inhibitor. So again, the data came from big clinical trials. So Everose was superior to trial, testing apixaban against aspirin in patients with cardioembolic strokes, and there was a very high risk reduction of stroke or systemic embolism in patients with cardioembolic strokes in the group taking apixaban. So this is very important slide, especially for young neurologists and young physicians taking care of patients with stroke and AFib. So apixaban is definitely more effective than aspirin in cardioembolic strokes, which was then showed that DOACs are as effective as warfarin. As you can see here, so this is the comparison of apixaban versus warfarin. So there was significant risk reduction of stroke and also quite reduction of significant bleeding. So the highlights, NOACs are more effective than antiplatelet medication in secondary stroke prevention in patients with AFib, and at least as effective as warfarin, but some of them has some favorable risk-benefit profile in selected group of patients. Let me talk briefly about glycoprotein 2B3A inhibitors, because this is also important for our clinical practice. I will talk about some evidence if we can use this medication in an ischemic stroke, what is the evidence in terms of combination with TPA and during the EVT procedure, carotid stenting, and so on. So glycoprotein 2B3A receptor antagonists or disintegrins. Right now, we can use tirofiban or eptifibatide in Europe. Tirofiban is the first drug, small molecule, non-peptide and reversible inhibitor. As you can see, the half-life, it's just 2 hours, and onset of action, 30 minutes. It's mostly excreted by kidneys, and if you want to reverse its effect, then you need to discontinue the drug. So current indication of tirofiban, acute coronary syndrome based on these trials, and can we use this drug in stroke? So there are some trials which were run in the past. One of them is Mr. T trial, combination of tirofiban or alteplase. As you can see, this trial was terminated prematurely because of its futility. Intra-arterial tirofiban during EVT, there is a prospective registry in Germany. So basically they use this medication in case of intracranial stenting or after multiple thrombectomy passes, but the dose of tirofiban is not specified. But if you look at the table, there is a significant increase of fatal ICH in patients who were treated with tirofiban. IA tirofiban after failed EVT, again, there is one registry in China. Low-dose IA tirofiban in patients with residual thrombus after EVT, primary safety outcome was symptomatic ICH. As you can see here, there is no significant difference in ICH between the group with and without tirofiban. Eptifibatide, integralin, again, it's a small molecule with relatively low affinity to glycoprotein 2B3A. Onset of action is 1 hour, which is a little bit slower than the first drug. Again, it's excreted by kidneys, and if you want to reverse the action, then you need to discontinue the drug. So the current indication, again, treatment of acute coronary syndrome, managed medically or with PCI. And let's take a look if we have any data. So there was a clear group of trials, eptifibatide in a combination with TPA, published in Stroke in 2013 and 15. As you can see here, it was a relatively small study with only 27 patients. Ongoing trials, eptifibatide and TPA, and eptifibatide and endovascular treatment. So the first one, it's MOST trial. I checked on the clinicaltrials.gov. It's still recruiting, so the patients are randomized to argatroban or eptifibatide versus placebo in combination with standard dose of TPA within 3 hours of symptom onset, and the primary outcome is 90 days MRS. The second trial, EPOCH, I checked the status, and there is just a comment, it's recruiting, it's an open label trial in China. So what does the guideline say? If you look here, so American Association Heart and Stroke Guidelines published in 2019 and ESO guidelines published in 2021. So eptifibatide has some RCTs with reduced doses of IV alteplase with no significant increase in ICH. Tirofiban, there is no RCT as an adjunct therapy to IV alteplase. So key points for tirofiban and eptifibatide: conflicting results regarding symptomatic ICH. Most, I would say all the studies are underpowered to show efficacy. Tirofiban and eptifibatide may have a role in treating reocclusion during EVT, in acute intracranial stenting or angioplasty or emergent carotid stenting, but we still need some data. So I will be happy to answer your questions, and thank you for your attention.
Thank you. Thank you, Dr. Waldani. We'll have the questions after the session is done, so we'll ask all the speakers to stay. We move further from the presentations to the very unusual stroke scenarios. The point is that the time limit for the case is 10 minutes for each cases, and there are 3 speakers in this session. I would like to call upon the first speaker, very good friend, Dr. Thomas IP, to be on the dais for recurrent strokes, my case experience. Can I have the CV for Dr. Thomas IP? Dr. Thomas IP is the professor and head of neurology at Government Medical College, Thiruvananthapuram. 32 years of experience, and all know his interest is stroke, neuroinfection, cognitive neurology. very hardcore clinician, and he's the Best Doctor Award, Government of Kerala Medical Education 2011, and he's Teachers of Teachers, Medical Master Teacher Award for 2020, Shine 2020. Dr. Thomas Hype.
Thank you for giving me this opportunity. This will be more of a practical thing than a theoretical one. We have a 72-year-old hypertensive diabetic who had ICAD. He had recurrent stroke on medications. See, as we all know, the commonest cause, or one of the common causes, is the lack of compliance, or some others call adherence. Even yesterday, we know all patients will say they are very adherent. But when we really look into it, patient may not be adherent. For example, yesterday, one patient had base of skull osteomyelitis. Patient was on antibiotics and morphine for severe headache. I just asked him whether he was on medications regularly. He said, yes, perfectly all right, I'm taking all the medications. Then I just remarked that morphine is not a good drug for headache. Immediately the patient and the caregiver said, I'm not using morphine. So then that's the situation. The ground reality is that even though a patient says that they are compliant, they may not be compliant. You have to look into the actual reality. Again, yesterday in the outpatient, we had a patient who said she was extremely tired after taking clopidogrel, and she stopped it and the fatigue disappeared. There are many reasons why patients do not take medicines. They have their own reasons for aspirin, for dual antiplatelets, etc. The other common reason is the wrong diagnosis, or we are not detecting, as all the experts have said, it is difficult to identify the actual etiology of stroke. We may be missing large artery disease. This is in the general practice. Extracranial carotid disease, which is more than 50%, may not be detected. Because the patient may not be getting a CT angio, which includes the neck vessels. So these are things that are happening in the community. So they may not be getting the right treatment for prophylaxis, endarterectomy, or carotid artery stenting, or antiplatelets. They may not be reaching the target for LDL or the blood pressure control. And as has already been highlighted today, less than 50% carotid stenosis, the high-risk plaques may not be really identified and intervened. The other common situation is when you have cardioembolic stroke, patient may be having valvular atrial fibrillation. But patient usually the majority of our patients are on subtherapeutic dose of warfarin. Majority. And those who are on therapeutic dose, the time in the therapeutic range will be less than 60 to 70%. Then we have the non-valvular atrial fibrillation, the newer anticoagulants. Because of economic reasons, patient may not be taking the right dose of dabigatran. Patient may be taking 110 milligrams twice daily, or 110 milligram once daily, etc. Apixaban 5 milligram BD patient may not be taking that. Rivaroxaban, etc. Then are we looking at the left atrial appendage or the aneurysms, etc.? Are we going for left atrial appendage closure? Most places do not have the facility for doing that. So that may be the reason why patient may be having a recurrent stroke. And patients on oral anticoagulants, as I've already mentioned, medication errors, the non-adherence, the wrong dose, or some concomitant drugs which promote coagulation, a patient may be on such drugs. Or they may be having additional etiologies for stroke, like large artery atherosclerosis, which may be overlooked because we have already found a cardiac source of embolism. So we may not be very aggressive to look for other causes of other etiology for stroke, and patient may be only on oral anticoagulants. Patient may have small vessel disease, patient may have cancer-associated hypercoagulability in addition to the cardioembolic source. In patients who continue to have cardioembolic, or for example, patient already has a valvular heart disease, patient is on an anticoagulant, patient can develop infective endocarditis. So that may be the cause of recurrent stroke. And as has already been amply highlighted, the atrial dysfunction, looking for N-terminal BNP, the left atrial size, the P wave terminal force, etc., may be important, which we may overlook, or in majority of situations it is overlooked. Again, a patient in the young patients, PFO, as has been highlighted, may be a very important one. And the presence of associated atrial septal aneurysm has to be detected. The size of the shunt, the right to left shunt, has to be estimated by bubble studies, and then it has to be intervened. In the young, vasculitis, whether it is systemic vasculitis or isolated CNS vasculitis, may be one of the causes of the recurrent stroke, even though patient is on antiplatelets, blood pressure lowering agents, etc. Vessel wall imaging may be important, but now we know that even concentric thickening of the vessel wall can occur with vasculitis. It may not really differentiate the the atherosclerotic versus vasculitic lesions. As the ROPE score has already been, and the Pascal score has been highlighted, so we may have to look at the ROPE score or the Pascal score and see that patients with higher risk is treated. Another situation is the capsular warning syndrome. Patient may have a lacunar stroke, patient may be thrombolyzed, may be put on antiplatelets, but still patient may have fluctuations. And that may be another reason for the so-called recurrent stroke. So in small vessel disease, we should be aware of the vascular warning syndrome. The recurrent stroke may be due to recurrence of bleed. Need not be always ischemic. Patient may be having an amyloid angiopathy where patient has ischemic as well as hemorrhagic lesions. Similarly, patients with vasculitis may be having ischemic plus hemorrhagic lesions. And if a person has hemorrhage in the same territory, in the same area, not territory, in the same area, as usual, we should be looking out for vascular malformations. I think I'll stop here and take questions. Thank you so much.
Thank you. Thank you, Dr. Thomas. We call upon the next speaker, Dr. Vimal Bhatia. Dr. Vikas Bhatia. Dr. Vikas Bhatia is the Associate Professor, Neuroimaging and Intervention Neuroradiology from PGI Chandigarh, 8 years of experience. His area of interest are transradial access, stroke, aneurysm, advanced neuroimaging, and preclinical animal intervention studies. He has done randomized trials on stem cell and various other trials.
Thank you very much, Chairperson. So, I'll be showing you a few cases of refractory or resistant clots or a challenging mechanical thrombectomy. Now, we know that mechanical thrombectomy has become the gold standard, but still there are many situations in which we are not able to handle them because there are still no guidelines for them. So refractory or resistant mechanical thrombectomy, they can be because of clot factors or because of the anatomy-related factors. So if we consider the clot factors, it can be a RBC-rich clot, which is relatively favorable for mechanical thrombectomy, but there is still chances of fragmentation of clot which can be seen. Whereas fibrin-rich or white clots, they are actually less deformable, and also there is an increased resistance as compared to the when attached to the vessel, so they are actually difficult to take it out, and we may land up in a situation with refractory mechanical thrombectomy. Other situations can be massive clot burden, calcified clot, ICAD or dissection. I will not be covering ICAD and dissection because many talks are there on this. And we can have situations in which anatomy is challenging for you, where we can have a difficult access, intracranial vessel angulation, or we have a bifurcation clots. So management will require an alternative technique or a strategy, which can be in the form of using a combination of stent removal and aspiration, where particularly for the white clots, or when we have a curved vessel, or we have the pinch the clot technique as described by Dr. Anshu. Or we can have aspiration only, particularly in case of white clots. And if you are going for red clots, then use a balloon guide catheter so that the fragmentation of this RBC clot is less. Or you can use a different stent remover, such as intercase technology stent removers, or a double stent remover techniques, which actually cause reduction in the friction of the clot and the vessel and helps you out to take the clot out. Or you can have a rescue stenting, use of GP2B3A inhibitors or intra-arterial thrombolysis in certain cases. So the first case is a slipping or rolling clot which your stent remover is not able to catch. So this is the case of a 60-year-old male with acute onset weakness for 2.5 hours duration, and this patient had a recent surgery, so IVT was not given. His NHSS was 17 and SPECS was 10. So on this CT angio, we can see there is a occlusion of this left M1 MCA seen here. So we took the patient for mechanical thrombectomy, and you can see that this is the ICA run on the left side, and there is occlusion here. So we took the guider, and you can again appreciate this occlusion in the mid part of the left M1 MCA. So we took the microcatheter beyond this clot, and this is the distal perfusion which was demonstrated, and then we deployed this stent remover across this clot. But even after 3 attempts, you can see that this is not opening. We even tried the push and fluff technique, but we were not able to take this clot out. So in this case, we used a change of strategy. That is, we used combination of aspiration and stent remover, and you can see here that the aspiration catheter is getting engaged with the clot, and at this point we tried to take it out, and you can clearly see here that we can take this clot out, and this clot has not engaged with the stent remover. It is outside, and we could just pinch it out. So these are the scenarios where you can use a different strategy to take your refractory clot out. So in this case, we could open up the vessel, and this was the check CT angio 24 hours with a completely opacified vessel. So another scenario where all may not be enough is a heavy stroke burden, where you can try all the techniques, but you may land up in failure, and I will show you such case. So this was a case of a 35-year male with stroke duration of 4.5 hours. He had rheumatic heart disease with irregular medications, and his NHS was 20. So you can already see on NCCT there was some hypodensity involving the posterior circulation also. There are some evidence of a chronic infarcts in the left MCA territory, and some hypodensity here, which is of recent onset. So on CT angio, we can see this, there's a tandem occlusion. There's a cutoff seen in the ICA in the flame shape. We suspected it may be can be a dissection. Also the left M1 here, you can see it is occluded. So in this case, we thought that it may be a dissection or it can be a thrombus. So we started with aspiration, and while doing aspiration, we took our guider aspiration catheter beyond this occlusion, and we could take out a large amount of clot, and we continued with the aspiration up to the level of MCA origin. And you can see that even after taking a lot of clot out, there was still occlusion at the ICA bifurcation. So again, we used a change of strategy. We used a combination. Here is a stent remover as well as the aspiration in this case. But even after 2 attempts with this technique also, we could not open up this ICA bifurcation occlusion. So we thought we will use a double stent remover technique. So we entered in the left MCA. We took the 2 microcatheters, but you can see that it is entering into a separate vessel. So this case was complicated by, with the presence of a duplicated MCA. So we did not open in the MCA the second stent remover because we thought we were not sure of the diameter of this vessel. So instead we opened this in one stent remover in the ACA, one in the MCA, and also the aspiration was continued with this. And even after doing this and taking a lot of clot, you can see now partially we could open this ACA as well as the PCOM, but still there is some clot fragmentation happening and the MCA was not opened. So again, an attempt was taken, stent retriever was placed in the MCA, aspiration was continued, and we tried to dislodge this clot with the help of wire. We wanted to just dislodge it with the help of wire, and it was done in the ACA also. You can see here, we tried to dislodge it. The stent retriever is still open in the MCA. So this was the final run. Almost 10 attempts with all the known techniques were done, and we could just open it. The PCOM was open, the ACA was open, and we have to stop it here. And you can see the massive amount of clot which came out with each attempt. And even the aspiration tubing was getting clogged again. 2 times it got clogged. It was such a massive clot. And you can see this clot in the double stent retriever also. So these are the situations where still there is no guideline that how to handle these. Maybe a use of a balloon guide catheter or use of an intra-arterial thrombolysis during the procedure may have helped, but it could have resulted in bleeding. So again, this was as expected. The patient developed a massive infarct in this case, even after doing all the known techniques known to us. So the final case is in case of difficult access or anatomy. So you may sometimes land up with these cases. This is a 51-year male with known case of RST with severe MS, and he presented with stroke, and he was a known case of aortic bifurcation occlusion. You can see here, there is occlusion here. And also this patient had repeated cardiology procedures and angiographies, so his radial artery was 1.2 mm. So we could not go via radial access in this case. So this patient presented with this left MC occlusion and also a large thrombus in the left atrium. So in this case, we had to use a different strategy. We went through a transbrachial route. This is a 7F Cook sheath. We took a brachial run and then entered the left ICA here. And after that, this is the microcatheter showing the distal perfusion. We opened the stent retriever and finally got a good result in this case. So sometimes you may have to use a different strategy for these cases. So I will conclude here with these messages that challenging mechanical thrombotic situation may require an alternative strategy and treatment, and sometimes everything you do may not be enough, and future may hold better answers for these situations. Thank you very much.
Thank you, Dr. Vikas, for interesting cases. We'll call upon the questions will be at the last. We call upon the next speaker, Dr. Piyush Ojha. Dr. Piyush Ojha is consultant neurologist and neurointerventionist at Fortis Memorial Research Institute, Gurgaon, India. 9 years of experience, acute stroke, IV thrombolysis, mechanical thrombectomy, SAH, aneurysm, carotid stenosis, secondary stroke prevention is our area of interest. And he got a WSC 2022 Young Investigator Award at World Stroke Congress, Singapore in October 2022. He's a gold medalist for Best Postgraduate Student in 2013 at MGM Medical College, Indore, and Best Postgraduate Student for efficacy of endovascular thrombectomy 2, second prize platform presentation for that paper. We welcome Dr. Piyush Ojha for his presentation.
Thank you so much, sir. Thank you so much for the kind introduction. So, thank you so much, Dr. Gaurav, sir, and Hanshu, sir, for the allowing me to be standing on this stage and present this particular case. So, the reason that I chose this particular name, Devil in the Dark, because most of the cases that we encounter, which we consider as embolic stroke of undetermined source, so we don't know what is the reason going on, and this is such a case that I was a part in management as well. So just a disclaimer before I go to the case that I was involved at certain stages of this particular patient. And then for us, financial and socio-economic constraints play a vital role. And many times the patient, is not able to do a regular follow-up. So he's a 54-year male. He has a past history of hypertension, coronary artery disease without any LV dysfunction. He's a doctor himself. So he was particularly compliant with the medication. He was on tablet ecosprin, no addiction history. In December 2020, he was found to have left side weakness with dysarthria in the morning. And then he was rushed to the ER. As a usual institutional protocol, we activated code brain. So he comes to the department. Our protocol is that we do a CT brain with a CT perfusion and a CT angio. So CT brain doesn't show any significant ischemic changes involving the right hemisphere, but there is an evidence of fold infarct involving the right MC territory. CT perfusion does show there is a large area of mismatch with an M1 MC occlusion in CT angio. The neck vessel non-significant. So it was a wake-up stroke, and we shift him to the DSA lab for mechanical thrombectomy. This is the first run, and single pass. It was a TK2C recanalization without any procedural complications. After that, we evaluated him. His routine blood parameters were within normal limits. His echo did show an mildly reduced ejection fraction of 50%. There was a mild apical hypokinesia without any clots. So we started on him on dual antiplatelets, that is echosprin 150 and Plavix 75, and then he was discharged with minor residual deficits. He was stable for approximately 6 months. He's also started coming back to work. He was a surgeon, so started doing surgeries as well. But one fine day, he developed sudden onset confusion and then had an episode of GTCS at work. There was a staff who witnessed this event, and again he was rushed to the emergency room. Examination was, he had a Broca's aphasia with some weakness on the right side, and NIHS was 7-ish. So we thought it could be a stroke and a postictal deficit. So we shifted him for an MRI brain. So MRI brain did show there was a small acute infarct in the left high posterior frontal cortex, and there small infarcts involving insula as well. His angio, there was nothing significant except for small stenosis, mild to moderate, that we thought involving left MCA, otherwise non-significant. We did thrombolize him, and then his aphasia improved over the course of next few hours. So there are certain slides which I've just prepared just to keep you considering, like what are the possibilities that you would consider and what we thought. So the likely possibilities could here be cardioembolic, it could be vasculitis, it could be hypercoagulable state, and then we need more workup for further assessment. Further course of investigations, Holter, transthoracic and transesophageal echocardiography, vasculitis workup, hypercoagulable, or all of them. So I'll tell you what we did. So we did an EEG because he had a seizure. So there was some sharp activity involving left temporal cortex. Homocysteine was normal, biomarkers negative, and his cardiac markers were within normal limits. Echo again showed an akinetic apex with an ejection fraction of 50%. We also did his Holter monitoring, but no F. So we started him initially on injection Clexane 0.6 twice daily, and then discharged him on tablet Estrom with an iron of 2.1 along with echospin 75. But when you think that everything is going well, there can't be anything which can get worse. We simply lack imagination. So within 48 hours, he comes back to the ER with another episode of GTCS, and again with the right side persistent weakness. So he had right side weakness with a left gas preference, and we urgently shifted him to MRI with the possibility of Torch palsy. But we were wrong. So MRI did show an infarct involving the left MC territory, and it was a DWR flare mismatch. We again shifted him to CT. And there was a large area of perfusion mismatch involving the left MC territory. CT angio, left M1 MC occlusion without any affection of the neck vessels, and we shifted him again for a mechanical thrombectomy. 2 passes, we were able to open the vessel, but during the procedure, there was a dissection involving the petrocavernous segment, and we had to put a stent. We again went and repeated his investigations. 2D echocardiography again showed an akinetic apex with an ejection fraction of 45%, and rest of the parameters were non-significant. We also went ahead and did a TEE for him. Nothing significant except for there was a reporting of something called Lambert's excrescences, which the cardiologist thought that this is not usually a cause for stroke. This time we started him on tablet dabigatran, which was 110 milligram twice daily, along with Brilinta. And we explained the family that there is a very high risk of bleeding in such patients who are on these medications. He had some improvement in his aphasia, and then he was discharged. He was stable for almost 2 months, but again comes to ER with an episode of dizziness, shuffling gait, nothing significant in examination. We repeated an MRI again, and again to our surprise, there was another diffusion restriction. Nothing significant in MR angio except for there was some stent artifact, otherwise it was within normal limits. We again repeated all the investigations. Again, to our surprise, more or less the same condition. So this time, we changed his medication. We started him on Clexane, 0.6 twice daily, and we continued Brilinta, again explaining the family that there is again a very high risk of bleeding tendency. So he was discharged without any new residual deficits. Again, we are hoping that he would not come to us again, but he comes again. So he again had an episode of GTCS, and this time, his wife being a doctor again, it was witnessed event. He was brought to the ER in post-ictal state. Consider our past experiences, we activated code brain. This was the CT perfusion. So there is a large area of mismatch on the right side. We did a CT angio. So CT angio does show a right M1MC occlusion, and when we look at the left side, his left CCA is completely occluded. The left MC territory is getting some blood supply from PCOM circulation. We shift him for mechanical thrombectomy. So it was a tandem occlusion. We opened up the vessel, left side territory starts flowing. So what should be a further line of investigation? Should we repeat Holter monitoring, again repeated transthoracic or transecho, hypercoagulable state workup, or a PET scan? Or we should do all of them? So we repeated a transthoracic echo, more or less the same thing. There was an akinetic apex. His ejection fraction is again 40 to 45%. TCD, no evidence of shunt. We repeated Holter monitoring. This was 48 hours, no F. We repeated D-dimer, which was found to be pretty high. It was 2084. We did other workup, like his blood workup. It is normal, calcium normal, vasculitis panel including ANA, ANCA, normal, all the vasculitis parameters within normal limits. We also did his endoscopy. There was some inflammation involving his rectosigmoid area, but again, it turned out to be just congested mucosa. This time we repeated a PET. So PET concluded there was an enhancing lesion involving the right side of the prostate, and they advised to do his PSA levels. PSA turned out to be normal. So this time we discharged him on Plexane 0.6 BD, Plavix 75 milligram once daily. Since then, we have not heard of him. We are just hoping for the best. So if this patient comes again to us with a recurrent stroke, what would we do? Frankly, I don't have an answer. I'll be repeating probably everything. We might repeat a loop recorder, again thoracic. What I would consider is that it could possibly be a cardioembolic stroke or a paraneoplastic syndrome, because we know that paraneoplastic syndrome can present earlier with a hypercoagulable state and then turn out to be full-blown malignancy. Thank you so much.
Thank you. The session is open to the questions. I hand over to the chair, Dr. Anup Thakur.
Thank you, all the speakers, for the excellent presentations. And I invite all the three speakers, Dr. Hastak, Dr. Chacko, and Dr. Andres, to answer any questions. Is there any question, please?
Dr. Anand. Mike is at the back. Mike is
there.
Please introduce and...
Anand Vaishnav. The question is to Dr. Volney. What about, do you check ever for platelet reactivity or CYP2C19? You know, the PRINT study and then the CHANCE 2. Because that's a gray area. Maybe talk about 30%.
Okay, thank you for the question. So you mean the testing for the resistance? So not, let's say we don't do that in all patients, but in case that we have somebody who had the recurrent stroke and we do all the workup and we want to check up for resistance, we do it in selected patients.
I think the 1 or 2 day halters, again, I think the data with prolonged 30 days and 3 months is also not that great with AF. I mean, correlation with recurrent strokes. But 1 or 2 day halters, I mean, do they really help?
So you want to suggest a loop recorder for that patient?
I would have said it 2 months ago, but I think Lee Schwamm presented a very good data that, you know, I mean, this ESUS construct, I think it's more probably substenotic stenosis.
Yeah, please. Dr. Shirish.
Yeah, so I think it's actually going to follow on quite nicely from the very last comment from the previous questioner, which was that there's some evidence coming out now that suggests many cases of ESUS actually get reclassified as substenotic ICAD when you do vessel wall MRI. And I know that there's quite a lot of people in India doing vessel wall MRI, and that ICAD's also quite common. So amongst our population. So I'm just thinking actually it's potentially a very nice study for Indian diagnostic neuro and interventional neuroradiologists to do, and to actually get confirmation that what we're calling embolic may not be embolic, and it may just be slight encroachment upon a small perforator branch from a substenotic or let me reclassify, from a ICAD plaque that does not cause significant change to the lumen of a vessel.
Dr. Hastak.
Yeah, the question I wanted to ask was MRI heart imaging versus CT heart imaging. Is there a difference? Because there's a cost difference. as between MRI and CT.
Dr.
So,
Vimal Chakur, the question which Dr. Hastak is asked, I will add to it. Is CT angio is better for looking for arch of aorta atheromas, or as you mentioned, that is what my question was. Yeah.
Hello. Yeah, definitely CT. Yeah,
first is the MRI heart versus the CT heart.
CT, yeah.
I mean, what would you and what is the advantage of one over the other, and how does it balance out in terms of cost as well?
CT and MR heart.
For the heart, it again depends on the indications. For the left atrium, the thrombus. For the cardiomyopathies, for cardiac tumors, definitely CMR is better than CT angio. For the aorta, CT angio would be better because you have a better spatial resolution with CT angina of the aorta. But for these specifically for the heart, with specific reference to the thrombi, the cardiomyopathies and the cardiac tumors, definitely CMR would be better because the tissue characterization properties give you, like, you can get a specific diagnosis of the cardiomyopathy, a specific diagnosis of what cardiac tumor it is, and also the confusion between tumor versus thrombus. Again, it's better, much better with cardiac MR versus CT of the heart.
Thank you.
We are running short of time, so it will be last question by Dr.
Yeah. So my query is to Dr. Hastak. Yeah. Are there any differences on imaging in patients who are developing a stroke, cryptogenic stroke versus ESUS?
Yes, of course. I think cryptogenic stroke, which is, the ESUS has a clear-cut embolic, type of imaging. It's a signature of embolism to the brain, which is large infarcts, cortical, multiple, subcortical also sometimes, but again, large. And they're not small infarcts. But of course, this large and small is still open to question. There's no sort of classification on how large and how small. But yes, we tend to think of embolic when they are large, cortical, or multiple, and they think of ESUS. And when they're not, and you don't know the cause ultimately, you think of non-ESUS cryptogenic. Of course, 80%, as I said, are probably ESUS, but ESUS is also having its own problems about sub-classification into ESUS, because that's why the Navigate and all the other trials are negative.
Thank you so much. I'm Dr. Jyoti. I'm an Associate Director in Neurology in Medanta. And two observations, Dr. Vikas Bhatia, when he showed one scan where in the end, there was a large left MCA infarct, midline shift. Sometimes, and also comparing to Dr. Piyush's case, at both the cases, I'd like to suggest something is that sometimes it can be very exhaustive. We go on treating and we get a lot of infarcts, and it is very, 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 very disappointing. But let me tell you, as a neurologist, we have been following these patients very closely in OPD. 3 months, they come on the wheelchair. 6 months, they come with a stick on the walker. 1 year, they survive. All these patients, believe me, the last case of doctor, he's been in touch with me, the family. I know them, how much it is difficult for them to undergo when, you're dealing with doctor's family. Keep doing it, even if you rush every time. Sometimes seizure, sometimes hypoglycemia, sometimes potassium, sometimes sodium, lots of things add. Please go on doing it. They all do well if we intervene earliest at whatever setup we are. Thank you so much.
Mechanism also. Still do for the mechanism.
Yes, sir, thank you for allowing me to ask regarding the last case, which has been managed, I think, so with courage and so much recurrence. What I thought was we should put the causes for a heart attack, find out all the things which are associated with this 52-year-old man who can get AMI, find out the risk factors, then with heart attack, with stroke, probably from arch of aorta to the heart to all the areas what others are also told, to find out a large artery or a cardiac or arch of aorta, and try to see if any rarest of the rare case can come.
Yeah, we have
really appreciate your.
Thank you, sir. So close.
Yeah, we close the session.
Just to comment on that last case, which is fantastic. I think you did a fantastic job. Maybe we should use the algorithm and try to separate out at least the 4 types that had looked at. And maybe look at the algorithm paper, 2020, and see how it pans out and where should you focus on, because you can't have a defocused idea. So maybe use artificial intelligence and go into the algorithm. Thank you.
We'll do that. Thank you.
Close the session. I think now we can close this session. Thank you very much. Yeah, and we can thanks all the speakers for their excellent lecture and co-chairpersons. Yeah, and the audience. Yeah, thank you.
I thank all the chairpersons and the speakers for elucidating this topic of ESA's cryptogenic stroke, how to manage, and all the various cases that we face day to day in our practice. We now have discussion on hemorrhagic stroke. So I call upon the chairpersons for this next talk. We have Dr. M.S. Johri, sir. He is the director of Johri Hospital, Jabalpur, and he has more than 35 years of experience to his name. He is retired from the government NSEB Hospital, Jabalpur. We also have Dr. Thomas Aipe, sir, the professor and HOD of neurology at GMC Thiruvananthapuram. We have Dr. K.K. Bansal, sir, senior consultant neurosurgery with more than 26 years of experience to his name. We have Dr. Srinivasan, sir, senior consultant neurosurgery and HOD of neuroendovascular surgery at Apollo Hospital, Chennai. We ask our chairpersons to kindly take the stage and introduce our speakers for this session on hemorrhagic stroke.
Hello, thank you, Dr. Goel and the team of organizers. I think let us begin the session. And the first topic will be Dr. Girish Baburao. He'll be speaking on cerebral venous thrombosis, exploring challenging scenarios and advanced medical management.
Thank you, sir. At the outset, I want to thank the organizers for giving an opportunity. I think I have 15 minutes of time as per the schedule given. Now, all of us have learned the various aspects of ischemic stroke and especially the feast on management of endovascular and intervention therapies. Now, we have another rare form of stroke, but as neurologists in India, we are very well versed in managing. Now, the difference with this to ischemic stroke, the volume of knowledge available is predominantly observational studies and case reports and registries. So here lies the importance of knowing the difficult to treat and manage the patients in this. So for better introduction, for 2-3 minutes, I will be going through the usual things, what all of us we know, that is a very rare form of stroke, presents with multiple ways to us, and diagnosis is very challenging. Only 50% of the referring physicians know that it is a CVT, and we have 4 lines of management in the medical treatment: anticoagulation, risk factor management, anti-epileptics, anti-edema, and others, very rarely. Because the paucity of time, I will concentrate on anticoagulation. Now, the anticoagulation management, revising, depends upon the 3 pillars of venous thrombosis, and here the predominantly hypercoagulability there. So we have to choose a agent, maintain the anticoagulation, and decide the duration. So these are the pillars of management, and we have host of things available for management: anti-edema, anti-coagulant, and health education forms a very important part of the management. Now, the challenges in IVT, I found that managing a patient who has a hemorrhage in the brain is the most important thing. Now, if you see the guidelines, low molecular weight and unfractionated heparin are the choice of the agents for treating the acute, and the risk factor management will help in prevention of the progression and recurrence. Now, the initial anticoagulation, we depend on heparin, and we all know there are multiple ways to give the advantages, disadvantages. Now, at NIMHANS, we follow this, which is the time tested by our teachers from the last 35 years. we start subcutaneously, convert to oral on 10th, and we use predominantly acinocumarol. This part also has been published in the literature. The acinocumarol we use at NIMHANS for various reasons, and probably this table helps us to understand. Now, the duration from 3 months to 1 year in majority of the patient, and in some patients who have issues of procoagulant or more than 2 CVT, we use for a longer duration. Now, the next trend is use of newer oral anticoagulants, and we have a lot of agents, and all of us know the advantages, disadvantages, and the various trials and the registries and the ongoing trials thing. So after summarizing all these things, I will go through the challenging cases. Now, I divided all the cases from the last 20 years I have seen at NIMHANS to these 3 headings. The challenging cases with respect to anticoagulation, the challenging cases with respect to anti-edema, the challenging cases with the anti-epileptic. The more common we see, the uncommon we see, and rarely we see, but it will have a major impact on the outcome. So what I have realized over time is identifying this group of patients is very important, because as I have told you, 95% will improve totally, 5% will have a mild, 90% have a good recovery, 5% will have disability, and 5% die in our wards currently. Now, among the various things, I thought that perioperative management, the use of anticoagulation in the presence of ICH, the issue of recanalization and the anticoagulation, pregnancy, the menstrual bleed and DUB, and in the presence of SDH and Behçets, I will discuss. Because of the lack of the time, all these things we will not be able to discuss, but if any doubt is there, always happy to the answer to the question. Now, this patient is a young fellow who has history of CVT going on from 15 days. And as all of us know, we are very comfortable in converting to injectable to oral. So this patient was converted to oral, and within 2 days, he develops these new symptoms of worsening. Now, what to do? So this is the important aspect which we have to see in around 5 to 10% of the patient who progress for requiring surgery. Now, the most important is whenever we have a patient who has a lesion in the areas where it can herniate, or a large supratentorial lesion, preferably until the midline shift comes down, we should make sure that we use the parenteral heparin, depending upon your area or your place, whether it is a unfractionated where we use at NIMHANS, or using low molecular weight. The only advantage of unfractionated is we have a reversal agent which can be given very fast, and we use subcutaneous, so it is easy for us. The other important thing is use of heparin will also help in prevention of the DVT, because this type of sick patients will be having a risk of DVT. Now, the various options, supposing this patient was subsequently taken, we have 3 options now. One is vitamin K, we have prothrombin C complex, concentrate, and cryoprecipitate, and all of us should know what are the effect time it takes for them to act, and also on the cost and the number of the units. In this patient, we used fresh frozen plasma and vitamin K, and luckily he gave us a 2 days time, and he improved, and the anticoagulation was reversed. He underwent the surgery. Now, in case there is a trend for using the NOACs, all of us should know which all the agents which are available free of cost, where it is available, and how fast they can be acting. So most importantly, we have Praxiband and Kcentra. Andexa, I am not sure whether it is available. Whenever I inquired, it was not heard. So we used to plan for a PCC in case a patient who comes with this is there. Then there are various trials which have showed the efficacy of these reversal agents and the time required for the reversal. Now, the next question is perioperative management is, I have done the surgery now, when to start the re-anticoagulate the patient. Why? Because we have to prevent the progression of the CVT, we have to prevent the DVT in the legs, but the challenge is bleeding, and we bleeding not only in the cranium, and at NIMHANS we keep the abdominal flap, the bone flap, abdomen, so whether a bleeding can occur. So what we usually do is, the patient is shifted to our stroke ward, and we start the BD dose of heparin after around 12 hours, and next day we make it TID, and once the drain is removed, we go to the full and carefully observe the patient. The literature also has lot of case reports and a small series. They also tell the same thing. 1 to 2 days you start the heparin and start with a low dose and then go for thing. Rather than giving the newer agents, better to go for heparin, preferably unfractionated, because reversal is easy. Now the other group of perioperative managements are wherever you plan for a surgery for the visual failure. So you will recognize this group of patient. It is very less, but it is a challenging, and you will decide whether the patient will undergo thigoperitoneal shunt or optic nerve sheath fenestration, depending upon the presence of headache, and then you will stop the heparin, and then you refer to the surgeon or ophthalmologist. Usually ophthalmologist facility is not there at NIMHANS. We send to other hospital and they come back after 1 week and we start the anticoagulation. Now, we have a lot of patients with pregnancy, with CVT. The main challenge is our unispecialty hospital. So I will give you 5 patients with CVT, with pregnancy we have managed, and the challenges we face. The first patient was a young lady, married recently, developed hyperemesis gravidarum. Now, after some time, 10 days of continuous vomiting, she developed headache and she underwent MRI. It showed CVT. Now, the gynecologist herself referred to us. We were very reluctant to take continuously vomiting lady. All the medicines on the earth tried in the gynecological facility, taking for a CVT treatment, but the relatives and the patient insisted that we only treat. Then there was a problem with use of medicines. Which medicine, mannitol, whether you can use, Diamox we can use. This is a very challenging situation. When you go through the literature, none of them are known whether it can be used in pregnancy. But the patient and father, mother recently married, so both the families we have to counsel. They told that we are not worried about the child. We want the my daughter and wife to be happy. So we started the medicines with heparin. We gave 3% sodium chloride with consultation with our anesthesia colleagues, and 1 week her headache and vomiting stopped. And we told that we will continue the heparin, as I will explain to the next patient also. And you come back. The patient got discharged, went to the gynecologist. They came back after 1 month with MTP, and we continued her on acetram after that. The next lady was a little more milder patient with pregnancy with end of the 3rd month and first trimester end and 2nd trimester. Here we diagnosed CVT. Here we started her on heparin. We gave option of converting to oral acetram in the 2nd trimester and again converting it to the heparin in the final trimester. You can use both low molecular weight and unfractionated. The lady told she prefers to have a 3 days injection of unfractionated and all the measures she followed, and she delivered a healthy baby. The 3rd patient was a lady who has multiple risk factors for CVT, family history of CVT, and undergoing a imaging with CT brain on a precious pregnancy trial on 8th day of her probable conceivement. You can imagine the amount of stress to the family and to us. And we explained her about the risk factors, about various aspects of the radiation. She still not has taken a decision what to do regarding the continuation of the pregnancy. She's on heparin. Now, the 4th lady is a mother of 1 child, has come with CVT to NIMHANS, undergone decompression on oral acetram. 4th month of treatment, she develops pregnancy, and she has already exposed on acenocumarol. We again explain her. She tells she wants to continue the pregnancy and she will have a look in the ultrasound. She stops the acetram. We stop the anticoagulation and give heparin for the next 2 months. And after that, we stop. Patient delivers a healthy baby. The most difficult patient I have managed at NIMHANS is this patient. The couple decide to use morning after pill to prevent the pregnancy, and patient develops CVT, and she comes to our hospital in a moribund state, undergoes decompression in the 1st month. No hospital is ready to take. She stays in 9 months. Gynecologist visits us, trains our staff for the delivery. She delivers a baby. She is in altered sensorium on ventilator. She goes home. She probably expires after 3 months, and 1 year later, the father comes with the child, healthy child.
So this is the most difficult patient we have managed. And 2010, whoever are there in NIMHANS that time, they will remember this patient. Now the next important group of patient is a patient comes with repeat scan. There is a no recanalization of the thrombus sinus. Sir, what to do? Should we continue? And a lot of literature is there. And we also have done one recent study of 150 patients. And we have come out with almost 90% of patients will have complete or partial recanalization. And there is no difference in the outcome. And probably the risk factor and rate of recurrence will decide regarding the continuation of the anticoagulation rather than the recanalization. Then we have a young fellow who has multiple risk factors for developing CVT, develops a pulmonary embolism, develops hypotension. Now we can't use IVT for pulmonary embolism because brain lesion is there. So we shift him to multispecialty. They remove the thrombus because of the hemodynamic status, and he recovers. He comes back after 1 month and he's doing well. And they have put the IVT filter also. Then other important thing all of us we face is presence of hemorrhage in the parenchyma and SIH, which is usually in the convexity. All of us, we are very confident, we treat them with anticoagulation. But the next important thing is very rarely will come with SDH, what to do. So we have 3 different types of SDH. We have collected and tried to publish it and submitted in one of the journals. We have a small SDH with CVT. We have a small SDH with a big CVT, and we have a SIH with SDH. What to do? So we tried to make an algorithm. We have to balance the risk of bleeding through our anticoagulation versus the spontaneous recanalization with symptomatic treatment and surgery in case of any worsening, and neuroimaging helping us to take a decision. Next, the another important problem we faced in management of these CVT patients is a lady who is having DUB or excessive menstrual bleeding during CVT on anticoagulation, what to do. So we were very hesitant. We went through the literature. There were reports of tranexamic acid being used. So we had a discussion with our gynecologist who is in another hospital. They told that, sir, you can use tranexamic acid if you are able to monitor these patients. So we went ahead and we started using low dose of tranexamic acid after explaining to the relatives, and 4 patients we managed initially, and we published this is in AIN. And now currently we use this short course until the patient gets. Other various methods we can use are there in the literature, we can also use. Now, then there are a host of other causes of CVT, which are predominantly related to procoagulant workup. I think all of you might have managed them during your thing. The recent thing, what we have seen very rarely is a Behcet syndrome. Now, in 2010, first case when we diagnosed the Behcet syndrome. Post patient developed complications, but we were more intelligent now. This first patient we diagnosed before the thing. We started him on immunosuppression, and the patient is doing well. Now, another important thing of CVT, all of us probably 1 year back, we were very much in lookout, was whenever CVT comes with low platelet count and patient has a immunization with vaccine of COVID. But now that scare probably has gone, and all of us know that we can't use heparin. We have to use IVIG and oral Novax. So the take-home message is CVT is a rare form of stroke. Medical management is the main form of treatment, which includes anticoagulation, anti-edema, and anti-epileptic, and risk factor management. There is lack of RCT. Even the main anticoagulation, only 3 RCTs are there, and the majority of the knowledge comes from the observational case reports and guiding force. Whenever challenging situation, we should have a multidisciplinary team from our hospital and surrounding hospitals, and it is gratifying to treat this rare and challenging patient. So all this experience is because of the patients, our colleagues at NIMHANS Stroke Center, and once again, thank you all of you for patiently listening. Thank you.
We will go to the next speaker, Dr. Anil Gobinath. He'll be talking on bridging the gap, endovascular treatment of cerebral venous thrombosis through case-based approaches. Over to you.
Let me begin by congratulating the NICE organizing committee for this fantastic show. I think the second or third, probably the third NICE I'm attending. Every time the theme is changing, the scale is becoming bigger. Yeah, really exciting, fantastic. Okay, so my topic today is to speak a bit about endovascular treatment in venous sinus thrombosis. Just like my colleague, the earlier speaker mentioned, that there isn't much of evidence for anything in CVT. So endovascular treatment also is in the same position. The evidence is not very great. So what I'll be sharing here are a few cases of how we have been using, or rather how our experience and how our approach has evolved over the years, and from the older kind of devices that we are using now, how we have kind of graduated into a more time, resource, and cost efficient approach. These are my conflicts of interest. Hopefully it will not be interfering in this session. Yeah, okay, so as the previous speaker already mentioned, it's a rarer version of stroke, and probably I must say that it's one of the more benign versions of stroke. In spite of that, something that we have to keep in mind is that it often tends to affect younger people, which means that the cost to the community, the cost to the economic burden is much more when it becomes bad, and it can become bad, especially those people who have a who manifest upfront with say a low GCS, or who got a bleed at presentation, or a deep vein CVT. These are the ones who generally tend to do not so well. And the management has already been discussed in detail. And yeah, I would like to highlight what he mentioned. There are only very few RCTs. And for that matter, the RCT on the basis of which heparin became the mainstay of treatment is RCT of 20 patients. Well, so it means that when it comes to CVT, everything is on very not so great grounds, not so, yeah. And as far as the role of endovascular treatment is concerned, European Stroke Association says there isn't enough evidence to make a recommendation, and American Heart Association has just left it open. It just says that, okay, if despite anticoagulation it's not working, well, you can try, they're just giving you a long rope to hang. And as far as the role of surgery or decompression is concerned, again, which is the right time to do the decompression varies from institute to institute, varies from the surgeon's individual threshold, as well as the way the surgeon will explain the risk to the patient's family. So, well, there are many more variables out there. And as far as I know there is only one randomized control trial which has tried to look at this problem. And this trial concluded that actually endovascular treatment doesn't make much difference. But the problem is this 2-act trial had a lot of deficiencies. It was done over like 6 or 7 years, 7 or 8 centers, each center recruiting, like doing very few cases each year. There was no homogeneity in the kind of devices used. You can see even devices like angiojet have been used. I mean, angiojet is definitely not an elegant device for the central nervous system. Yes, it works okay in the lower limb, but not for the brain. And there were also a lot of cases of intrasinus injection thrombolytics. Intrasinus thrombolytics is not exactly mechanical thrombectomy. It's still pharmacological thrombectomy. So, of course, there are a lot of limitations to it. Or say if you look at a recent, I think this is Michael Lawton's group, probably they did this meta-analysis. They concluded that EVT can achieve recanalization, but they found that the mortality was higher. Well, but again, this is a meta-analysis based on all retrospective studies, so you have to always interpret it with a lot of caution. And in fact, we ourselves published, it's accepted, it's not come up yet, our own meta-analysis and individual case series, and we found that actually we wouldn't agree with what the other published meta-analysis says. We are finding the evidence is slightly, at least we found that the outcomes are slightly on the better side if you're going ahead with the mechanical thrombectomy. Now this slide is actually giving a kind of summary of the various known or other more commonly used principles of techniques that can be used for performing mechanical thrombectomy in cerebral venous thrombosis. Amongst them, as I mentioned earlier, intrasinus injection is not mechanical thrombectomy, so I wouldn't speak about it. And angiojet, well, there are papers which have shown that use of angiojet is actually increasing the likelihood of complications. So again, we wouldn't speak about it. And as someone who used a few hundreds of angiojets in different parts of the body, I can tell you that it's too stiff. It's not good for the cerebral venous system. Coming to the other three, let's see some cases reflecting them. Now, this was a patient who had a bleed from CVT, and he did undergo a decompression, but still he was continuing to deteriorate, and you can see the yellow arrow is showing the clot out there, and he came for mechanical thrombectomy. We went a transfemoral approach. So this is the venographic face of the arteriogram, and you can see there's no opacification of the transverse and the sigmoid sinuses, and from a transfemoral axis, we got a wide bore catheter, aspiration catheter, all the way up into the sinus, and started sucking out clots, kept on sucking, and after a few hours, we managed to open it up. It looks good now in the okay. Now again, this is something I would like to share. We don't have to get this kind of pristine appearance. You just want to have a channel through which the blood can flow antegrade. So the end point is not a pristine appearing venous sinus. The end point is a channel that will allow the blood to flow in the antegrade direction, and that has been achieved over here. The patient did good as well, and this is a pre and post CT. But the problem is, it took around 3 hours. The hardware cost around $5,000 for us in Singapore, and the blood loss. You're continuously aspirating. Actually, we had to transfuse the patient after this. Another case, here there is again venous infarct which has got converted into a bleed. And you can see there is no opacification of the sinuses. Once again, came from a transfemoral route, brought in a wide bore catheter out there and tried aspiration. After a few passes, realized that the clot volume is so much that just by aspiration we couldn't take it out. So this time around, on top of it, used a stent retriever, and with stent retrievers and aspiration combined, managed to pull out quite a lot of clot and found good results. Of course, a patient also did well. But the problem here was, even this took 2.5 to 3 hours, and the cost is almost double as a previous case because you use a stent retriever. So now it becomes $10,000. So this is what we were doing for a fair amount of time. But in the last 2 or 3 years, we started thinking that, we are using these arterial devices, these devices that are meant for thrombectomy in the arterial system, and actually they are very cumbersome to use. They're not designed for this purpose. The radiation exposure to the operator is high. The venous anatomy is also not very easy to negotiate when you're coming from the groin, and that's why we changed our approach to a direct jugular access. So this is more or less in the last 3 or 4 years our usual approach. We go direct jugular and use a Fogarty balloon. The conventional Fogarty balloons that vascular surgeons use for doing embolectomy, use that for trawling the clot from the venous system. Let's see some cases. This was a patient who had a superior sagittal sinus thrombosis, and GCS was dropping despite anticoagulation. And in the venous face of the arteriogram, you can see there is no opacification of the transverse sinus, filling defects in the sigmoid sinus, and it's running, fantastic. I'm glad. You can see the filling defects in the superior sagittal sinus. So we directly went from the neck, directly punctured the jugular vein in the neck, and brought a 6 French long sheath, and using a simple diagnostic catheter and a 035 wire. I must say, because for the non-interventional audience in the ground, 035 wires usually we don't use intracranially as frequently, but it provides good support in the venous system. We managed to cross it, and then I think this step is very important, that is getting the big sheath all the way up into the venous sinuses. So we got the 6 French big sheath all the way into the venous sinus. And it's possible to do it if you're using a 035 wire and a diagnostic catheter. And then this is what I usually use. I cross the clot, not with the conventional 14 wires that are used in the neurointerventional field. This was an 18 wire. It's relatively stiffer, and it behaves. I think these wires work better in the venous system. So use this Teremu Advantage wire to cross the clot. Replaced the diagnostic catheter with a Fogarty balloon, and then with the Fogarty, started trawling the clot. So as we are trawling the clot with the Fogarty balloon, you can apply suction over here, And since this is a big sheet, 6 French sheet, there is still space for you to allow the suction force to act. And maybe in interest of time, I'll just, so just keep pulling, keep pulling this. And in the later stages, you just trawl it all the way down. And if the smoke clots, just bring it down into the IJV. Anyways, it will go into the lungs. The patient is on heparin, so usually you don't get any bad PEs out of it. And this was a final picture. And in the venographic phase of the arteriogram, it's not pristine definitely, but there is a channel, there is antegrade flow. Patient did quite well. And the best thing is, this took me less than 40 minutes, and the cost was like under $1,000. So it's like 1/5 the cost of the aspiration thrombectomy and like 1/10 the cost of an aspiration with stent retriever thrombectomy. Another case, similar, this here, the clot is only in the anterior part of the superior sagittal sinus, not filling over here in the venographic phase. Directly punctured the vein in the neck, and this time it's a 6 French Teremu destination. And after crossing the clot, injected some contrast. You can see the filling defects in the venographic phase of the arteriogram. You can see the filling defect. And once again, the same things. You can see the big sheath has been brought all the way into the posterior part of the superior sagittal sinus, which I think is very important, because if your sheaths are sitting in the neck, your Fogarty's or these things are not going to work for you. And okay. All right, So when you're using the balloon for the first time, I don't inflate it as much, but the second inflation usually is a bit more volume. You inflate the balloon a bit higher than normal, higher than the first pass. And this was a completion angiogram. It's opened up quite nicely. Earlier, if you remember, this part was not filling up, and now it's filling nicely. Another case here, again, transverse sinus thrombosis. These are clots sitting in the transverse sinus, and then there's a bleed over the same thing. I'll just rush through the case. The time is, just 3 minutes left. And that's a transverse and sigmoid not opacifying. Once again, crossed via direct neck axis, brought a diagnostic catheter up, brought the Fogarty up, started pulling the clot down. And you can see the big sheath is all the way up here. After the first pass, there were still some filling defects. This could even be a prominent arachnoid granulation. Anyways, I did one more pass. And anyways, that was the final picture. It was not looking pristine, but at least we have good antegrade filling of the veins, which means that there is a channel for the blood to drain down, and that's usually enough. So to summarize, I would say that this approach of directly puncturing the veins in the neck, the direct jugular axis, and using something more, much more suitable for the venous system may be a good way to go. You don't even have to use a microcatheter. Very rarely you need a microcatheter to be used for these kind of cases, and they seem to be working quite well. To conclude, I would only say that the role of endovascular treatment in CVT is not yet very well defined, but if your patient is deteriorating despite your best medical management, do consider it. It's very safe, it can be done, it's very well scalable, and you can use the conventional arterial devices, which will make it more expensive and tedious, and there are also less resource and cost intensive processes as I just shared with you. In the end, let me share this one slide. The later part of this year in August, we are organizing the Asia Oceanian Congress of Neuroradiology. I am the program chair for the interventional component of it, and we have put up a good program, and quite a lot of speakers. These are not all the speakers that we have more than this. I'm just sharing the ones which I could put on one slide. So I hope at least we'll have a few from this crowd to be attending. Anyways, at least you can have a good holiday in Singapore. Thank you. Thank you for your attention.
Great talk, Anil. It was a good overview of the endovascular treatment in cerebral venous sinus thrombosis. Could we ask a question to him?
The next one. Unfortunately, Dr. Thomas will be leaving us. He has to catch a flight. Next person is Dr. Manas Kumar Panigrahi is speaking on cerebral ischemia, revascularization from therapy to practice.
Yeah, good morning. I'd like to thank Dr. Gaurav for inviting surgeons to this kind of conference because as we look at the history of treatment of vascular surgery, though it started with surgery, means now it is become the reversed medical, and then people then think of intervention, then they think of surgery. Yesterday I was speaking with Dr. Subhash Kaul, who heads our stroke unit, and then he means if, like I was talking on intracranial arterial stenosis, is there a role of surgery? I asked him. He said, no, surgery doesn't do any harm. That's why you can do it. But I asked whether you'll send patients for stenting. He said, no, I'll not send because it causes more harm. And at least surgery doesn't harm. So so what are a few cases we have done with the support of Dr. Kaul, and then so I'll be telling our experience on doing revascularization in ischemic disease. All of us know as a surgeon we do a bypass, like doing an extracranial to an intracranial bypass. But then if you look at history, in 1985 we discarded that, telling that it is not useful. Though the first bypass was done in 1942, but in 85 there was a trial, and they said that it's not effective in ischemia, and then it went into disrepute. But then there are a lot of criticism that it was not done properly because half of the patients were received antiplatelet at entry into study, and there was no evaluation of the cerebrovascular reserve of those patient, and the patient and the therapist were not blinded. And randomization to treatment, there is a bias, and then many times the patients were operated outside the study. So the conclusions, though it is discarded, but many surgeons and neurologists together have found that surgery is helpful in few cases, like intracranial stenting also is helpful in few cases. Now, there was a study called the carotid occlusion surgery study. Again, they had two groups where surgery arm was 97 patients and medical arm was 98 patients. Because in this group, again, carotid endarterectomy, neither endarterectomy nor stenting can be done. And what you have to do for the patients who come with recurrent strokes. Unfortunately, of the 92 bypass which was done, there were 30 different surgeons who did. So each surgeon has done only 3 cases. So the results, what we get from this is skewed. And as we expected, that the perioperative stroke rate in the surgery group was almost 15%. So if you exclude the perioperative stroke rate, but there was a significant reduction in the benefit, like there is a 9% incidence of a recurrent stroke in those group of patients as compared to medical management of 22%. So the surgery is helpful if we do not have a perioperative stroke rate. And this study, when you have 30 surgeons doing each one doing 3, probably it is not correct. But if you had 100 cases done by 2 or 3 surgeons, probably the perioperative stroke rate probably would have been less. So if you eliminate this perioperative stroke which happened in 2 days, it is helpful. Now, if you don't do surgery, what is the current scenario in intracranial stenting, especially in intracranial stenosis? Now, if you look at this table, like ECIC bypass, none of the other studies are so encouraging. That intracranial stenting also has, as Dr. Kaul, as a question, it caused more harm than surgery. At least surgery was not harmful, but intracranial stenting had caused more harm. So now they do stenting in intracranial stenosis in selected cases. At the present status, the failed medical management, in spite of 2 antiplatelets, and the patient gets a recurrent stroke in 3 months, then they can be thought of intracranial stenting. But if it's amenable for stenting, and if it's not amenable, then one has to think of surgery. So the present status of revascularization, though cerebral ischemia, most RCTs shows no benefit, but in selected cases, like I'll show you in my consecutive slides, that it is helpful. Moya, it is a class 3 evidence that it is helpful. In complex aneurysms, whether one does coiling or bypass, it's a class 3 evidence, but there are many cases where intervention is not possible, and skull-based tumor where one has to sacrifice the vessel, then again, revascularization becomes an important armamentarium. Now, what do you do like these cases when there is an intracranial stenosis which is complete blocked where stenting is not possible, or a carotid occlusion which is complete occluded where intervention or endarterectomy is not possible, and then or calcification in the wall, what has to be done? Or Moya disease, again, intervention cannot be done. like these cases of Moyamoya disease, or are this case of a giant thrombosed aneurysm who present with a thromboembolic stroke, then again intervention is not possible. In these cases, one has to do a trapping of the aneurysm and do a bypass procedure. So bypasses are basically divided into two types: flow augmentation, where there is inadequate flow like in Moyamoya disease by doing a bypass, or a flow replacement where you deliberate sacrifice the artery like in aneurysm or tumors, then you replace with either a bypass, either a high flow bypass or low flow, that will depending on the need of the patient. Now, once you decide that a revascularization is required, so before we make a decision, first we establish whether there is ischemia or not, and to decide whether surgery will be helpful or not, we have to assess the cerebrovascular reserve. We do not suggest surgery unless we confirm that it will help the patient. Cerebrovascular reserve is something where means a patient has occlusive disease, but the ability to increase the blood flow in response to a stress is compromised in stenosis. So collaterals are already vasodilated. So in case of stress, they do not have that reserve. So any activity like crying, eating food, or running or fever, where they need an extra autoregulation when it is lost, they are high prone for having a stroke. And these are the cases where one needs to suggest surgery. Now, how do you, so that is a stage 2, that's called mesoreal perfusion. One is to confirm that this particular patient has an inadequate cerebrovascular reserve, then we go for surgery. Now, to establish ischemia is easy, you can do radiologically and symptom-wise, but to establish cerebrovascular reserve, one has to do perfusion study, like SPECT or MR perfusion, one can do a CT perfusion or oxygen extraction fraction or ASL. Normally, what we practice is to do a SPECT with and without Diamox. This is what we do. We do a SPECT with and without Diamox. And if the perfusion does not increase with Diamox challenge, then we assume that they have inadequate cerebrovascular reserve, and then we suggest them surgery. Now, there are papers, people do use acetogelamide and do ASL study in Moyamoya, and then this has come in Stroke 2022. We have not done that. We follow SPECT in our institute. Once we decide this patient has an inadequate reserve, we plan, when you do a plan for biopsy, one has to decide whether one does a direct revascularization or an indirect. Now, depending on the caliber of the vessel, caliber of the donor or the recipient, we decide whether to do a direct or an indirect, wherein a mental graft or the muscle is transposed on the brain so that you get an indirect revascularization. So indirect, the disadvantage is it takes 3 to 4 months to mature. When it's only done when you have a very thin vessel, there is no acceptable recipient, then we do an indirect. But what is preferred is a direct revascularization. So Moyamoya, normally we prefer to do combination of both direct and indirect so that it is helpful for the patient. I'll tell a few steps on how you do in the surgery. Like XTA the superficial temporal artery is the commonest thing what we use for bypass. We use two types of technique. One can first mark the superficial temporal artery on the scalp and incise directly, identify superficial temporal artery, that is like outside in technique, or reflect the flap like this, and then harvest the graft from inside out. Both ways, whatever one the surgeon is used to, can do that. So this is the graft is harvested. And then this is again the inside out technique where the graft is harvested from inside out technique. The vessel is then brought in through the temporalis muscle, and you identify the recipient vessel. This is the recipient MCA cortical branch. And then anastomosis is done using 9O or 10O nylon under high magnification. And finally, the patency is confirmed with Doppler and doing a angiography, either an ICG or a fluorescent angiography showing that the patency is good. Now, of the 55 cases we have done in 41 patients, we divided into two groups of less than 18 years and more than 18 years. The predominant etiology was Moyamoya in children less than 18 years, and in adults it was in 75%, but many of them were aneurysms and ICA occlusion. As you see here, there are only 3 cases. Like we do not do many cases in ischemia. In adults also, it's like Moyamoya disease. Of the 18 cases in children, like 12 cases had a CT angio follow-ups, which showed good patency, and in adults, we had 10 cases of CT angio done in follow-up and had a good patency of the vessel, as you see in the pictures there. So if you're reviewing the literature, the patency is maintained in different studies from 100% to 96% to 100%, but the stroke rate has varied from 2% to 12%. Now, this does not come without complication. As you can see here, children had less complication of 5% stroke rate, whereas adults had a higher risk of stroke, like 13%. We had one patient who had a flap necrosis also, and one patient of a Moya disease who came back with, again, hemorrhagic stroke. So we had to do another bypass. We used, in this case, earlier we had done STMCA. Now, again, we use the occipital artery and then tunnel it, and again did a occipital to MCA anastomosis. So then this patient, after doing the second anastomosis, is doing well. For aneurysms, one does a second genesis, like this giant aneurysms, ICA bifurcation, where stenting, they said it is not possible. They said they can do a flow diverter from one ICA to either ACA or MCA. So we did a bypass to the MCA and attempted a stenting from ICA to ACA. Though the patient didn't do well, but that was the plan, and that's what we did. And this is a short video of the high flow bypass using a saphenous vein graft from the internal carotid artery, cervical carotid to the MCA vessel. And then again, finally, confirmation, you can see the flow here, there, and confirm with ICG that there is a patency. This, as I told you, the symptom recurrence was less in children in 5% of the cases, and in adults it was in 8% of cases. In conclusion, revascularization is helpful in selected cases, especially it helps in reduction in ischemic attack with acceptable complication rate, and surgery was safer in the younger age group, and complications rate were higher in the atherosclerotic disease and low in Moya disease. Thank you for your attention.
Thank you, Manas, for a very nice talk. I would invite the next speaker, Osama Jedat. He will speak on recent Tesla trial update. He is the Neuroscience Institute. He works at Neuro Institute, Stroke Center, Director, Professor in Northeast Ohio Medical School. And his major achievement is he is the founding president of SVIN. His interest in clinical trials and clinical research led many aneurysms and ischemic stroke studies, as well as working on medical device development. His proudest achievement is mentoring and training both neurology residents and neurointerventional fellows in collaboration with the worldwide neurointerventional community. So I would invite Dr. Osama O. Jedat for his talk.
Great. Thank you for inviting me. It's my pleasure and honor to be here with you today. I'll try to share some data with you on the Tesla trial. But if you want to know the final result and the primary analysis of the Tesla trial, you have to come to Munich, Germany, on Friday, the 26th, I think around 11 in the morning, and you will hear the Tesla trial primary result. So it's boycotted. We could not really share it with you. It's accepted at the ESOC meeting in Munich. I'm going to just give you some update about generally the large core infarct trial in general, the large core infarct. I mean, I think those recent trial makes you think that the answer is there. But the truth is, those trial is totally different, as we're going to see. They are really testing different theory. And recently, in our own stroke and endovascular morning conference, I asked one of the residents to prepare more or less a review of the angel aspect, for example. And as you dig deep into it, you realize that's really not testing the true large core infarct. These are my disclosures. So, I mean, I think in general, you know, when you look at the large core infarct, it becomes a question of cost-effective analysis, right? So is it worth it to treat someone with is it a futile thrombectomy or not a futile thrombectomy, even if it's better than the controlled treatment? And we're going to try to walk you through this as we review the recent trial data. So I'll give you a brief update on the recent trial data if you didn't get a chance to review it yourself. So I'll give you in 3 slides each trial, the recent advances and update if you did not get a chance to look at it. So we know the argument to treat and not to treat when you encounter a patient with completed infarct or large core infarct. The argument that if it works for the patient with good CT, it would work with the patient with bad CT. So that's one argument. The other argument that you really wanted to try to say that every brain matter, and you want to try to take the thrombectomy to the next level. Also, you can argue that treating it may reduce the incidence of hemicraniectomy, decompressive surgery, and the complication from cerebral edema. So there is several arguments to treat and not to treat, but we don't know whether we really have an answer. Several previous studies from the good aspect have looked at the subgroup analysis, and they looked at the 0 to 5, and there is no clear answer from the Hermes group whether 0 to 5 patient work or doesn't work. So as you can see specifically, 0 to 2, it seems it's not as good, if not worse. 3 to 5, there was a signal. Now, I'll tell you the story with the Tesla trial. Originally, I wanted this to be funded by the NIH. So I went to the NIH and I asked him for funding. And Joe Broderick sits on the stroke net. And he pushed us to say, you know what? We want to know the threshold. Why are you only enrolling 4 to 5? We want you to go and push the limit and enroll aspect of 2 to 5. 2 to 5. So we changed it, and then after we did everything they want us to do, they said, oh, we're not going to fund you. So we did everything, and they're not going to fund us. So we decided to go to the industry and get investigator-initiated grant in Toledo, and we managed to get funding for it. And luckily, now the trial is completed, and the result will be in May. So there is multiple meta-analysis looking at different really aspect score, and the mortality range is 30 to 43%. Remember those numbers, 30 to 43%. The 3-month, 0 to 2, and the aspect 0 to 5 range 24 to 28%. If I had more time to prepare, I'll compare those, what I call it, the prediction versus the randomized trial. It will be cool to look at that, right? Based on the subgroup analysis, is the randomized trial gave us an MRS of 0 to 2, functional independence at 25 to 28%. And the mortality, 30 to 43%. Is that true? The symptomatic hemorrhage, 7 to 40%. Is that true? We'll see that. In the Stratus registry, no significant difference in patient who has aspect of 0 to 5 or aspect of 6 to 10. Recanalization, it doesn't seem to make a difference. However, ticket 3 in aspect of 6 to 10, the complete recan was better. Maybe because of this. So anyway, so you can see that there is ticket 3 that's higher in a patient with good aspect versus not good aspect. In a bottom line, patient with first pass or second pass effect, the recanalization did the best in the aspect of 0 to 5, fewer cases of symptomatic hemorrhage, ticket 3. So the more recanalization, the better it is in the aspect of 0 to 5. If you looked at in the Stratus age and outcome with the low aspect, almost if you are more than 75, you will only have hemorrhage, and you almost none of them would recover. So age and low aspect is important for your decision making in the middle of the night. Someone with age of 75 or older and low aspect, none of them in the Stratus registry made it at 90 days. So anyway, so these consideration for randomized trial, and that's why I say randomized trial in large core is different. Are you going to use MRI? Are you going to use CT? Are you going to use combination? What's your cutoff for the volume of infarct? We know the Dawn went as low as 50. So they didn't treat a lot of people above 50 versus 70 ml in Diffuser 3. So Diffuser 3 treated up to 70 ml dead tissue, 70. Dawn treated people at 50 ml of dead tissue. So what cutoff you will decide, and we will talk about it in the next slide or two. So this is the nice slide summarizing all the incoming large core infarct. As you can see, it's all over the place. The definition in the recent trial that we're going to talk about that completed Rescue Japan is mainly MRI. and mainly a recent, mainly recent. If you look at the onset within 6 hours, almost everybody. If you looked at SELECT-2, it's mainly a perfusion study. If you looked at Angel Aspect, it's all over the place. Aspect of 3 to 5, aspect is more than 5 and more than 6 hours. You have to look at CT perfusion. And aspect less than 3 and core infarct, you have to look at CT perfusion. So each one of those 3 trials have looked at a different definition of large core infarct. And in my opinion, different definition means different study. Because now you're looking at totally different thing. The only study that did not mix imaging modality is the Tesla trial. So Tesla is a zebra. We didn't enroll based on CT perfusion. We didn't enroll, and we went all the way down to 2. As you can see, there is mixed in the last, which is also finishing up, I heard, they mixed diffusion, they mixed MRI and CT scan. If you look at the tension, they mixed MRI and CT scan, and they only stopped at 3. As you can see, there is different definition to different trial. Let's look at the Rescue Japan. You guys seen Rescue Japan trial. Rescue Japan is a positive trial. What did they pick as a primary endpoint? Their primary endpoint, they decided it's MRS of 0 to 3, not 0 to 2, in green. Look how different is this. If they decided that the primary endpoint is 0 to 2, the trial would have been negative. It's interesting. And if you look at them carefully, 0 to 6 hours from onset and 6 to 24 hours if flare negative. 55% of the subject were within 4.5 hours, and 70% of the subject within 6 hours. So this trial is different. It's 0 to 6 hour trial because 70% of the subject were enrolled within 6 hours. More than half enrolled within 4.5 hours. And again, I mentioned that the primary outcome was 0 to 2, 14% and 7%, while the biggest difference was MRS of 0 to 3 with an odds ratio of 2.5 versus 12.5. Again, it's an MRI studies, 87% of the population in both arms were enrolled based on MRI. So close to 90% in Japan, they do MRI on everyone. Do you guys do MRI for triaging thrombectomy here in India? I don't do it in my hospital. I don't think you guys do it in India. It requires a lot of manpower. In Japan, almost 90% of Rescue Japan large core infarct was defined based on MRI. Keep that in mind. And I'm going to summarize in a little bit. Angel Aspect, on the other hand, they enrolled aspect of 3 to 5. If the aspect is more than 5 and the patient is more than 6 hours, they have to have a CT perfusion with a core infarct of 70 to 100. Interesting. Keep that in mind. Aspect is less than 3, also they need a CT perfusion. So if you are more than 5, less than 3, they're going to enroll you based on perfusion, not based on CT scan. And you have to have a volume of 70 to 100. That's interesting, right? I'm going to just walk you through this. It's a 500-patient study. Look at this. They said they're going to enroll CT perfusion 70 to 100. Their median, you guys know math. Indian is famous for knowing math. Look at that. What's their core infarct volume? The median is 60. That looks like what study? We just mentioned it. That looked like Diffuser 3 study. They enrolled patient with a median infarct volume of 60 cc. That's a repetition of Diffuser 3 study, basically. Basically, they enrolled some patient. Some of those, I don't know. I mean, to me, that begs an ethical question, right? If you enrolled in the control arm of 200 patients, on average, 63 cc, you have withheld this therapy that would have been a candidate for Diffuser 3. But more so, is 31 cc, is 25% of the subject has volume of 31 cc or less. 25, 1/4, right? That's what IQR, interquartile ratio, means, 25 to 75%. So I don't know, the trial is positive, great, and I think they enrolled a lot of good patients. That's why, if you look at their outcome, 0 to 2, they have 30% good clinical outcome. Remember, Rescue Japan had 14% 0 to 2. Now, Angel Aspect has 30%, 2.5 times Rescue Japan, 14% 0 to 2. Rescue Japan I'll just remind you about this, 30 and 47%. 31% versus 47% in angel aspect, and 14% versus 30% in angel aspect. So, and I'll show you that in a graphical way. Symptomatic hemorrhage is 6%. Symptomatic hemorrhage. Anyway, so this is kind of typical slide. I wanted to pay attention here for a little bit. So aspect less than 3, this is good outcome. I want you to pay attention to yes. So there is less than 70 ml. Less than 70 ml core infarct, 140 patient, less than 70 ml. The 140 versus 129, that's diffuse population. So the population of less than 70 ml is huge in angel aspect. And maybe that's why they have the best MRS score. Make sense? Excellent. Okay, good. So we walked through this. Select 2, on the other hand, enrolled patient is more than 6 and core more than 50. So now the enrolled aspect more than 6, as long as their core more than 50. Aspect of 3 to 5, they have to have a core more than 50. Aspect 3 to 5, less than 50. Again, they mixed the design, CT perfusion and non-CT perfusion. And let's look, and one more thing fascinating to me, almost 1/3 of the population in Select 2 are tandem lesion. And tandem lesion tend to do good, and their CT perfusion tend to be inaccurate. So there is 31%, 31.5% in Select 2 population had tandem lesion, 31.2%, 31.5 versus 25% in the control group. So it seems also there may be a problem if you have a tandem occlusion in your CT perfusion. It's interesting finding. So this is their final outcome. They went with the ordinal scale, but they're 20.3% MRS 0 to 2. In between, diffuse in between Rescue Japan, which is 14%, and Angel Aspect, which is 30%, they came at 20%. Their MRS of 0 to 2 at 90 days is 20%. 20%. Their MRS of 0 to 3 is 37.9%. Still less than Angel Aspect, but more than Rescue Japan. Somehow, their bleed rate is only 0.6%. 1 out of 178 patients had a symptomatic hemorrhage. Interesting findings again. Their group is, I don't want to, I'm running out of time. I don't want to overwhelm you with their group, but this is the analysis basically. These are the 3 trials. Each paragraph is different trial. So this is MRS of 0 to 2. The lowest is Rescue Japan that used MRI. I was going to add MRI. The next to it is Select 2, and Angel Aspect had the best MRS of 0 to 2. If you look at MRS 0 to 3, it's the same trend. Angel Aspect has the best MRS 0 to 3, Select 2 has in between, and Rescue Japan that used mainly MRI has the least. And if you look at their mortality, the lowest is Rescue Japan, and the highest is Select 2. It's fascinating. Back to the Tesla trial that we're going to share the result with you in May. We completed the enrollment. The enrollment was completed as of October 17 was the last patient in, was October 17. That same patient came back for follow-up January 17 of this year. We finished all this. The primary result will be presented on May 26, 2023. These are the site and the enrollment. And this is kind of like, I'm able to share with you the demographics. The demographic table between our thrombectomy in Tesla, and this is the same table that you're going to see in the publication. So 153 in thrombectomy and 148 in medical management. Age is the same. Stroke scale 19 and 18. Location of the stroke, left and right, is equal. AFib, mainly the slight imbalance in the diabetic patient. 30% in the thrombectomy versus 17.7 in the other group. None of the patient had M2, which is, we are happy with that, because some of the Select 2 had M2 population. Some of the Rescue Japan has M2, which makes no sense with large core infarct, right? So I'm glad that it looks like 0-0. Our time metric, our door to puncture is not the best, 90 minutes. And almost 110 minutes. Imaging to puncture ranges about, our goal was 1 hour, the 95 minute, and the median randomization to puncture. Our goal was 45 minutes, and the site managed to do randomization to puncture in 30 minutes. Overall mortality in the Tesla was 36.7%, similar to the other one. Our symptomatic hemorrhage closer to angel aspect versus select 2, about 7.6%. And hemicranie, we did that on 29 subject or 15% hemicranie. Again, it's the only large core infarct that's purely enrolled patient on CT scan only. We went all the way to 2. It's an adaptive design study. We tried to look at 100 patients to remove the 2 to 3. There was no difference. We tried to remove the 2 to 3 at 225 patient interim analysis. There was no difference. And now we don't know what the result will be. We will share it with you in May in ESOC meeting. Thank you very much.
Thank you, Professor Osama. Now the session is open for discussion.
Very interesting talk by all the speakers, and we will have some quick questions.
So the question is for Dr. Zaidat. So obviously, I think with your CT scan trial, we will not know the volume. But if you compare the Japanese trial, the angel aspect and select, and the results when you look at it, the Japanese trial obviously was a year ahead, but the core volume, was the highest. I think 94, I think 81, and then 60 in the. So I think could that be the reason why the results were the poorest in the Japanese trial?
I think I think the Japanese study, because they use the MRI that much, and the MRI is more accurate, I think, than the CT perfusion and CT scan, and that's why they have the lowest MRS of 0 to 2 at 14%. Their volume probably was closer to the true large core infarct. So if you want to try to counsel a patient with a true large core infarct, the problem is, would you use, that's why each study is applicable, right? Each study is different. So if you triage with MRI, you tell them the likelihood that I'm going to make you better at 90 days is 14%. 14%. That's the truth. So 14% becomes, cost-effective analysis. Is worth it if you have MRI data. If you don't have MRI data, then you have to go, okay, angel aspect. Am I using that criteria? Then their outcome is 30%. 3 out of 10 patients will do better at 90 days. If you go to the select 2 criteria, back to 20% in between. So now you are back to 2 out of 10 patients and 1 out of 5 functional at 90 days. But the worst is really but maybe for the return of maybe we should do the MRI.
Yeah.
Why? Because it's the most precise. There's a precision there. So if you suspect a large core infarct and you want to try to manage it based on your cost-effective analysis and your resources available, the MRI will be your best bet that it is going to be telling you how the patient will do at 90 days versus the other 2.
And I think one other comment, I think diffuse 2 and Dawn, they were great. But I think we were treating much severe infarcts before that. And the core in both diffuse and Dawn, and you can correct me, was 9 or 10. So I think the selection criteria was there, but I think they were pretty cherry-picked. So therefore, the results were very impressive.
Yep. Thank you.
It's a full session, and I think it's fascinating to go. I don't want to dig more deep into it because I only have 15 minutes. And I did I only did a journal club on angel aspect alone for an hour and a half. So,
absolutely.
I can share with you more analysis from my mind.
Correct. This needs a lot of discussion and debate. Let me move on to the other questions. Anil, that was a wonderful presentation. I have a quick question for you. Do you think in future the endovascular therapy for sinus thrombosis will become the mainstay of treatment along with the medical treatment, and we would take patients much earlier than we do today? Mic is not working, I think.
It shouldn't sound as wishful thinking on my side, being an interventionist. But yeah, I guess that's what it should be going, because at least one thing that we can definitely say is that it's very safe. We should not be comparing the current way of mechanical thrombectomy with the like something that used to be done in the late 90s and 2000s when catheters used to be left in the brain and TPA used to drip in, and then if I talk to many of the neurologists, they still have that memories. When they're bleeding all over the place, and that was what was actually making the people scared of that procedure. But that's not what we do now. I mean, even if you're using the arterial devices, they may be expensive, but they work well. And outcomes are quite, I mean, they're very safe. Even the 2-act, if you look at the 2-act, the good thing about 2-act is that there are no complications. There are only 3 minor wire perforations with no consequence. So definitely the safety and feasibility is very well established. Now the only thing is how do you rationalize it to make it like a first line or somewhere in an earlier way. So yeah, I think that's where probably more trials will be required. Only place where I can draw analogy is lower limb DVT. So for a long time, lower limb DVTs used to be like an absolute only medical treatment. But if you start looking at in many parts of the world, for lower limb DVT now, mechanical thrombectomy has more or less got a good footholding into the primary treatment. The same thing for pulmonary embolectomies. So that's what is probably going to happen for CVT as well, because they all are very similar. They don't kill you immediately, but they have there's a role.
Absolutely, absolutely. It's fairly safe, and people with even limited training can do this procedure. And compared to even arterial thrombectomy, it is fairly easy and safe as well. And we will allow the next question. Please go ahead, sir.
Myself, Dr. Arora. I'm a neurologist come managing director of Aurora Neuro Center, Ludhiana, Punjab. So my first question is to Dr. Kulkarni. We recently had a case, who has intravenous thrombosis with hematoma of almost, which is parietal lobe hematoma, and close to the cortex of roughly 22 centimeter. We treated him with all kind of antiedema measures and heparin and whatnot, sir, what you suggested. But in low doses,
we are not able to hear you properly, sir. Can you get closer to the mic, sorry, and be a little louder?
But it was low dose heparin. And yesterday also the patient came. He responded with his left side hemiparesis. But thrombosis is, or sinus thrombosis is persisting, still persisting in the same way. Number one, what to go ahead with this patient? Second, my question is that we have got some kind of explosion of cases of venous thrombosis, maybe COVID related or some other reason in last 2 years. And third question is that in asymptomatic cases of carotid artery thrombosis or stenosis of maybe even up to 80% and multiple, bilateral 1 or 2 to 1 or 2 and all that, what should be the approach for those patients? And they have a stable in the sense that there is no active plaques which can break out. Thank you.
Thank you, sir. I think 2 questions are related to CVT. I will be happy to answer. The first is, sir has treated with low dose of heparin, and the patient has improved, but the sinus thrombosis is still persisting. So with our study and also with the large number of studies available in the literature, the recanalization will be there within 1 month in around 50 to 60%, and remaining 30 to 40% will recanize over the next 6 months, as our study also has shown. Mm-hmm. If patient has improved and there is a reduction in the mass effect and whatever the shift is there, please convert him to the oral anticoagulation. So it will get resolved, sir, over time, and slowly taper the antiedema measures and continue the routine CVT. And maybe after 6 months you can check. The recanalization has not occurred, patient is improving. That means the alternate channels have opened up. That's what my thinking is. Regarding COVID and CVT, I think large amount of literatures are available. The initial, there was an enthusiastic correlation between the CVT, worse outcome, and various mechanisms and others. The later part with VITT, and finally, there are multiple meta-analysis and comparing the risk. So I feel in the initial part, there were a lot of procoagulant things and large artery strokes and CVT. The later part, we have vaccine-associated thrombocytopenic thrombotic events. And there is one review article in Journal of Stroke also, which has looked into the prevalence of the incidence of the CVT, incidence of the COVID, and the vaccine starting, and they felt that the later part, it was related to the vaccine. So a lot of discussions are happening in the literature.
Thank you, Dr. Girish. I think that brings us to the conclusion. I thank all the speakers who have given very nice talks and educated us. Thank you.
Thank you to all our chairpersons and speakers for this highly informative talk on hemorrhagic stroke and its management. We'll now have a panel discussion where our consultants will be chairing the session, and we'll have their residents discussing their individual cases. So chairing this session, we have Dr. Anil Karapurkar, sir. He is the Director of Neurovascular Intervention at Breach Candy Hospital, Mumbai. We also have Dr. Matthew Cherian, sir. Sir is the Chief of Radiology Services and Director of Interventional Radiology at Indian Medical Center and Hospital. He has more than 32 years of experience with more than 100 publications to his name. We have Dr. M.V. Padma, ma'am. She is a Padam Shri. She has more than 200 publications to her name. She is the HOD of AIMS Neurology. We have Dr. Dheeraj Khorana, sir. Sir is the professor in Department of Neurology at PGI Chandigarh. Sir is in charge of the MS and Stroke program. We also have Dr. Arvind Sharma, sir. He is the head Department of Neurology and Stroke Specialist at Zydus Hospital, Ahmedabad. We have Dr. Srinivasan, sir. Senior Consultant Neurosurgery and Head of Neuroendovascular Surgery at Apollo Hospital, Chennai. And we have Dr. Rashmi Saraf, ma'am. I ask our chairpersons to kindly introduce their residents and start the case. We'll start off with Padma Srivastav, ma'am, MV Padma, ma'am.
Good afternoon, everyone. My name is Dr. Saman Fatima. I'll be presenting two cases relating to ICH. So our first case was a 45-year-old gentleman who was a driver by occupation. He had no comorbidities and no addictions. He presented to us with recurrent focal neurological deficits. So this is his timeline. His first episode was in April 2018 when he had sudden vision loss in the right eye along with severe headache. I'll be showing the imaging in the subsequent slides. He was found to have a parieto-occipital bleed and managed accordingly. July 2018, post-discharged, he again had severe headache with psychiatric symptoms and left hemiparesis. He was found to have a bleed in the right parieto-occipital region again, following which he had, September 2019, almost a year later, left focal to bilateral tonic-clonic seizures. And finally, in his fourth event, he came to us with a right-sided hemiparesis this time. This is his scan for the first event, which was the headache with visual loss. And as we can see here, there's a bleed which is showing different kind of intensities. It is heterogeneous at varying stages, almost look like a space-occupying lesion. This was managed outside, and he was found to be non-hypertensive at multiple occasions. His BP recordings were normal. At this time also, in the outside hospital, his vascular imaging was done, and the MR angio did not was not suggestive of any significant abnormalities. The second event, when he again had headache with psychiatric symptoms, he was found to have a recurrent bleed in the same location, again a very heterogeneous bleed and causing mass effect, following which a decompression and hematoma evacuation was done at an outside center. It was also sent for histopathology, and the report that the patient showed us when they came to us was, it was mentioned that there was just blood clots and bleeding material found, and nothing suggestive of any atypical cells or any malformations. Follow-up, when the patient had those late post-stroke seizures, as I mentioned earlier, he was found to have post-op gliotic changes and scarring, and the hematoma is visibly reduced here. Following that, when he came to AIMS, with the last event when he came to us with the left hemiparesis, was this large MCA hereditary infarct. And when we did the angio, we found a cutoff, and there is a slight tapering also. I hope it's visible from the from behind, that there was a slight flame-shaped appearance just before the cutoff is visible.
Okay, go on.
So we did his routine evaluations. All were found to be normal. In his echo, there was found to be a large lobulated mass, and his cardiac CT found a mass attached to the posterior inferior left atrial wall and prolapsing through the mitral valve. This was the left atrial myxoma. This patient had presented to us with recurrent bleeds, and this time with an ischemic stroke. Atrial myxoma is the most common primary cardiac tumors that are found mostly in the age group of 30 to 60 years of age, has a slight female preponderance, and ischemic stroke is one of the major, most common neurological complications of a left atrial myxoma. It can present in the absence of systemic or cardiac manifestations, and a smaller percentage of hemorrhagic stroke is also seen with these patients. Pathogenesis being either oncotic aneurysm, sometimes myxomatous metastasis also, which might lead to this presentation. So the lesson learned in this case was basically that an atypical bleed, non-hypertensive, having recurrent bleeds along with an ischemic stroke also, a 2D echo and a cardiac evaluation is a must. And histopathology also really should be looked into again. And if in retrospect we are getting somebody who's having recurrent deficits, whether there is anything atypical in the histopathology.
What do you think, if we have to rewind this whole history, what should have been done in the first instance and then after the second instance? How was this actually, atrial myxoma mixed? Supposing this case had come to you, if there are there any residents out here? Okay, so it's to the open house. So what was actually the thing which was missed in the first instance after the first bleed?
Yeah, nice case. Padma, I think, if you see a bleed intracerebral, I think our tendency to not investigate the heart is pretty high, given our statistical truth of not seeing anything there. So I think we sort of not do the echo on patients who have had intracerebral hemorrhages. Think of aneurysms, AVMs, and all those routine stuff. So I think that was the first, thought that came, that was probably missed completely. And I don't know if you would have missed it on the echo, to begin with, had we done it. But it's pretty rare, isn't it? I mean, yes, rare things do happen, but rare things are rare and not shouldn't guide us terribly in terms of what we should do. But yes, I think we probably missed it based on that. Would we have picked it up on doing a standard 2D echo would be the first thought.
Yeah, I think the first thing is that one statement that when we're looking at a bleed, then we assume it's all those conventional reasons, and we do not fit in cardiac evaluation into an algorithm of stroke evaluation. That's number one. And number two is the angiogram which was done, since this person did not have conventional risk factors. So you are actually looking for AVMs and the usual ones, and an MR angiography sometimes is probably not the only way. And then there is an issue that when a recurrence of a bleed had happened again at the very same site, then again there was nothing more done. The third thing was that the bleed was evacuated, and this is what happens, the eye will not see what the brain does not know. So you actually have not looked at the vessels, and if they had done, they probably would have picked up the myxomatous tissue out there, because this was an atrial myxoma and it was an embolus, and then there's a bleed there. So I think it again comes down to the fact that we don't see when we're not looking for them. So this person came to us in the last, when had a ischemic event and landed up with us, and the last one was that flame-shaped thing that was actually looking like a dissection. And the immediate thing which comes to one's mind when you have a young person is also angiitis and a whole host of vasculitic syndromes, which also were looked into, which should be looked into. But a very simple test like a cardiac echo had picked this up. So that was the take-home message from this. I do not know if we have time for another case, otherwise
just one little addition to this fact, why it got possibly missed. Can you show the bleed of the first CT scan? of the patient. One, of course, like ma'am just said, the important part is a young patient with no risk factors. An angiogram would have kind of pointed out to this. Now, if we look at the distribution, this is not a usual distribution of a hemorrhagic stroke. It happens to be likely in the region of the posterior or the PCA and looks like a converted hemorrhage, ischemia converted to hemorrhage. That itself should be a trigger to evaluate embolic sources, which if I see now, of course, you're always wiser retrospectively. You might not have done it, but looking at this kind of a scan, you could have looked into the embolic sources, which
But
wouldn't
yeah,
trigger
but
a
it
heart.
does look like a bleed.
But
I mean, all said and done, with due regard to the.
I just confess that I would MR for tumor bleed. I will more
Okay,
go for a tumor bleed.
exactly. So I think since we are running out of time and I'm just taking this, we will not present the second case, but what I would request Saman is, don't talk, just present the next scans. Do not talk. I'm going to give the questions to the house. Okay. No, the first image.
This is the first image when she came to us with the first symptoms.
Okay, so the first impression, one answer from anybody. What's the first impression? Okay, thanks. So the next, again, do not give the history, Saman. Skip it. Run it fast. Yeah, run it, go to the next one. Yes, now. Open house. Next. Impression. Yes, sir. Yes, sir, without history.
There's a spot sign, and you have a mixed density. It appears it's rebleeding from the same site.
Okay, anybody's thinking about a tumor there? Who all think it's a tumor?
No, it's a
So yes, so that now it's. I mean, this is just the reverse of somewhere. It's essentially it's not a stroke. It's a stroke mimic, presented as a stroke, and eventually turned out to have. In retrospect, when we went back to the images, there were red flags. But this is again when it appears in the region, and you have age group which does not say it's not a hypertensive bleed. This is how we go. Since we have overstepped our time, sorry, I just wanted to show these two scans. Thank you, Saman.
Thank you.
What was that scenario? Tumor.
Looking back at the first case that you presented, how many of you in the house would have evaluated the heart?
Practically
none. Yes.
But I guess that's the reason we put these things, that when there are red flags and everything doesn't fit in the bill, then just expand your search engine, and especially then when there's a recurrence of a stroke. Patient doing well, I'm fine. When they don't do that, that's actually been a dictum. You revisit your entire history. Your whole trajectory needs to be revisited if the patient is not doing well. And this patient didn't do well.
The first case, the MRA was not done in the first sitting, right? Was it?
The first case was an MR angio. Yes, sir. Actually, this case was
young
evaluated.
person who's bled, is it vasculitis or is it a venous bleed?
True. Totally
I
agree
think the
on
problem was not the cardiac. The problem was not doing an MRA and MRV. You'd have seen the occlusion, you would have looked for an embolus and we'd have found it. In our center, by protocol, young bleed, atypical, MRA, MRV is always done.
Absolutely. And I totally agree with you. That is even our protocol. This case has been evaluated outside. We don't have to name the centers where it has been done. But it is a third stroke that he came to us. And that's where, I mean, and retrospectively, like, I don't know what we would have done when he came with that bleed though. But this time it was an ischemic stroke, obviously went through the same protocol. However, I completely agree that when you have a stroke in young with no risk factors out there and completely unconventional in a lot of aspects, one should have had that kind of a protocol and not just do one circular Willis MR angio vaguely and then be done with it.
At our center, as a routine for all stroke patients, we are doing cardiac evaluation irrespective of whatever the age is, because the critical care team or the anesthetists, they don't leave the heart behind actually.
No,
They're
but the
always looking forward
hemorrhagic
to evaluate the
stroke,
brain.
see, for a young hemorrhagic stroke, why do you need a cardiac?
No, before taking the patient for any surgery, a cardiac evaluation is mandatory.
Here
as
the
per
question is, if you see that CT image, will you do a cardiac? I wouldn't do a cardiac on a young person, but I would definitely do an MRI and MRV. I think there, when we see the occlusion, which looks so embolic, we would have definitely gone for a cardiac. But otherwise, as a pre-op evaluation, I mean, that's different. I mean, I think here the question was, on that CT, will you be doing this? I mean, that's an incidental pickup, not directed towards finding a finding, you know?
I would agree with you on this cardiac thing as part of critical care management. I completely, whenever we have to intervene, we have other things, and we know that there are problems on an ECG when you have an acute stroke. There are a lot of issues there. So cardiac evaluation, but as Sir has said, not as part of etiological evaluation, but as part of critical care evaluation, critical care management. The next case.
So yeah, second case is from Mumbai. Dr. Karaputta. He's ready for the live.
Yeah.
Yeah. Yeah. No, he's presenting.
Yeah,
from
she's
the
presenting
Mumbai.
live.
She's presenting. So, yeah. Can we know the name, sir? Who's presenting? Yeah. Fair.
Yeah. Anyway, the next case is, she's here. Riddhi Patel from Beach Candy Hospital, Mumbai. Yeah, she's a neurologist and she's our SNVA student. SNVA, not SNVA, FNB. FNB fellow in neurovascular intervention.
Riddhi, ready?
Sir, just a minute.
Yeah.
Sir, my slides are visible. Am I audible?
Not yet.
Sir, is it visible now?
I think you have to share the screen, no?
You are able to display, then we'll continue. Otherwise, we'll take the next one. Yeah, you're able to do it? Next one? We take the next one? Yeah.
Yes.
Yeah. Okay. So we can ask Nishita till the Riddhi is ready to come and present the case.
Nishita, she is doing her DRNB, that's what they call for a postdoctoral full-fledged degree at our center, at the Kobe Medical Center at Coimbatore. I get confused, your second year or first year because of the admission thing, but I think you've nearly done a year, isn't it?
Just entered second year.
So she did her post-graduation in Delhi. So the house is yours.
It's good. Good afternoon all. I'm Dr. Nishita. I'll be presenting a case that we did recently. We feel we missed an opportunity in the management. Slides are not changing. Yeah. She was a 74-year female with no known comorbidities. She presented to us with right side weakness and aphasia since 2.5 hours. GCS at presentation was E4, B1 and M6. Our NIHS score was 14. Power on the right side was 0/5. Our sugar levels were 325. So these are KMCH stroke protocol. Total of 15 minutes for 6 sequences. If we don't want neck MRI, it will come around 10 minutes. So our diffusion was like this: left MCA territory infarcts with aspect 6, hardly any flare changes, and with a huge diffusion ASL mismatch. And she had a fatal PCA, so there was also a PCA territory infarct. When we see her MRA, there is ICA occlusion of left ICA, but there is reformation of ACA and MCA. And neck angio shows occlusion of ICA from the origin. When we see SWA, there was few distal fragmentation of pial emboli, as we can see here, and there was no hemorrhage. So, is she a candidate for mechanical thrombectomy or not? This would be my first question. Do we take her up or not? She's a 74-year female, reformed ACA and MCA with aspects borderline.
I mean, anybody can answer. We don't have a punch thing.
What was it?
2.5 hours.
2 hours.
2.5 hours.
And you have a considerable
house answers,
mismatch,
so
isn't
what
it?
happened
There is a mismatch of,
okay.
you have
Yes,
a
ma'am,
mismatch.
yes, ma'am, we have a
considerable
mismatch. I have a large.
And it's from the origin, it is obstructed.
Yeah, it's a.
So you said
I
it's
think
in
I
2.5 hours.
Yeah, it's a
I
2.5
think
hours.
You didn't
would.
thrombolize? You don't thrombolize?
We did not thrombolize.
We don't thrombolize generally if the patient comes into the
The
hospital.
first question should have been, do you want to
would.
thrombolize and bridge? Because the main, I know it's a LVO. We still haven't gone into the stage where IVD has to be overlooked. I believe this is an interventionist.
Yes, so I'll butt in here. We didn't ask that question because we decided we save a lot of money.
Straight into the cath,
Why not
then I
thrombolizing?
would
Because
go
the
for
delay
it.
is only half an hour.
Straight in the sense our doping
Okay.
imaging time was.
But
90%.
as per evidence, we still don't, and that's a message which
Actually,
I
if
would
you
like
look
to.
at evidence, they are more or less equivocal. Even while I was flying, I was going through this because I knew this question would be asked, and I just realized that it is very close to plus or minus. So we save 30,000-40,000 rupees. So we, in generally, unless and until the patient is being shifted from another hospital, they already reached the hospital, we kind of avoid it. We have been rethinking whether we should start at least in those where there is a blooming on SWI or where we are definite it's a RBC clot, because other than that, again, it doesn't, and if the volume of clot is not too high. So in this case, sorry, the boss decided that question was not necessary.
I would tend to disagree to that because most of the trials have shown patients who are not given would do worse, actually. There is no equivocality over there, I guess. But yeah, for a case-to-case basis, you would possibly...
The volume of thrombus is too high anyway on the angio. I don't think this would have benefited in any form. Whole ICA is involved. We know that in an M1 maybe, but not with something where the thrombus load is so high, it will never work.
So we went
Go ahead,
ahead.
please.
We
Well,
went.
these would be very difficult for intervention also, because you are starting all the way from the origin going in.
Why don't you take a vote?
Yeah,
And TNK, in fact,
you have to
TNK
do
would have been a
intervention.
better
No,
option
no
than
question.
TPA.
How many of you want to thrombolize seeing the thrombus load on this?
You mean you asked for IV?
IV.
Before the thrombectomy.
I think one of the thoughts
And-
I had was
and how many
the
it-
time. I mean, what time?
2.5
does it take?
hours stroke.
No, not that. I'm saying the time of door to or the door to groin time.
For us,
or the
it's-
time if it's less than 60, then I think you could
for us
go
it's an
straight.
average of 45. In this, from MR to this thing, it's half an hour. So that's why we stopped thrombalizing.
So in such
So
a
door to
case,
groin time is less than 60 minutes.
Always.
well,
Okay.
but TNK
So,
takes that over, and TNK, is superior
Yes.
to TPA
Yes.
pre-thrombectomy.
Yes, there's some
So
evidence for that.
I definitely would
Neeraj,
go for a
Neeraj, I know
TNK.
we've heard you. So let's take
It's
the
important to
vote
be
now.
heard.
Let's take the vote.
This message needs to go across.
Let's take the vote. I want you to be very, very practical. I sometimes we will get too carried away by literature. I keep telling my, be sensible. There is no one-shot solution. You have an occlusion starting from the origin, going all the way up. You're going to get the patient into the lab in half an hour. How many of you want to give that tenecteplase shot now? I'm asking in this case.
Yeah, of course.
Okay, fine.
Okay, and
how many don't want?
how many of you directly to mechanical?
Okay. It's very strange. We have this neuroaddicts group. I put the same question there. 50% yes, 50% no. People like Rene said totally waste. So same thing here. I think people have plus minus. And believe me, all the literature around, we are somewhere floating in between.
There are studies now.
Yeah.
Without.
Yes, maybe.
Well, I think literature would say yes.
It's not really a yes,
It's quite indicative currently.
But if
Whatever
you
literature
look
we
at the
have.
literature, it's kind of,
as
if you
far as
look
I
at a
think-
3-month MRS, there's not a big change,
See-
But in my personal experience, sometimes I find it very, very messy. Unless we have a balloon, It fragments a lot more. I see a lot more of distal embolization going place. So when in a full-fledged RBC clot, sometimes it's a problematic issue. And this is in my hands. I don't know about other people's experience.
I think the question boils down to the... I think the main question is the patient factors and the bystanders relatives factors, because cost is the main issue. The literature, more than the literature, the bystanders and the relatives are the main thing that you're going to face. And the additional 25 to 30,000. I mean, before like small centers where you're looking with the thrombectomy itself, the cost comes to somewhere around 3.5 to 4. And you're always looking at that extra
So taking
cost
a point, that's well taken, and that's agreeable that if you have, even if you have a shorter time, and relatives do take a longer time to sometimes give a consent for both the things. So you save that time. In fact, that's one of the reasons why we prefer to take up bridging rather than no bridging. Yeah, you may have hospitals who are highly, I would say, inclined to take direct thrombectomy. Well, that's, they call their shots for that kind of a situation.
Elderly patient having a complete ICU occlusion, they have something there most of the time, around 50%. So giving a TPA or tenecteplase, and suppose you want to place a stent, it's really difficult.
Very difficult.
It's really difficult.
Even
to place a
tyrofuse,
stent.
if you want to run after that, very challenging.
Tenecteplase. So definitely more than 60 of phase, completely ICU occluded, I don't want to thrombolize that in
Well,
this scenario.
on a case-to-case basis, yes. But as a rule, I said, what I was trying to indicate, you would first consider, maybe as a case, if there are exclusions, more than reasons not to do it, then you could possibly avoid it. But one has to probably, till the time we don't have robust evidence against it, I would say.
Yeah, today we stand in an era where we are moving towards direct thrombectomy, but we still don't have enough of evidence. I think in the current scenario, if you go by literature evidence, yes, we have to do thrombolysis followed by thrombectomy. But if there are centers, if you're in a center where a direct thrombectomy can be done right away, immediately, then go for it. It's a large vessel occlusion. You know that it works well, and various factors can come into play. And it depends on whether you're a neurologist or a radiologist or a neurosurgeon doing it, and depends on the comfort level and your local logistics. I think either way you can decide, but we are moving towards an era where we are doing more towards a direct thrombectomy going forward.
So one question, if that center is not enabled with thrombectomy, what you will do?
We will shift, drip and shift. Now there's no dripping with tenecteplase. We'll shoot and shift, you know.
Yeah, means you will give the drug on
and shift. Yeah.
Okay.
I think there is no. I don't think there is
choice
any
of drug, tenecteplase or tenecteplase.
It's so easy to give tenecteplase, right? One shot.
So what was the what happened next?
Vessel
Yeah, so let's see what happens. So let's go ahead with the story. I mean, this is not the problem we face, honestly. So,
just to clear the timings, door to imaging timings was.
Just one question for like, if this patient is not given internal thrombolysis and the patient, we know that this is the best for endovascular because there's a huge thrombus load. We have to do a suction or angioplasty and we can open it up.
All directed.
But if there is a failure in the procedure and we have not given intravenous thrombolysis, I just want to know what will be the legal implication. Like suppose the family says that the patient had a bad outcome because we denied a standard of care. So we know standard of care for acute stroke is IVTP is there, as Dr. Dheeraj has mentioned. So what would be the legal implication, just for practical?
Actually, let's finish the case. Let's finish the case.
That's exactly what I was going to come. Yeah, let's listen to the story first. And this
just to clear the timings, door to imaging time was 43 minutes and door to needle time was 65 minutes, as the patient has already came with the view of getting an MT to our center. Door to needle time was 65 minutes in this case.
Go on.
So again, we went ahead taking the patient for thrombectomy. Left CC angiogram showed occlusion of left ICA from origin. So we took a 8 French cerebase guiding and through the whisper wire coronary, we use whisper wire to cross the occlusion and it is dilated with 4 mm coronary balloon. Check angiogram shows patent osteoproximal ICA but occlusion of rest of the ICA. Suction aspiration using React 71 yielded nothing. However, the cerebase, which was also connected to the suction, giving a wedge effect, yielded a long length of clot.
Whoa. I mean, that wouldn't have gone at tenecteplase. Oh.
Check angiogram showed normal filling of left ACA and MCA. 15 minutes post-procedure, there was a recoiling of dilated left osteoproximal ICA. So what would everyone choose? These are the options or any other option?
No, we have to tell. Okay.
Then-
No, we need that. Just one sec. Please go back. We want to vote. How many of you would stent the carotid? Rest of you want to leave it to occlude? I mean, how many of you will stent the carotid?
If it has re-stenosed
It is
after
occluded.
the plasty, then you have no choice but to do
choice,
it.
right? Now, would you like to give would you like to give tyrofuse before you stent it?
If the patient has not received TPA, yes.
That is why we don't like you to give TPA. No? Because when we have occlusion starting to the origin, we know in the vast majority is a stenosis. Another place we never give TPAs, if we see multiple lacuna infarcts in the territory, we have realized there's an underlying ICAD. And we will end up again give tyrofuse at the end of the procedure. Other than that, if it's a blooming clot, we are not against it. But here we gave tyrofuse. Go ahead.
So then we went ahead with giving tyrofuse bolus and started on infusion, and carotid wall stent 9 into 30 mm deployed across the carotid stenosis.
Now look at this.
As a format, we do a post-procedure CT for every patient after thrombectomy, and this was the image. We were not sure certain this is a reperfusion hemorrhage or contrast staining, so we did an MR. And MRI showed this kind of pattern, cortical laminar necrosis kind of, which is rare. We have never seen reperfusion hemorrhage like this. So for safety purpose, we stopped the tyrofuse infusion, and we thought we'll repeat a CT after 2.5 hours to see if the hemorrhage, if it is hemorrhage, it will progress. So we did a 2.5 hours later CT, and there was no change. The CT was same. So again, we were not sure, is it just a staining hemorrhage?
Okay, at this point, we just stop again. How many of you think this is a reperfusion hemorrhage? Raise your hands. So we all thought exactly like you. No extent, no change, looks like contrast staining. We restarted tyrofuse. Okay.
And we actually loaded with 300 mg aspirin and clopidogrel just to be safe, and we did it. After 6 hours, we do a repeat CT. There was a large reperfusion hemorrhage, midline shift
Just
and
blew on the
herniation,
face,
and patient did not make it through.
No, but the whole thing is not bleed. This is different.
Yeah.
So why do you think the reperfusion hemorrhage happened?
I think it's part of statistics, you know.
So now let me re-question back. Since you said that we don't use tirofiban, if your TP had given, you didn't use TPA, still you had a bleed.
Still have it. But if we had it, they would have blamed us, you know.
Yeah, but on the other hand, if we had used a tenecteplase or TPA, the chance would have been patient would have been partially recanalized. And that's where I go back to reminding everybody about the Hermes collaboration. Hermes collaboration came in after the Big Five, and that clearly told us every minute you lose, the outcome gets worse. And we've been harping onto that. And you had a door to needle time of 60 minutes, you said?
65 minutes.
65, door to groin puncture.
You see the CT.
So that time is vital, and that's the reason we err towards thrombolysis. I wish we could reach the era where either the patient who comes through the door to through the mobile unit, and we've been talking of that direct to suite, angio suite. Till the time we don't reach it out, I think thrombolysis would be needed, and even in this case.
So Dr. Dheeraj, in this case, the problem is not thrombolysis. The problem is the patient has got underlying carotid stenosis.
I agree.
Whether we thrombolize or we did not thrombolize, we pre-dilated with a 4 mm balloon. The elastic recoil over there would have taken place. I would have still had to stent, I would have still had to use. See, the thing is, every institution can have its own policies. I believe one thing, you can't have a buckshot standard policy look at it, if the volume of thrombosis is high, if you really think it's not going to make a difference, why add another drug which has a problem?
Sure.
Here it's none of those. I'll tell you where the problem was. Let us complete this picture just to let you know where we made the mistake. I feel the mistake we made was not at this point. Can you just show the slide because we're going on time? We'll come back to the discussion again. Okay, so we had a bleed, messed it up. There was nothing much we could do seriously. You know, that reperfusion bleeds are disasters, you know. So just go ahead because we have less time.
That's all, sir. After the patient, yeah.
Now see, this is where we missed. Keep going. Actually, there is flow across the ACOM. We should have actually tried to see how good this was. Maybe if that flow was adequate, we should have probably been allowed the ICA to occlude. Maybe it would have just, I know mentally it's a big thing, but that's one thought we sometimes wonder. If there is a good ACOM, good filling, the T has been removed, do we still have to go around and fix the carotid at that point, you know?
Our patient is exactly the opposite. No. So there was very good cross flow.
So that's where the controversy
and
is.
And patient came here with a fresh stroke.
Yeah, so our thing was, there was ACOM, and see, who likes to see a vessel you open shut down again? There is a mental issue there, you know.
You're faced with a dilemma there.
So,
great.
Yeah, thank you.
Thank you.
Wonderful.
Okay, thank you.
Thank you.
So we tend to use, by the way, we use a lot of C-guard in elective carotids, but in stroke we always use
Bombay,
the wall stent, because somehow we found it the least thrombogenic among the stents for the carotid. Maybe some other people have other experiences. We felt terrible after that big volume of clot and feeling so good about it. Next couple of, for the ICA.
The whole ICA.
Actually,
no, but there was stenosis, so
this is from the carotid. But we realized that those the long sheets do a good job. Yes, the combination of both.
Coming?
The
Excess flow.
reperfusion on a very lowly purpose brain.
Dheeraj, I would like to ask you, I mean, the thrombolytic that we use has a very short half-life, right?
I didn't go to the details of that. In fact, I would have
exactly. We need to look into it. I mean, not giving antiplatelets because you've given a thrombolytic, it's more of a mental block.
Yeah, so I was about to come to that, but since we were not discussing
because thrombolytic has a very short half-life. By the time we take the patient to the cath lab, the thrombolytic effect from the system is gone.
Yes, so that I was about to come to that. That's actually technically and pharmacologically, you're totally correct. TNK has a slightly longer half-life. So TPA has a half-life of 45 minutes.
We also don't like it.
So by the time you are actually in the angio suite, the effect is almost half to 1/4 or whatever. And in fact, a lot of interventionists do use antiplatelet infusions post bridging, and they would possibly.
Can you able to protect the Mumbai case, please? So, Devashish?
Actually, मेरे phone पे है, if you want to do it.
We do the next bit still then? You're able to. Yeah, Devashish and Riti. Right. So get her on, please. Yeah.
Good afternoon, all. My case is whether bridging should be done or direct NT. This is the patient details. 46-year male and sudden onset left-sided upper limb, lower limb weakness for 3 hours, slurring of speech and deviation of mouth to the right side since 3 hours. The past is diabetes for 7 years, hypertension for 5 years, episode of TIA in form of left-sided weakness in October 1 year back, and pre-morbid MRS is 0. Now the vitals is BP is 150/102, pulse is 116, respiratory rate is 18, SpO2 is normal, RBS is 311, and GCS is full, and NIHS is 12/42. Now this is the MRI image. There is some subtle changes in the right side, subtle hyperintensity in the right basal ganglia and the cortical areas as compared to the left side, and also similar DWI changes and ADC changes. Now this is the flare and DWI. There is no changes in the flare. Then this is the SWAN images showing clot at the origin of right MCA. Along with that, angio showing complete occlusion of the MCA, right MCA. This is the acute right MCA territory, in fact, with right MCA complete occlusion. Now, management plan, whether IV thrombolysis alone or breathing or direct mechanical thrombectomy.
Yeah, long time they went, man.
Then this is the timeline, 10 a.m. onset, and the breathing is done with TNK 13 milligram at 2:15 and shifted to cath lab. Now this is the right IC angiogram AP view. We showed there is a complete opening of the right MCA, but there is still tight stenosis in the right SCA. Along with that, some portion of the right MCA. This is the lateral view, same. This is the left angiogram. There is no filling of the SCA from the left ICA angiogram and the retrograde filling of the SCA from the MCA through pial collaterals. And the left ICA angiogram is as before, and vertebral artery is AP view, that is some stenosis in the basilar artery, and right fetal pecum. Now the left angiogram, same view, that is some basilar stenosis. Now interpretation is no acute thrombotic occlusion on DSA. In right MCA terminal ICA, near complete occlusion of right ACA A1, moderate occlusion of the terminal ICA and right MCA. Left A1 is hypoplastic, A2 is formed retrogradely by pial collateral, V3 V4 segment atherosclerotic changes, and right VA is hypoplastic, right pecum is dominant. Now this is the post-procedure expert CT. It is not clearly visible. This is the post-IVT status, DSA. There is no acute thrombotic occlusion, so we abandoned the procedure and no reperfusion hematoma is seen. Now the discussion is, after 3 months the patient has not improved, but there is on DSA, there is complete opening of the right MCA.
Okay, so you meant that after the thrombolysis, everything recanalized, and the patient didn't do well. That's what we're trying to look into? Sir? You said the patient's outcome was not as good. What was the MRS at 3 months?
3 months is MRS is 3.
No, what are your questions?
So what I'll refer to here is MRS 3 is not bad. He's independent. He's walking. MRS 3 means you're walking independently, maybe with a stick. Yeah, some help, but walking is possible. Independence. So it's a measure of independence. It's not 2 is okay. Let's not go into details, but clearly we also have data to suggest that patients who recanalize, you remember Rahan Saber's paper back in 2004, recanalization is equal to good outcome. Nothing else. It's only recanalization. So if you look at 1 year down the line, this patient would do way better had the recanalization not happened. And like we know, rehab keeps working, plasticity keeps happening. So all that needs to be done is a very good rehab, and he's going to be MRS 2-1 in 1 year. I can assure you of that.
But what are your questions? Was that your
question?
That's
a good, very good case.
Whether we should...
Let's see. What's the question, beta?
Question is that whether the tight stenosis in ACA should be treated, because subsequently he developed the ACA infarct.
What I want is,
can I just see the pictures? I mean, this is we have to imagine a situation.
Yeah, so that is what the question was.
No, where is the problem here?
Where is this tight stenosis? Tight stenosis in the origin of the ACA, right ACA.
A1.
No, you're talking at the origin of the A1. How is the filling from the opposite side? If it's not possible. With that critical stenosis, if this fellow has been walking around till he came a few hours back, his collateral has to be good. I don't think you took the injection from the opposite side. I mean,
ACA would have led on to more like weakness. And you in fact, we see this.
Do you have an opposite injection?
Just show the entire angiogram.
Because I can see a negative jet in that ACA.
He had very good collaterals.
He's got just...
So, in fact, he would not have been MRS 3 had the ACA been totally gone off.
Vertebral injection also.
Where was...
Vertebral injection. Next.
And what did the MRI show? Where was the infarct? Can you show us the MRI infarction?
See, anyway, nobody dies of a A1 infarct.
This is the MCA territory infarct.
No, post. This is the acute one, right? MCA. So, ACA is spared.
ACA is spared.
ACA is spared. It's a very small infarct left. So
that's
don't
what
worry.
I said. There has to be a supply from somewhere.
Yes.
And honestly, even if there was no supply, I don't see anybody dying because of an AC infarct, and I will not be too bothered. He will get a hypertonic limb and he will finally walk,
True.
I mean, see, our aim in life is not great angio pictures, right? We want to get a guy to live and walk. Dead and a good angio doesn't make sense.
True. So, and MCA would lead on to upper limb. In fact, this paradox is so visible. If you see an AC infarct, it's very surprising. Their hands are working, and that surprises you. Their leg is not working. So in this case, likely the AC is completely fine. If you are MRS3, that means he's walking by 3 months.
She's sharing the screen. Thank you.
So just carry on with the rehab, and you will.
Actually, this is actually a study that strongly favors what Dr. Dheeraj says. It worked.
It works in quite a few patients, but if we look at...
It's also the etiology of the lesion. If it's
a cardiomyopathy, it could be cardiomyopathy.
It will work.
Both sides are there. The long clot which you have showed
will not work.
Yeah.
A small one, if it's RBC, will work.
So the fibrin-rich ones which come from the heart, they respond very well to the thrombolytic agent.
Because you have to open this one. So she's coming. Technical issue.
So what happened now?
Sir's case.
He says he's got the case with him on the phone.
Sorry. Thank you.
Sorry. So this patient which we were trying to present, Riddhi, if she can get on, was somebody who came with an acute stroke and there was very good cross flow. There was a proximal stenosis, severe stenosis. And we said clinically the patient is well, we just had that string of pearls suggestive of hemodynamic stroke. So we said we'll wait. 3 days later the patient developed a hemiplegia. And then we had no choice but to go in and... so actually when we did our fresh MRI, the PC was very big from that side, the stenosed or occluded side. So there was a small infarct in the thalamus and in the MCA. So then, because the patient worsened, we went ahead and did a thrombectomy. Patient improved again, but the question was, when there was very good cross flow, should we have intervened? There was very good cross flow from the ACOM, there was very good cross flow from the PCOM. So normally in such situations, most of us, because the intracranial ICA is also opacifying up to the ophthalmic, most of us would say don't do anything. Because we may, in fact, there are no emboli distally. When we are doing the thrombectomy, we may dislodge and lead to new emboli, going into new territory. So this is one of those, so we just wanted to show that.
Yes, sir. We also look at what the hemodynamic parameters are at that point, the blood pressures and other factors. And if blood pressure drop can precipitate, then we have to be extremely cautious.
All that was ensured, patient was still in the hospital.
Because most of the time we see these patients drop down like in the middle of the night when the blood pressures drop in the ICU. So we need to look at the hemodynamic parameters at the time when we're making the decision.
Yeah.
If my all respected coaches say that we can close the session. Yeah. Thank you. Thank you, everyone. Thank you very much. Can we have a group photograph?
Some of us are still on the stage. I am still here.
Yeah, it's after the lunch, but sir.
Oh, okay. I thought I was not getting.
Hold on. He wants to take a picture.
He wants a picture.
Yeah.
Yeah.
Thank you.